Today's TB Day commemoration is basically to remind us all that there is a disease which is looming large, which is responsible for the highest mortality due to any infectious diseases. And the efforts behind TB elimination have gone on for decades altogether, but we keep learning a lot of new things every time. The path is not easy. It needs a lot of commitment, lot of initiatives from all corners. The Ministry of Health is also making a lot of effort, and in fact, the National TB Elimination Program in India has made major strides over the past few years. We will have some members from the NTP also join us and share with us the progress. And we are honored to have with us today who's who in the field of tuberculosis. They have kindly obliged to spare their time for some of my colleagues. It is very late in the night. Some of them from overseas will be speaking early morning tomorrow for them. So, this only shows the kind of commitment each one of us promises to the elimination of TB. But every drop is going to actually help us move closer to our target of TB elimination. So I would request Dr. Tamanna to kindly introduce our first speaker, Dr. Puneet Dewan, who has been esteemed colleague for several years. He's worked in the India National TB program, and he's currently with the Gates Foundation, leading so many new things that he will share himself. Dr. Tamanna, please.
Thank you, ma'am. It's my privilege to introduce our esteemed speaker, Dr. Puneet Dewan. He's a senior program officer, TB Delivery, Gates Foundation. His area of interest includes global tuberculosis control, public health program design and evaluation, diagnostics and health technology innovation, technology integration, and implementation research. He has authored over 100 publications. His work focuses on developing innovative diagnostics and delivery modules to improve access and quality of TB care in high burden settings. He has also contributed to the design and implementation of large scale TB programs. Today, he will be speaking on transforming TB screening. I invite Sir to share his valuable insights on the same.
Thank you, moderators. I think I'm unable to share my slides yet. So there's a setting.
We'll look into it. Just give us a minute, please. बेटा क्या हो रहा है? Allow sharing, right?
There's something.
नहीं ठीक है तो वो लोग बोलेंगे.
Tell me if it's visible.
Sorry. Yes, we can see it. Thank you, Dr. Puneet. Please.
Oh, okay. Thanks very much. Thanks very much, Dr. G. Colleagues, appreciate the honor to come and speak to you briefly this evening for me and morning for you. And for those of you brave enough to show up early in the morning, in the time, I appreciate you doubly. I was going to do this talk on transforming TB screening, but then I woke up this morning and read a editorial from the minister and realized it pretty much done my job for me, which was to recognize the importance of TB screening and to a large extent make the case and set the bar for what India is going to do and how it's going to do it. So my job has been made much easier by the marching orders by the health minister. However, I'll share with you some of the science behind why we think it's important and perhaps some ways forward to address some of the challenges to actually achieve the scale required to have impact. First, I wanted to change, yes. Briefly touch on why we're failing in the case for screening, which I won't spend too much time on. Again, I think just read the minister's editorial and that'll cover it far more succinctly than I could. deconstructing myths around screening, which I think still are persistent and pervasive, and discuss what I would call the required transitions to make it scalable. And and if we have time, we'll touch on some unknowns. Global TB control is I like to call it running to stand still. There are increases in global case notification, which is good, and significant declines in TB mortality, which is great. But generally speaking, you've got a less than 20% reduction in incidence since 2015. So we're almost to the 2020 targets by 2026. Generally speaking, TB control measures haven't been as effective at halting transmission, and the why of that remains a little bit uncertain. And I'll highlight India in the lower right, where notifications have continued to increase, which is nice to see, but the estimated incidence behind them appears unaffected. Sometimes I think we over-index on incidence and we don't talk enough about prevalence. At the end of the day, for every person who's notified of the case, there are 2 to 3 prevalent TB cases. Case finding and notification, generally speaking, would be inadequate because that's who's out there available to capture at any given moment, not incidence. And it's especially notable among men. This figure from the WHO Global TB Report highlights the prevalence to notification ratio, shown there on the bottom axis, across a number of countries. India is sitting in the middle there, but also separating it out for men and women. The prevalence of TB among men is higher. Accordingly, notification is sometimes moderately higher. And accordingly, there's more missing TB among men, especially. So the reservoir of prevalent infectious TB, which is detected late or not at all, continues to drive transmission and also future incidents. So perhaps our inability to really knock down prevalence has perhaps contributed to our persistent problem. There is historical evidence behind community-wide systematic screening. And this is just one small example from Czechoslovakia in the old days, from Poland, famous example, which, this is repeated in a number of times across the Netherlands, et cetera, where you have post-war Europe and Asia, which had rapid reductions and gradual reductions in TB. And over time, they were mainly doing X-ray screening, but the low yield of X-ray led to ACF falling out of favor. And at the time, the DOT strategy was being developed to prioritize symptom screening. So somewhere along the way, we forgot that symptom agnostic screening worked. Perhaps we remembered, but just weren't willing to pay for large-scale screening among the populations in the global south. There is some surprisingly thin evidence from the modern era behind community-wide systematic screening, and recommendations from WHO and others are conditional and weak because they're just not well evidenced, and the investment case isn't well established. But generally speaking, there are some countries I would call phenotypes. There are some countries which are all in on TB screening. Philippines is really notable for moving forward. Indonesia is jumping in with both feet this year through a health screening program in their primary healthcare facilities. Others are called dabbling in screenings, such as Pakistan or Bangladesh, Nigeria, and the light touch and many others. But there are a number of people who tried to study this over time, over the past 15 years or so. And generally speaking, when you do systematic screening in a cluster randomized trial mode, you can see increases in case notification. And that's clear. When you gate them by symptom screening, they did not affect the ratio of prevalence in the intervention areas versus the control areas, and whatever way you chose to compare it, whether it's before, after, or intervention control, or whatever you did, it didn't make a difference. And generally speaking, that suggests that global TB programs are using mostly likely ineffective ACF efforts, which are using, to some extent or a large extent, outdated tools, which are symptoms or testing by smear microscopy with varying degrees of enthusiasm and coverage. I will note the bottom one, which is the study which was a departure from this experience, was the single study from Vietnam a few years ago, which included door-to-door and annual high coverage of most. They were able to get a symptom from about half of individuals in their intervention area with no symptom screen, and they just used an expert for all. And they used a pool test to reduce costs, and they were able to reduce prevalence over 3 rounds of screening by 45% in the intervention areas relative to control areas, as well as show corresponding decreases in ARTI among children, the tuberculosis infection rate among children. So it's promising, but a single study in time. Modeling around this stuff has shown that one thing may not do it. But generally speaking, while you can improve your program that you have, and you need to improve the quality of care and improve the coverage of treatment, ultimately the reduction of incident cases is going to be driven by things that are going to avert early transmission. And that's going to be either early screening and detection, especially of asymptomatic disease, or vaccination if one comes along. And some of these models in different countries and different places kind of show the same thing. And you have to kind of blow up the line to look for minor improvements in doing business better as you have it to show impact on incidence. But you start to only see significant reductions when you deploy these larger measures of early detection and treatment. Cost effectiveness is limited around this, but it's generally speaking, it's going to be expensive to do more on this domain, especially on a cost per case basis, if that's your metric, right? So and it's going to get more expensive over time on a cost per case basis, right? And then that's very clear. And there's plenty of simulations around this, as well as studies looking to show that it's not cheap to do this kind of job. But let's talk about why that may not matter. And so I'm going to use a few slides from my colleague in Vietnam, Tuan Nguyen, deconstructing some myths around screening. So one myth that's been stated is that targeted ACF is sufficient to really address things. And targeted ACF can find more cases. Community prevalence in targeted screening has never been shown to be able to successfully do that. Because most people, although people have high-risk groups have elevated risks of TB, most people with TB are not from an identified high-risk group and are not accessible to TB programs who are taking targeted-based approaches in general. And really, targeted is not, I'm talking about individually targeted. Prioritized might be a different approach, where you can find more cases earlier. But generally speaking, population-wide ACF is going to detect the vast majority of infectious cases, because the reality is this TB is really easy to spread. It's kind of everywhere. It'd be nice if it were easy to pick off with high-risk groups, but we don't have that luxury. Second, it's just not feasible. It's like too heavy to do, and we could get into the logistics and the money and the everything, but let's just start with the simple fact that it was already been done. This is not new. It's been done before we had drugs, and you did population-wide screening, whether it was recently, and the example I cited from Vietnam, or what's been done across the West and post-war Asia for 50 years using old technology. It was a matter of increasing willingness to pay and mobilization. So this is not new. But maybe it's unaffordable. And sure, it costs money. And this is an example of some models thrown together which show that, roughly speaking, it'll probably, if you were to do an X-ray based approach and screen 20% of the population per year, it would cost you $1 billion US, roughly speaking. But how much do you save when you NTB? If you push your horizon forward, estimates about the economic impact of TB in the country are like $120 billion over the next 20 years. So it's a bit of like, well, it's a bit of saying that yes, it's going to cost more money, but what are you saving when you actually don't just find cases and do business as usual, but are actually averting incidents and preventing future disease and the health and economic consequences and the human consequences subsequent to that. So if you simply extend your horizon of time, it actually ends up being cost saving and has a strong return on investment. But if I screen everyone and I find all these cases, I'm going to overwhelm the program. And I guess it's going to be more work. There's no question about it. But who's that work for? Patients ultimately have the right to diagnosis and treatment, and ultimately, whether it's been HIV programs or TB programs, we've scaled up to meet the demand. India increased its case notification from 1.5 million for a decade previously to almost 2.5 million. And they managed to input 1 million cases into the system to support their care and support for it. It wasn't a problem. It could easily handle more, or would work. But generally speaking, it's not going to be easy. You do find some. This figure from Indonesia shows, they had lower rates of initiating treatment amongst people detected in the community who are asymptomatic and were bacteriologically negative. Had lower burden disease. They weren't convinced. And some of them didn't start treatment, and some of them didn't finish. So it's not going to be easy, but it will be. Generally speaking, it is doable.
Okay.
If you don't mind muting, that would be awesome. Thank you. Number four, the same thing. Programs, you need to treat more people with TB if you're going to eliminate TB, and it is possible to have high success rates and treatment success among community screening programs. Maybe shorter regimens will help us in the future, and certainly we never said anything about HIV, patients infected with HIV, saying, no, there's too many people, we can't treat them. No, you found the will and the way, and we did it, and it's possible with TB. People are also concerned, well, if you do community screening, you're going to find all these false positives, and you're going to overwhelm true positives, and you're going to waste a lot of money and create a lot of problem by treating all these false positives. Well, generally speaking, when you use molecular testing, especially with molecular confirmation, it really reduces false positives by a lot. And in fact, when you have, a lot of it depends on what you call a false positive. The first is that the calculated specificity of molecular tests in the screening population is upwards of 99%, so it's very specific. Second, that when you extend your reference standard to not just culture positive cross-sectionally, but anyone who not only has clinical TB and developed TB over the next 6 months, you end up with a ratio of false positives per true positive that falls well below 1. So generally speaking, it's probably about as good as regular case finding is today. And not only that, let's say you do overtreat some people. The Dolly ratio between missed TB and the secondary cases it generates versus the harms of unnecessary treatment favors screening and treatment by about 1,000 to 1 ratio. So yes, unnecessary TB treatment is something to be avoided where possible, especially at a reasonable scale. But you want to know what's worse than an overtreated TB case? Missed TB cases. And I think we apply this lens of being erring on the side of caution to many diseases of public health consequence, and personally, even without public health consequence, like overtreating, for example, cervical cancer lesions of moderate dysplasias. And let's just make sure you don't get cancer. With TB, I think we can probably err on the side of caution given the community consequences. Next, you'll find all these asymptomatic people, and they don't matter. Maybe they're not going to get sick, they're going to self-cure, or they're going to be infectious. But generally speaking, the clinical and public health consequences of asymptomatic TB are becoming clear. And I think that's not too much controversial in India anymore after the prevalence survey. So I'll skip over this data. Now let's talk about what it's going to take to actually do this at scale, because that's actually what I really wanted to get to in this discussion. I think I'm okay on time. Yeah. I outlined here 8 particular transitions I would stipulate are required to transform TB screening to where we are today to what we need to be to actually harvest the potential impact of TB screening. And I'll go through them one by one, so I won't make you read the slide. The first is we need to move from low sensitivity symptom screening to high sensitivity symptom agnostic screening, whether it be X-ray or a molecular test or some other test that can actually find most TB cases and not miss most of them. And I think the example I have here is the global prevalence surveys, where the great majority of TB, half of TB or more was below symptom thresholds. Contact studies showing that the majority of people, when they follow contacts forward, are asymptomatic on regular screening. And this is true from the Indian prevalence survey, which showed the same, which has been cited widely, which is that generally speaking, prevalent TB cases were asymptomatic 54% of the time. And that's interesting because that also only is among those who were either, they only tested those who were symptomatic or had an abnormal X-ray. Most people without an abnormal X-ray weren't tested, right? And we know from the previous data from the report cohort that a substantial proportion of those who were identified with culture-positive TB had normal X-rays. And that's kind of what I would like to call the dark matter of TB. We don't actually know when we do a standard prevalence survey how much TB, bacteriologically positive TB, that was sub-threshold on the radiographic screening that we just missed at that point in time. So there may be more out there in the dark matter of asymptomatic TB to be detected. The next transition that's required beyond moving from symptomatic to asymptomatic symptom agnostic screening is to go from low population coverage to high population coverage. And I'll just point to the figure on the bottom from a modeling study from Hanif Ismail from the London School, which shows that if which shows that as you increase the number of years of screening and you increase your population coverage, you
don't do a whole lot. You don't, in terms of the proportion of incidents, the darker you are, the more incidents you're averting. Okay. And you really have to get relatively high levels of cumulative or annual population coverage and or screen for a number of years to really drive down incidents at a 10-year horizon. And that just highlights the importance of population coverage. And the above figure is a model which showed the similar thing from India, which highlighted a cumulative 75% X-ray screen versus a 95% X-ray screen. There's just the point of the principle is that, you know, a little bit of, you know, coverage doesn't get you too far, but if you begin to actually achieve reasonable population coverage, you can cull prevalent TB from the population and start to avert incidents more rapidly. The next is we kind of have to move from centralized camps, which is the way it was done, to what I would call household and workplace-based screening. And this is simply because of relates to population coverage question, right? Ultimately, the centralized camp model requires enormous civic mobilization, oftentimes can capture the wrong people. And the same thing applies perhaps to healthcare facility screening. And the important thing I want to highlight in the bottom is that, you know, depending on who you capture in your screening effort, you might actually end up biasing for the people who you didn't need to screen as much. And this example just shows the simple distribution of prevalence among men and women, men on the right, women on the left. And if you screen the dotted line, you would, and let's say people who were available at home during working hours, and you might have more women than men captured as an example in a population that had a bias to workplace participation, then you would just miss most TB. Whereas if you were to get it down the middle, you would get a lot more. And it's just highlighting the importance of thinking about that issue when planning screening programs, especially on workplaces. So it's camps to decentralized screening. Next is a little bit of a kind of an important but a little bit tricky concept, which is we chase yield in screening sometimes. How much money did I have to spend to find this case? And if your goal is elimination of TB, that's going to get more and more expensive. So maybe that's the wrong metric. And rather, we should be looking, well, how can I screen the most number of people for the least amount of money? In other words, look at your dollar per person screen and take what you get because you're eliminating TB versus your dollar per case found, which will always begin to escalate. You track that only when you're deciding how to screen. Associated with reducing cost is to move from where we are today, which is repurposed diagnostics, right? We use our X-rays. They've been made a little better, but they're still X-rays, right? They generally speaking mostly reside in healthcare facilities, and we use our existing CBNATs and PCRs that we have, and we use those in screening populations for the purpose of confirmation. But how do we move to ultra low-cost screening tools, and why does that matter? The figure on the right shows a model from our colleagues in India and WHO who looked at the screening costs and what percent of dollies could you avert and how much money would it cost you to do that in terms of cumulatively $1 billion over this period of time. And let's say you did X-ray screening with molecular confirmation. So you avert a certain amount of cases. Let's say I want to avert a quarter of my dollies averted, right? And that would have cost me $5 billion. I can make that cheaper by sequentially improving my tools, improving the specificity of my screening tests, right? So it's fewer false positives to test. Reduce the cost per person screened. That gets you to the green line. Reduce the cost of my confirmatory testing. Do it all together, and now I'm only spending $3 billion to avert the same incidents that would have dollies that would have cost me $5 billion earlier. So as you began to move to ultra-low-cost screening tools, and then you began to improve their performance characteristics, you began to get from what sounds like a fantastically large number to something that's more manageable in the context of the willingness to spend in the country. I will highlight also that starting your screening in higher prevalence areas, as was in fact suggested by the health minister in his editorial, like peri-urban populations and settlements, will yield a very high amount of dollies averted because of the high prevalence of disease in those settings relative to the amount spent. And I'm excited just for fun to show you, since I'm from the Gates Foundation, I can't help but talk about new toys. I'm curious and optimistic about whether or not digital stethoscopes could be trained with AI models can be used as TB screening tools. That can perform roughly similarly to an X-ray, except with a couple $100s of hardware and something that can be decentralized in the hands of a healthcare worker. And there's some, I would call proof of principle among from early models, and we're investing with partners in India and around the world to try and collect data to improve those models and make data available for other innovators to improve them further so that we can actually potentially have lower cost initial screening tools. Now, if you find a lot of people to test, you still need low cost confirmatory testing of adequate capacity. You know, the last screening round, you had all these people detected and screened. From screening, you ended up getting microscopy because there wasn't enough molecular capacity available. So doing a lot of screening implies doing a lot of confirmatory testing. The diagnostics have to be in place. The next transition, and I have just two more after this, is to move from integrated from TB screening camps to what I would call integrated screening and health promotion. And the examples on my right are not hypothetical. They're actually two from Indonesia and Kenya, where in Indonesia they have systematic health screening and healthcare facilities that they're shooting for 20% of the adult and adolescent population per year starting next year. Including the integration of x-rays in all their primary healthcare facilities. But they don't just do TB screening. They do blood glucose, blood pressure, PAPs, you know, they do cervical cancer screening, blood pressure, cardiac, a couple simple anemia blood tests, and if you go to their desk, there's a pile of stuff there, and they sign up 30 people a day per healthcare facility and screen the population systematically. And the bottom left is an integrated lung screening tent, which is not just screening for TB, they're screening for asthma, COPD, occupational lung disease, psychosis, and a workplace area population, and they're testing them on the spot. So if you start to increase, the one way to make it cheaper for the TB program is the TB program doesn't have to pay for screening. The health system pays for screening because you're screening for everything. And the TB program just deals with the presumptives. So that's a nice way to make screening cheaper, is to stop paying for it, make the health system pay for it. So that's along the lines of that, we have to move from a program-driven to more of a civic and community campaign. And this is one area where I think India is very far along with the Prime Minister's initiative that I don't need to explain to any of you who are very well aware and trying to deliver across all ministries and levels of government to try and build a comprehensive response against TB. Lastly, when we look at how we're doing, you know, we stop chasing incidents and notifications and incidents and really start checking prevalence. And when you're screening a large proportion of the population per year, your screening results are to a large extent, with some adjustment, reflecting your prevalence. So you can monitor what your prevalence is doing by the results of your screening activity. And that's actually an important one, because I return to the fundamental problem that it's not incidents, it's the pool of people who are transmitting disease today, and that's what we need to empty out very rapidly, rather than just get them drip by drip. I'm going to stop there because I've run out of time, and I hope that's been stimulating and a good way to start your morning of an exciting lineup of talks today, which I will continue to stay and watch for as long as I can stay awake. Thank you very much for your attention.
So thank you so much, Dr. Puneet. Sorry for the technical glitch. Such a wonderful talk. I'm sure we have infectious disease fellows with us today. Echo. And it has been a learning experience even for me. So thank you so much. And if we can take a few questions, Dr. Puneet, there's one question. So in case the person asking the question, you can actually ask Dr. Puneet directly if you would like to come in. So the question this person is asking, I'm sorry, the name is hidden. It says, what is the IOC for diagnosis in infants and PL-HIV? So, Dr. Puneet को unmute कीजिए please.
Thank you. Can you hear me now?
बेटा ये unmute वाला खोल दो आप
I think
बटन
you
सब
can
परेशान
hear me. So it looks like I'm heard. So so the question, sorry, I didn't fully catch because I didn't hear the first part. What is the IOC? Or ICE, do they mean?
IOC
I
for
said-
IOC for diagnosis in infants and PLHIV.
I just wanted to make sure I understand what IOC stands for.
I myself am confused, hence I was calling the person asking the question to ask on his own in case he'd like to.
Maybe just put it in the chat. I'll be happy to answer
It
later.
is in the chat. It is in the YouTube chat.
Yes, ma'am.
So we have the program live in YouTube and Zoom, so we're getting questions on both. This
Okay.
was a question on YouTube.
Got it. I don't see. I'm on the Zoom call, so I don't see.
Yeah,
you.
I know.
So I'll be happy to answer subsequently. I don't want to hold anyone else up, but my apologies for.
No, of course. Thank you so much, and I think we'll ask him to elaborate the question, and we'll share it with you. You could answer over an email or something. But we are immensely thankful, and especially I did not really, anticipate that there'll be so many angles to how to deal with the screening question, and that is the reason we wanted you as the first speaker, the star speaker, yeah, because it's the screening which is the first step towards diagnosis and treatment. Unless we are bringing in all those who are suffering with the disease, unless we are looking at the subclinical TB, and you talked about the risk groups and the feasibility of actually going population wide, or just limit ourselves to risk groups, at least to begin with. That's what the country is doing, India is doing for now. And you actually brought in so many different aspects of how this could help us, and how world over different countries have used screening application finding as one of the major tools to bring down the disease burden. And so thank you again, Dr. Puneet, and we'll share any questions that we receive for you over email, and you can kindly address them at your convenience. Thanks again. Bye-bye. We'll move to the next speaker.
It is a pleasure to introduce our distinguished speaker. It is a pleasure to introduce our distinguished speaker, Dr. Kiran Bala, Additional Professor, Tuberculosis Laboratory in the Department of Microbiology, All India Institute of Medical Sciences, New Delhi. Her areas of interest include diagnosis of tuberculosis, drug-resistant tuberculosis, newer diagnostics, and airborne infection control. Dr. Kiran Bala brings over 10 years of extensive experience in field of tuberculosis with significant contribution to drug-resistant TB, advanced molecular diagnostics, and infection control practices. With more than 50 research publications and multiple research projects, to her credit, her work has significantly contributed to strengthening TB diagnosis and surveillance. On this World TB Day, she will be speaking on newer diagnostics of tuberculosis. Good morning, all. So thank you for this talk, newer diagnostics for tuberculosis. As we are dealing with so much high burden of the tuberculosis and country and worldwide, so what are the available diagnostics since the years and centuries? In 1882, the light microscope has come, which has given the scope for the AFP sensitivity, and which the 10,000 decilli per CFU per ml is required. Turnaround time is around 45 minutes, along with the processing of the sample and staining. So the sensitivity is less. In 1992, just a brief, the solid culture, the LG culture has come. In 2007, we have the automated liquid culture. In 2008, we have line probe assay. In 2009, LED microscope has come, which has given for the fluorescent microscopy. In 2010, we have expert MTB RIF, which has given us the molecular platform for diagnosing the rifampicin along with the diagnosis of the Mycobacterium tuberculosis. In 2017, we have the Gene Expert Ultra. Can we do better out of that? From 2007, we have Expert Ultra, TrueNat, TrueNat Lab from the Mall Bio, And we have the Omni platform from the CAFED. We have the sequence midget culture for the balaquilin and delaminide also coming in 2019. We have expert XTR also, which is basically for the second line injectables, but after that the treatment part has changed and it is not that useful, but it is able to give us for the fluoroquinolones and isoniazid and also few injectables which can be added to the treatment part. So what are the non-sputum based? WHO has given the guidelines for the some point of care test for the tuberculosis, non-sputum based test for the diagnosis or triage. So urinary LAM, layer LAM has been recommended for HIV positive patient. We'll discuss it a little bit. Then for the expert the pediatric for the pediatric tuberculosis, disposable squeeze bottle for stool processing prior to the expert has also came up. We have the blood host markers also, depending on the transcriptomics markers, miRNAs, and then incipient blood test and breath test, and also the skin patches, which is known as the e-nose to identify it. So these are the available diagnostic for the tuberculosis. ZL staining, gene expert ultra. I'll give a brief about it, and then we'll go for then what are the diagnostic available for us. LAM, line probe assay, LAM assay, midget culture, and SciTB, which is the newer one. The program has integrated it for the TB infection. Acid pass staining, as it has a limit of detection from 5,000 to 10,000 bacilli per ml. No resistance is detected, cannot differentiate MTB and non-tubercular mycobacteria. For the gene expert, it is rapid molecular platform, closed system. Limit of detection is 131 CFU per ml. Simultaneously, we diagnose the rifampicin resistance detection, more specific for MTB. So it is a cartridge-based nucleic acid amplification test. It was launched in 2004. Development of platform was completed in 2009. FDA has approved the diagnostic since 2013, rolled out in India in 2014. Now we had come the Gene Expert Ultra. What is the difference between Gene Expert MTB RIF and Gene Expert Ultra? It is a hemi-nested real-time PCR using 5 molecular beacons. Gene Expert Ultra is a nested PCR which is using the 4 slopy molecular beacons. We have the single target of the RPOB gene for the Gene Expert MTB RIF and the 2 targets, insertion sequence 6110 and IS1081, to increase the specificity for MTB. Limit of detection is 131 CFU per ml, and for the Gene Expert Ultra it is 16 CFU per ml. It falsely shows the rifampicin resistance when MTB load is low, and the trace is the problem in Gene Expert Ultra, which shows the chances of the false positivity. Gene Expert MTB XTR, we are able to identify the isoniazid fluoroquinolones with the GAR-A, GAR-B, and ethionamide with the INHA promoter gene, and amikacin, kanamycin, and capreomycin. So after the MTB is positive, we can identify these resistance to these drugs. But the group A, group B, and the group C drugs has changed. The treatment part has changed. So it is a costly one. Also, the cartridge is also costly. But so we are not able to basically utilize in the program and do better with this Gene Expert MDR. So the INH has showing the sensitivity of the 94% and specificity of the 98% with the Gene Expert XTR. For the quinolones, 93% and specificity of the 98%. This is a meta-analysis. From the ethionamide, the sensitivity is 98% and specificity is 99.7%. For amikacin, sensitivity 86% and specificity 98.9%. What are the recommendations for repeat testing in case of the ultra? For the diagnosis of the pulmonary tuberculosis, if the ultra trace comes, then we have to review the history, clinical history. And for the children, if expert ultra is negative, probability is more than 5%, and probability of having the tuberculosis is less than 5%. So we have the TrueNut MTB RIF. This is the Indian-based indigenous assay, which has a chip-based real-time PCR test for quantitative detection and diagnosis of MTB in human pulmonary and extrapulmonary tuberculosis specimens and sequential rifampicin resistance. This is a mobile device run on the battery power up to the 10 hours. The target sequence is NRDJ, the gene which codes for the ribonucleoside diphosphatidylase large subunit. It is cost-effective in the Indian setting. It doesn't require AC settings and the high equipment. And we can use it. And after the COVID, we have so many at the peripheral areas, the Gene Expert and these TrueNut MTB machines are good in number, so it gives a good platform for molecular diagnosis of the rifampicin and for the MTB integrative diagnostic algorithm. For the recommendations for the use, I think the slide has changed something in that. It has 94.5% sensitivity and specificity. So what are the difference between TrueNut MTB and the GeneXpert? It is chip-based, battery-operated, and the GeneXpert requires an uninterrupted power supply and air conditioning. It requires another run to detect the rifampicin resistance and MTB detection and rifampicin resistant detection in the single run. Uses the melting probe analysis and it uses the real-time analysis. For the TrueNut MTB, the problem is of the intermediate results is quite high in the settings. There's a TrueNut Ultima is also which is coming up. This paper has come up in 2025 for the diagnostic accuracy of the TrueNut MTB Ultima on the sputum for pulmonary tuberculosis diagnosis in HIV endemic settings. They tried to compare, this company has tried to do it for the GeneXpert Ultra, but the results are not so good in that. Results are good as a point of care test. The Ultima MTB Plus and the Ultra has TB sensitivity of 90%, 84%, and 92%, and specificity of 85 for the MTB for the Ultima, 95% for the MTB Plus, and Ultra is a 95%. So specificity is less for the Ultima. So it has met the recommendations by the WHO for TB detection, but specificity, reagent load variation, and unsuccessful results were suboptimal in the study. They have then the Abbott NAT real-time MTB test and MTB ref INH. This is the real-time PCR with TB detection target, insertion sequence 6110 and PAP gene, and INH and ref resistance also been done. 8 dye probes for rifampicin testing and 4 dye probes for it. LOD for this diagnosis 17 CFU per ml and LOD for resistance testing 60 CFU per ml. So the pooled sensitivity and specificity, sensitivity is 93% and specificity is 97.7% for this Abbott real-time PCR. We have LAMP, that is a loop-mediated isothermal amplification. It is more objective, easily visualized. It requires this controlled environment, and as compared to the AFB staining, can easily be set up in the primary healthcare. And so the TB LAMP amplification may be used as a replacement test for the sputum smear microscopy for diagnosis of pulmonary TB in adults, and may be used as a follow-on test to smear microscopy in adults with signs and symptoms consistent with pulmonary TB, especially for the sputum smear negative specimen. So coming to the line probe assay and phenotypic DST, line probe assay has a faster turnaround time, 1 to 2 days, will miss the uncommon mutations, and LOD is 10,000 CFU per ml. So first line LPA based on the multiplex PCR and reverse hybridization, it was first approved in 2008 for detection of resistance to rifampicin and INH in sputum smear positive specimens and culture isolates. Excellent accuracy for rifampicin resistant detection, but for INH sensitivity it is limited. WHO still endorsing the same recommendation, manufactured by Hain version 1 and 2, and the program has also implemented it. And we also relying on the second line DSTs, second line resistance for the LPA. It doesn't eliminate the use of the culture-based DST. Rifampicin sputum samples, the sensitivities are ranging from 96.8% for the Hain version, and the specificity is 98.1. For isoniazid sputum specimen, 88.4 and 98.3. So Hain version 1 and Hain version 2 is giving the good sensitivity and specificity. For the rifampicin culture, we are getting the good one in 97.3 and 99.5. For isoniazid from the culture, 91.5 and 99.8. Second line LPA has changed from version 1 to version 2. The version 1 is having the ethambutol locus control, but the version 2 has the GAIR A, GAIR B, and RRS and EIS giving for the injectables for the amikacin and kanamycin, and it is giving for the fluoroquinolones resistance. It is giving the good sensitivity and specificities. For the second line, indirect testing, 76.5% to 99.1%. Now coming to the TB LAM antigen, it is the point of care test for the urine test. It is a lateral flow assay It is basically the improved sensitivity in HIV patients. There are many studies in HIV positive patients. Sensitivity is even higher in patients with low CD4 count, less than 200. Results are specific to the Allaire LAM test. Now, the Allaire has been changed to the Abbott LAM test, and there are other ones also, which the Fujifilm is also making it. So, LAM antigen is a lipopolysaccharide present in the mycobacterial cell wall. It is released from the metabolically active or degenerating bacterial cell, appears to be present only in people with active TB disease, greater glomerular permeability to allow the increased antigen level in urine. It is the first of the point of care test validated for urine sample. Specificity is good, that is 96%, but sensitivity is 35 to 40% associated with the increased mortality. There are many studies which have studied it in the ICU and with the increased mortality and disseminated TB and HIV with the more CD4 counts. So for the inpatient settings, WHO recommends for the assist in the diagnosis of the active TB in HIV positive adults, adolescents and children with signs and symptoms of pulmonary and extrapulmonary TB, with advanced HIV disease or who are seriously ill, irrespective of signs and symptoms, if CD4 count is less than 200 cells per cubic mm. In outpatient settings, WHO suggests for active TB in HIV positive adults, adolescents and children with signs and symptoms of pulmonary and extrapulmonary TB or who are seriously ill, or irrespective of signs and symptoms if CD4 count is less than 100 cells per cubic mm. So LAMS is giving the strong and moderate inpatient. For the conditional, it is giving the conditional and low suggestion. It has changed in the slides direction. So we have the sensitivity and the specificity in the CD4 count is less than 100 and more than 100 in 8 to 13, 1% and 31 to 61%. And so assist in the diagnosis. So recommendation for the LAM for the outpatient settings, which we have covered. So in fact, we had many studies from our lab also. And the urine samples we had tried in the HIV negative population. And this, the urine LAM has shown the sensitivity in the 60% and the good sensitivity, and the specificity is 83%. And PPV and post-predictive value and the negative predictive value is 92%. However, it is not good as a positive predictive value in the extrapulmonary TB. And when we compared it with the microbiologically referenced standards, so the LAM has given the sensitivity of 48% and specificity of the 84%. So for the basis of this, and we many studies has been done from the Urvashi ma'am has done many studies and the pediatric ones and the pleural fluid also, and from the CSF also and lymph node also. So let's coming to the TB infection test. It has been integrated in the program, and it is a replacement for the basically for the IGRAs, which are very costly. The TB is selectively detect the recombinant ESET6 and recombinant CFP10, which are MTB specific, eliminates the false positivity in the previously BCG vaccinated population. So this is the key advantage over the first generation TST, especially in the developing countries with the BCG vaccination program. So it has been enrolled. It is for the Montux test, the intradermally it has been given, and the 5 mm or more is the induration of 5 mm or more has been given for the positive individuals, and it is being tested for the contacts of the tuberculosis patients. Now coming to the PathoDetect, it has also been integrated into the program. It detects the rifampicin and INH. As incorporated, it has been made from the MyLab, and 32 tests can be simultaneously done on the indigenous molecular diagnostic. It detects the MTB complex and first-line drug resistant to rifampicin and isoniazid simultaneously as a one-step process. The analytical sensitivity or limit of detection for the test was found to be 25 CFU per ml for MTB detection and 200 CFU per ml for RIF-A, RIF-C, RIF-E gene and INH-A and CAT-G gene of confirmatory LOD at 95% confidence interval. It is a multiplex RT-PCR test, and the targets are specific primer and probe designed for the conserved region of the MTB, INH for INH-A promoter and CAT-G mutations, for RIF, RIF-A, RIF-C and RIF-E gene, And the delta CT has been used for identifying the mutations in that, and it is a real-time multiplex PCR. So this was the validation, the multicentric validation of PathoDetect has been done, and it has given this results. They had done it for the MTB detection only, not for the drug resistant genes. So the positive, the MTB positive by the measured culture was found, and the sensitivity is good, 98.1%, and specificity is 94.2%. It has given the good Cohen-Kappa agreement, almost perfect agreement with the gene expert, that is a 0.89. The another one, that is a Quanti plus MTB fast detection kit. It is developed by the Google Life Sciences. It is first in world indigenous open system RT-PCR kits and validated by ICMR. It is an open system real-time PCR based assay on the detection of the MTB complex DNA with 3 gene targets: insertion sequence 1081, MPT64, and insertion sequence 6110. In comparison to the gold standard liquid culture, sensitivity of the kit is 86% and specificity is 96%. It is low cost and have a potential to expand the outreach of the molecular testing, including more than 3,300 RT-PCR machines used during the COVID pandemic and many more. It has many kits for the MTB detection, for differentiation of MTB from a non-tuberculous mycobacteria, and for the it has a basically there is no, it is cold chain free friendly and for MTB testing, and it detects the MDR-TB rifampicin isoniazid detection. So this paper has been published in IGMR, and which they have done it for them only for the MTB detection. Extraction free protocol is there, fast turnaround time, results within 60 minutes. It's validated in clinical settings, compatible with the open system, and it is field ready options are there. So sensitivity was 85.9%, and in the smear negative it was 61. For the if the CT values are less than 38, then the sensitivity was 85.9, and for the smear negative it was 61.6%, and specificity is 96.7%. In smear positive it is 96.4 and 91.7%. They are also providing a compact open system RT-PCR device also designed for the real-time PCR detection for the point of care. It can be placed into the PHCs, and it has a capacity of the 16 sample altogether. There's ongoing research are going on the CRISPR assay, CRISPR-Cas 12A, and it is a kind of the gene editing. Sensitivity is 90%, specificity is 98%, turnaround time is 7 to 14 days. So detection of the MTB in lower sample input and detect multiple sites in MTB genome associated with the drug resistance and susceptibility. But Cas, there are certain disadvantages. The Cas protein has a lower sensitivity, and target selection is crucial, as long target selection near the PAM sequence is advantageous, but it is prone to the mutation, hence provide many false negative results. Multiplexing is another challenge for the CRISPR-Cas assay. We have the nanopore sequencing, Oxford nanopore technologies. These are being in the use, detection of the rifampicin resistance. Sensitivity is good, specificity is good, but the resolution should be improved. It can detect even a single base before the commercialization, and bioinformatics is also a problem with that. Whole genome sequencing, we have the many high-end sequencers, but it requires technical training. Clinical interpretation of NGS data is challenging. Now the transcriptomics, miRNA, PCR-based assay, they'll tell the disruption. Sorry. The differential expression of miRNA represent different stages of the pathogenesis on the immune system and the cytokines and immune pathways. They're able to differentiate between active TB and LTBI, and expression pattern of miRNA depending on the study design. And the Raman spectroscopy is also one of the options, which is the ongoing research. Research has been going on since the years. And Raman scattering doesn't require unnecessary sample preparation. Adoption of the Raman spectroscopy in a clinical lab is a challenge. So there is certain ongoing research is going on the nanomaterial for the TB diagnostic. Quantum dot, they have the different nanomaterial types. A quantum dot-based detection system, magnetic nanoparticle-based diagnosis, nanofabricated devices, biosensor-based nanodiagnosis. There are a few studies on that. It is going on, and nucleic acid hybridization nanodiagnosis. Thank you.
Thank you, Dr. Kiran, for the excellent talk. I'm sure it must be so many of the new things that you covered just now must be new to all our fellows and all our NT students as well. Uh, if there are any questions on the chat, we can take those first. And then from amongst the fellows who have joined here, we'll be happy to take questions.
Thank you, ma'am.
So no questions in the chat, neither on the YouTube nor on the Zoom. So we can take questions, if any, from the fellows who are present in the hall. So I guess you were too clear. They have no questions. But I must compliment the talk. Very beautifully covered all the aspects of the newer diagnostics, and the sensory specific details that she shared are from different studies. We still have, a long way to go. So, improvising diagnostics, of course, I think screening, Dr. Puneet covered so well that the concept of screening and options are very well covered. In diagnostics, Dr. Kiran has shared with you what is available in the field of diagnosis today and what may be available tomorrow. We are going to have two more talks on diagnosis a little later. We had to adjust the timing, because of choices of different speakers. So thank you again, Dr. Kiran. I'm sure if there are questions that come in later, we will share with you on email and you can answer them. I would like to briefly share with you a message from our Honorable Director, Director AIMS, Professor M. Srinivas, who wanted to welcome all the participants. So if we can play Sir's message, he was occupied, so could not be here in person.
Thank you, ma'am.
Dr. Nishant from the National TB Elimination Program, he also could not join in person because he's preparing for the So we'll have Dr. Tamanna talk briefly introduce Dr. Nishant. So Dr. Nishant would like to talk about the diagnostics under the program, how they have been scaled up over the past few years, what newer diagnostics the National TB program in India has been able to adopt, and what is the important messages. There are several firsts that the diagnostics under the National TB program have been able to do. By first, I mean globally, India has been the first country which has more than 10,000 NAT systems spread across the country. We have not only the gene expert, but we have an Indian indigenous technology, TrueNat. Dr. Kiran briefly talked about the mechanism or the principle behind it. So the program has been able to scale up the TrueNat, which was validated painstakingly by AIMS, NIRT, NITRD, and JALMA collaboration. Way back in 2018, the program adopted it. Today, we have close to 8,000 plus systems of TrueNat, which are in fact reaching as far as the CHCs and the PHCs. In addition, of course, we have the gene expert systems to the tune of 2,000. So in all, we have close to 11,000 NAT systems across the country, which give us point of care diagnosis, in the periphery. So much so that the medical mobile units, which can go village to village to conduct screening using X-rays. You saw beautiful pictures by Dr. Puneet showed wonderful pictures how screening is being done, and that is the state-of-art screening method. Now these vans are equipped with handheld X-rays. Another first in the country, our country is leading in that as well. We have close to 4,000 handheld X-rays today under the National TB program. These are available with the districts, with the blocks, and the blocks and the districts are organizing, if I may use the word, door-to-door screening. So the vulnerable population, as has been, the NTP has laid down the strategy. As again, Dr. Puneet introduced the National TB prevalence survey. published 22 by ICMR along with the Central TB Division, clearly showed the vulnerable risk groups which contribute about 80% of TB burden in the country. So what the National TB Program is now doing is identify these vulnerables, screen them well in advance to look for not only active TB, but also subclinical TB. So earlier on, we would wait for symptom screening. Now what we're doing is symptom agnostic screening. We're screening all the vulnerables, offering them the benefit of early identification, early diagnosis, and early treatment. So with this brief, I'd also briefly touch upon another first that the country has rolled out in the past 1 year is the equipping more than 43 labs across the country to do culture and DST to the newer bedaquiline and pretomanid, the antitubercular treatment, which are components of the BPAL-M, which was again rolled out in December 2024 across the country, and today we have close to 20,000 patients receiving BPAL-M. The training of these labs was facilitated by support from our esteemed institute, NIRT. I hope Dr. Srinath and Dr. Sivakumar are here with us. The credit goes to them for supporting this training. And today, India is the only country which is actually on the ground able to do DST for these newer drugs and actually benefit the patients. We also rolled out targeted NGS under the program in 5 centers of excellence of MDR-TB, so we can benefit the MDR-TB patients by knowing their drug susceptibility testing to all second-line drugs. Again, this was a collective effort. All our NRLs, all our IRLs, all our program staff have been part of this scale-up. Over to Dr. Nishant's presentation.
Good morning all. I will walk you through the strategies of TB Mukt Bharat Abhiyan and diagnostic advancement under NTP. First of all, I would like to thank the organizer, especially Dr. Urvashi Vising. She has been a true, I can say TB champion who worked day and night for almost 2 decades, more than 2 decades for the cause of TB and TB research. So thank you, ma'am. So just to give you a brief background, to accelerate the progress for TB elimination, the government launched a 100-day TB Mukt Bharat Abhiyan on 7 December. Whatever we've been doing since 2018 under the National Strategic Plan, I'll come to that a little later, but I'm just setting a context that what the new strategies which are being put and implemented in the last 1 year. And in that campaign, it was done in 347 high prioritized districts across the 33 states. And basic change was that we were screening the asymptomatic vulnerables. We identified the populations which are particularly vulnerable to developing TB. And based on the success achieved, the TB Mukt Bharat Abhiyan was expanded to all districts in 2025, and we've been doing that. The TB Mukt Bharat Abhiyan now is being again in this next year again on the occasion of World TB Day. Today we'll be launching the 100-day TB Mukt Bharat Abhiyan, which is more targeted, focused based on the learning and addressing the challenges which we did last year. So we are introducing more than 3,000 AI-enabled handheld X-rays with the indigenously developed AI tool for automated reading of X-ray images. If we look at the burden of disease, India has made, yes, we contribute 25% of the global burden, but we have made significant strides by successfully reducing our TB incidence rate by 21% and mortality among HIV negative patients by 25%, which is close to the double of the rest of the high burden countries, while pushing treatment coverage to an impressive 92%. Given the burden and a staggering 33% of MDR-TB burden, which means we have a long way to go still. Just to walk you through what we are doing, I'll come to diagnostics in a bit. Just to give you what we are doing under the TB Mukt Bharat Abhiyan, the main objectives are to find all the missing cases through proactively. Program has been doing active case findings since 2018, but every year it has given us some learnings and improve. Now we are going for upfront, proactive screening in the vulnerable populations, and anyone having abnormal chest X-ray, we are offering upfront that for these vulnerable populations. And this time we have identified 1.5 lakh villages and wards which are which have high burden, and will be targeting congregate settings and in these areas. To prevent and reduce TB deaths by implementing a personalized care of TB patients with different. Every patient has different. When it comes to the system, it comes with different level of the disease. Some come in very advanced stages. Some be too asymptomatic. We find early, but who come late. So we address. All the issues other than TB as well, like any other comorbid conditions, and these are supported by other intervention like nutrition intervention, management of comorbidities and follow-up monitoring, and doing the TB death audits and looking into the causes which can be mitigated by looking into the TB death audits. And we are also working on preventing TB cases by screening and providing TPT to household contacts, people living with HIV and other eligible high-risk group after ruling out active TB. The core of this whole effort is Jan Bhagidari. It's whole of you all are aware, you're all experts that it is a medico-social disease. The dimensions are beyond health sector alone. So whole of government approach for TB Mukt Bharat is being adopted, and by raising community awareness and reducing stigma and mainstreaming the TB. Also to identify and manage non-communicable diseases, especially diabetes, hypertension, anemia, undernutrition, and cancer among vulnerable population and TB patients, in order to enable early detection and appropriate treatment. In addition to the TB treatment, appropriate treatment to other health conditions as well. So what are our main strategies? Just I'll briefly talk about the TB Mukt Bharat Abhiyan will focus on, as I said earlier, that in relatively more vulnerable high-risk villages and wards, campaign will be implemented through a mixed approach of outreach camps. We call them Aishman, Arogya Shivir, and facility-based intensified services in the existing facilities where the patients are already coming, and providing the services for TB plus the non-communicable disease, any other comorbidity. And we have trained the states to implement the differentiated TB care by taking care of the comorbid conditions, BMI assessment, anemia, and any other health condition which has to be looked into. So if I say what is the geography which we are targeting, so all districts across the country, vulnerable TB villages and wards, screening of all individuals above 14 years of age, irrespective of vulnerability, in 1.5 lakh vulnerable villages, with X-ray, which have AI tool integrated into it, and also looking into the burden of child malnutrition in that area, occupation, use of clean fuel, and we have identified certain vulnerable groups. Just to give you an idea, individuals over 60 years of age, individuals with malnutrition, especially having BMI less than 18.5, diabetics, people living with HIV, smokers, alcoholics, person with past history of TB, and household contacts of the TB patients. Children under 14 years may be offered chest X-ray if condition, the clinical evaluation suggests that they need an X-ray. So even below 14 also as a need be. And children with known exposure to TB disease in last 2 years will also be assessed, children having severe undernutrition, children living with HIV and immunosuppressed due to other reasons, children living in congregate settings like residential schools, rehabilitation centers, slums, children in other high-risk population groups like urban settlements, and an important consideration while using X-ray in young children is that the X-ray exposure window should be restricted to the thorax and should not be large to include neck or lower abdomen to avoid radiation to thyroid or internal genitalia in growing children. This is for the active case. We're going in the asymptomatic vulnerables. For the health facilities, again we are intensifying the asking all the specialties, especially the OPDs, where the patients come to rule out TB in whatever conditions they present with, but to rule out TB in those areas. And in urban areas, the focus would be on slum clusters, jhuggi jhopadis, construction workers, homeless, beggars, street children, railway yards, coolies, gig workers, transport hubs, auto taxi drivers, sabji mandi, dairy farmers, abattoir workers, animal handlers, and households with close livestock contact and contact-specific local vulnerable population. To address the NCD undernutrition and anemia, those with diabetes, undernutrition, anemia, cancer, immunosuppressive condition represent biologically high-risk group for TB incidence or poor treatment outcome among listed vulnerable groups. While hypertension screening serves as an important, programmatic entry point, screening of population visiting Ayushman Arogya Shivir for diabetes, hypertension, undernutrition, anemia is included in this abhiyan, as they have greater risk, as I told earlier. And the routine service delivery in the health facilities will be further focused on, and these facilities starts with the sub-center level, that is Ayushman Arogya Mandirs, community health centers, hospitals, district level, sub-district level hospitals, medical colleges, and other primary healthcare services. Intensified screening at general OPD to ensure at least 5 to 10% of see that they are, when they present, if the clinician feels they should be offered a chest X-ray. And all symptomatics in general adult OPD will be offered upfront and ACT. And 100% attendees at specialized OPDs for people under care for HIV, diabetes will be subjected to the screening. And wherever functional X-ray, so these are being done in addition to the handheld X-ray which are in the field. So wherever functional X-ray facilities are not available, mobility arrangements will be made for the vulnerable individuals through a Nikshay Vahan, that's a van which will have not only X-ray but provision for blood sugar testing, hemoglobin, and body mass index, weight, BP, etc. And one thing which basically we've been making people aware about the 4 symptoms has been accepted to 10 symptoms now. So that is cough for more than 2 weeks or any duration, in fact. Fever, night sweat, hemoptysis, chest pain, shortness of breath, weight loss, loss of appetite, fatigue, lymph node, swelling, and any other pulmonary signs. And special strategy to reduce the TB mortality, non-communicable diseases such as diabetes, undernutrition, anemia, cancer. We are working with the NCD division so that the patients on medication, who've been diagnosed, the data is there with the states and districts through the CBAC form as well from the field at village level. So they will be made sure that in addition to the TB treatment, they get all the medicines for other comorbid conditions, because that will affect the outcome of TB and overall health. To strengthen the nutrition interventions, we have already made provisions since 2018, April 2018, for monetary support. Initially, it was 5,000 rupees per month, but in 2024, it was increased to 1,000 rupees per month per patient. And also to support making it mainstream and letting the community participate, The Nikshay Mitra initiative was expanded to cover household contacts of TB patient also. Anybody who wants to support any TB patient in the area can do so. Now coming to the algorithm for this, especially for the TB Mukt Bharat Abhiyan, of the algorithm which is made screening of vulnerable population during going out in the field. So screening of vulnerable individuals working in congregate setting, people under care for HIV, diabetes, hypertension, as I said earlier also in my slides, will be followed by the vans will be going in, shivers will be organized, that information will be there in the states and districts. So already micro planning has been done. So this will be done first, of all the asymptomatic vulnerables coming to these camps will be diagnosed by, will be screened by X-ray at these shivers, plus at the fixed facility. Mobile medical units under NHM will be used, so that plan has been made by the states and districts. So that is, in the field the van will go, in the fixed facility, if the van is not there at a, the state and districts will decide to take few patients, few presumptives in this group to the fixed facility, and they will be subjected to X-ray, and upfront NAT will be done for anybody found to have an X-ray abnormal, and it would be done. And we use other radiological tests, histopathology, and other appropriate tests as required for extrapulmonary diagnosis also. Drug resistance for all diagnosed TB patients for first line and second line drug as per the existing guidelines, and also testing for anemia, diabetes, and hypertension, and other parameters. And for prevention, will support initiation and completion of TB preventive therapy for eligible beneficiary after ruling out the active TB. This is what I was talking about, that, this is in a nutshell, it's a summary that this is how, after announcing, after making sure of the line list, doing the micro planning at the sub-center level, the ASHA and ANM and other field level workers will get these people to those camps as per the route plan given to them, and offered screening of with chest X-ray. In addition to chest X-ray, as I said earlier also, that they will be tested for blood sugar, hemoglobin, and BMI, weight, and blood pressure, etc. And then anybody found in this group, remember again I am emphasizing that this is the group which is asymptomatic but belonging to a vulnerable of the 8 categories which I said earlier. So they will be offered X-ray, and then anybody found abnormal will be subjected to NAT. So this will definitely, as we said, that we are trying to find everyone early, so that it will have a bearing on the incidence reduction as well. And all these interventions I have spoken earlier also. So now coming to the main topic of today's discussion is that what all infrastructure which we have under the NTP lab network. Over past 2 decades, India's TB diagnostic program has, progressively evolved from conventional smear microscopy to advanced molecular and genomic technologies. Starting with quality assurance for microscopy in 2005, the program introduced culture-based drug susceptibility testing, followed by rapid molecular diagnostics such as CBNAT, line probe assay, TrueNAT, for quicker diagnosis and appropriate diagnosis. And subsequent initiative focused on expanding the universal drug susceptibility testing implementation. And this is the structure which we have. It's a 3-tier structure. At the top is NRLs, geographically located 6 NRLs, then IRLs, culture DST labs, and you can appreciate the number of rapid molecular tests across the country has increased to close to 1,000 now, 9,800, and it's increasing. States are getting more and more. And also microscopy is largely to be used in as a follow-up. So this is the infrastructure, this is the diagnostic network here which we have. And TB, and the India's TB program is quite a forward-looking program, and over the past 2 decades, it progressively, evolved. As you can see, the timeline. This is the timeline which I said earlier. If in terms of infrastructure, you can appreciate all technologies like microscopy, CPNAT, TrueNAT, and now newer ones coming are increasing year on year, and the facilities are increasing year on year. So, and what this infrastructure has delivered, is the next slide. That is, you can appreciate that the rapid molecular test from 2017 to 25, how we have evolved. We had a quite a promising trend from 2017 onwards till 2019, but in 20 we all know that our infrastructure was pressed into COVID, and the laboratories, technicians were used there. But we quickly recovered, bounced back, and come back. And last year we did 2 crore NATs were offered in the country. Similarly, the sequential test has also increased. There's a gap, but we are working on this because and to ensure that the regular supplies are there. And this before this again, we have made sure that every for every lab, every state and district, we have enough consumable for all the technologies. So just a word that this you all are aware, and I think all speakers will also ask. I just would like to mention that WHO has approved, which includes TrueNAT, Abbott, BD, but the country currently, because of the use, the cost effectiveness, and have been the main approach has been to decentralize. So that's why, so that there is no delay in diagnosis. So we are following the principle of decentralization and working on some high throughput, platforms which are cost effective. LAMP and LAMP for diagnosis without detection of drug resistance. There are few other follow-on diagnostic tests for detection of drug resistance, which include expert XDR, and again for the cost effectiveness. And we currently are using 3 technologies, which are TrueNAT, CPNAT, and now recently introduced PathoDetect. That is one high throughput platform which we are using. But this is taking conscious decision so that it is the platform which we have complement to our strategy of decentralization, plus at the same time working on different NAT which complements the existing diagnostic lab network which we have. These are the methods which we these are the platform I told earlier also in the slide that initially we started with CPNAT from 2013 onward, expanded it, and then in by 2018 we had about 1200 odd CPNAT machine, which stands now is about 1800 CPNAT machines, plus we have close to 7,000 TrueNAT machines, and also introducing PathoDetect, and line probe assay is already there. About we have 100 laboratories which provide the service, and of course in the same numbers is the liquid culture facility available. So just to give you state-wise, so we have saturated the district and sub-district level already, and in some states it's almost at block level also we have, and further we are working on open RT-PCRs, which has been validated, and see that if this can be further decentralized. So this the data is till December 2021. There were close to 8,000 TNAT machine and about 1845 CPNN machines. So this is, I think, the largest network which is available in any country. Also, this GIS map, on graph illustrates, dense nationwide distribution of NAT facilities. You can appreciate the difference from 2021 to how fast we have, almost tripled from 21 to 25. And I mentioned earlier that last year we did, more than 2 crore tests. And this is, mind you, is by doing mostly the one cycle, 8-hour cycle, and we have got these many tests. And we're working with states, some of the states like Uttar Pradesh, Madhya Pradesh, Himachal, and certain other states are doubling the shifts. And what we have calculated that if every state doubles the shift, we have the capacity with this current rapid molecular infrastructure. We can do more than 5 crore tests a year. So this you all are aware, and I think my colleague Dr. Mattu will be talking about the treatment part also. But just to refer that this is our integrated diagnostic, treatment algorithm. So in patients aged more than 14 years or more, shorter regimen Beta-lactam has been introduced in November 2024. So unless there is a contraindication, this is the preferred treatment which is there. Since Beta-lactam and linezolid resistance levels in India are low, the NTG recommended Beta-lactam regimen can be initiated in all eligible MDR patients, irrespective of availability of baseline, and modification of the regimen may consider whenever DST results are available. So just to again reiterate, the samples with RR detected. The second sample is sent to CDST lab for LP and LCDST testing. Further baseline to be conducted for the drugs indicated. If resistance is not detected, second sample to be sent for FLLPA for H detection, and if H resistance is detected, then the second line LPA to be conducted. Further baseline LCDST to be performed for the drugs which are indicated. So, as you are, most of you are aware that presently we do not have any rapid molecular tests for newer drugs like BDQ, Pretamanid, and linezolid. We still have to rely on LCDST for these drugs till we have some newer rapid tests. So in 2025, we started under the leadership of Dr. Urvashi Singh. The capacity building of 42 laboratories was done in coordination with NIRT Chennai, thanks to all the help which NIRT Chennai provided, where laboratories were trained for DST to the newer drugs. And I'm happy to announce that 50%, about more than 24 laboratories have attained certification for performing DST on newer drug, and the rest would be completing very, very soon. Just a word, the TNGS, we all are aware, offers a high throughput culture independent approach. That delivers a comprehensive resistance profile in a significant shorter turnaround time. Making it simultaneously, we are also piloting it at 5 center of excellences with the support of ICMR to generate more data on mutation associated with newer drug and repurposed drugs, and design simplified and standardized workflow. And the SNRL, which in Chennai, is closely working with us, and so this just to inform you that this is the learnings from this will be seen that how we can incorporate in the programmatic conditions. Just a word about, I told you that for long the program was looking for an open RT-PCR kit. And the first one, which has been validated, is being tested under programmatic condition also. And currently we are working in about 6 districts in 3 states to see the operational feasibility exercise is being conducted, and within 2 months this will be started in about 501 co-located site where there is an open RT-PCR machine which is under NHM, and it is co-located with NAT as well. So we are working on this because currently this only detects TB. In the pipeline is also the resistance, but the program will very soon start this in about 500 co-located sites. And just a word about the tests in pipeline. The program division is working very closely with the ICMR to expand availability of rapid molecular diagnostic for TB and TB to enhance the detection under NTP. UNIM MTB card for detection of TB in sputum tongue swab is validated by ICMR. The validation is it will be taken up based on the recommendation of NTEG. We have discussed it, and very soon we will take a decision on this. There are a few other kits which are being validated by ICMR presently, like MolBio TrueMap for RIF INH and fluoroquinone, and the Huel QuantiPlus MDR fast detection kit. It will I will not go into details as of now, because I'm sure as per the agenda the other speakers will talk more about on this. So just to summarize, moving forward, the program envisions moving away from that is a wrong word to move away, but offering up from NAT as the primary tool to detect. Microscopy is very important. If rightly done, it is a very, we relied on it. But because the available NAT platform which we have gives us an advantage of getting the resistance to RIF that gives a quicker decision to the clinician to start the right treatment. So that's what we are doing. Screening of vulnerable population, as I said, I told you. That is why I spent so much time earlier. That what we were doing since 2018 onwards, when we implemented the NSP. Now we are going for actually screening the vulnerable population early. I mean, to address the subclinical subclinical TB in the country, so that if we do that will be a very, very critical step to reduce the incidence, finding early, because the experience has been most of the patients come very late. So this is to stop that these asymptomatic, which are still not come under the radar, should not develop full-blown disease and then come to the program. So that's what the program is working on. Of course, the training of CHOs, ASHAs on sample collection, strengthening and transporting mechanism to the nearest site. They've been trained. The materials have been given to them to with 7 red flags to refer the patient immediately who needs immediate care. And we are strengthening our IRL and CADC labs to improve the quality services and the turnaround time. So that's a continuous process that we have built this infrastructure, but now we are continuously working towards improving the lab services. So in the end, the most important thing is the core is detect early, and detect appropriately, so that right treatment can be started in the shortest possible time. And you all are aware that monitoring of all the time. Soon we'll have a lab, a dashboard also on Lamichhane. Other indicators are already provisional there that they are captured in Lamichhane. So thank you for the opportunity. And I'll end by saying that yes, we can end TB. TB harega, desh jeetega. Thank you so much.
Thanks for the wonderful talk, Dr. Nishant. And thus was the experience how the program is adopting the newer diagnostics. And the idea of sharing all this with you here is that the gears, possibly the program is moving in the fifth gear, adopting everything that is recommended by ICMR. That is one step that we take. A validation has to be first done. A feasibility study in the field has to prove that a particular diagnostic will do its bit. I would just like to summarize, in order to summarize what Dr. Nishant so beautifully put together. So the program was envisioning if we have drug sensitive, that is rifampicin sensitive TB, the treatment is well defined. What we would like to also know is if INH resistance is there in drug sensitive TB, for which Dr. Nishant in the end shared with you newer NAT systems which are bringing up a NAT for INH as well, and a NAT for fluoroquinolones also, because for treating INH monoresistance, we will need to know fluoroquinolone sensitivity. While we talk about the rifampicin resistant TB, the treatment as of today is the state-of-art BPAL-M. We took this call to include moxifloxacin, that is a 4-drug regimen for patients who are FQ resistant as well, because when the 4 drugs are being given to a patient, they synergistically are able to bring down the MIC of the fluoroquinolone. The proof behind this decision was the results of TB practical trial, several studies. One study was published from the US where there was no relapse, no recurrence in the patients who, despite FQ resistance, MDR-TB patients with FQ resistance, were given a BPAL-M regimen. They had no relapses in the follow-up. While in the group where they were given BPAL alone, there were relapses. So that was the decision making that the program did take. And coming to the relevance of the NAT testing, in MDR-TB patients. So, like I mentioned, we've expanded the phenotypic DST, which, let me reiterate, remains the gold standard. We are expanding it across the country, 43 labs doing it now. Certification, Dr. Nishant said, half have been certified. The rest half, I'm sure, will be certified soon. They've been under training for a long time. The bottom line being, when we look at the molecular answer to drug resistance to second-line drugs, what we rolled out was a targeted NGS, which is much cheaper, needs much less DNA as compared to the whole genome sequencing, and can give us all the answers that we may be able to use. So at the baseline, we're trying to offer targeted NGS to the second-line drugs that we'll be using. BPAL-M, choice of BPAL-M, like I said, BPAL-M is to be given to all MDR-TB patients who fit the inclusion-exclusion criteria for BPAL-M. Again, the guidelines for PMDT, the Programmatic Management of Drug-Resistant TB, have been updated last year and are available on the website. For those who cannot be given BPAL-M for inclusion-exclusion criteria, which the patients do not fit into, they are to be, either put on shorter oral or longer oral regimen. And for that, the targeted NGS and the phenotypic DST would be able to help us. So this is how we'll be able to proceed till there is a major change in the regimen recommendation. As of today, we have adopted the state-of-art regimens, in the country, and we are scaling it up so that we can give the benefit to each and every patient. The burden of MDR-TB in the country, earlier the estimates were close to 1 lakh, but last year we did a proper on-the-ground validation exercise, which actually brought in the number of MDR-TB patients to close to 50,000 only. So if we can identify all these MDR-TB patients early, and why only rifampicin resistance, but other resistances also, the way the program is going and the way the diagnostic research is going, we will soon be able to diagnose all drug resistance, give them the defined regimen required, and we should be able to, curtail the spread of the MDR-TB by early diagnosis as well. So the early diagnosis not only helps us diagnose drug-sensitive TB to break the chains of transmission of drug-sensitive TB, but early diagnosis also enables us not to allow a patient to proceed to drug resistance, for delays or such like issues and so on. And also early diagnosis using a NAT, like Dr. Nishant said, universal DST at the baseline will help us give them the right regimen and help us contain the burden of DRTB and TB. So thank you, Dr. Nishant. We'll briefly have our director sir's address to all of you, and then we'll move on to the next session.
Namaskar. Tuberculosis is responsible for significant morbidity and mortality amongst the infectious disease. It's a formidable disease that we continue to fight with all our resources. On this work, Namaskar. Tuberculosis is responsible for significant morbidity and mortality amongst the infectious diseases. It's a formidable disease that we continue to fight with all our resources. On this World TB Day, we reiterate our commitment to continue to fight this formidable challenge. The Ministry of Health and Family Welfare, Government of India, has consolidated and intensified steps to enhance efforts towards early diagnosis of the disease to stop the disease spread in the community. Special efforts are being made to increase awareness to decrease the spread of the disease through Jan Bhagidari. We at AIIMS, New Delhi, are committed to continue our support for this movement. We reaffirm our commitment to furthering our efforts towards TB elimination. We will continue to push the boundaries of our Trinity mission, that is, in patient care, teaching learning, and in research, specifically for TB as well. Jai Hind.
So moving on to our next session, I request Dr. Tamanna to please introduce our first speaker of the session on treatment.
Our next speaker for the day is Dr. Narendran Gopalan. He is the Senior Deputy Director, Scientist F, and Head of the Department of Clinical Research. Dr. Gopalan is a distinguished expert in the field of tuberculosis. He has authored nearly 100 peer-reviewed publications and is a valued member of the WHO Guidelines Development Group, as well as the National Technical Expert Group under NTEP. I now invite Dr. Gopalan to kindly share his insights. He will be talking on trial evidence for TB treatment, shortening. How far have we reached?
First of all, I would like to thank Urusi ma'am for the indomitable support she gives and the encouragement she always gives us and places our ICMR and IRT. So, shortening TB treatment in DSTB, I needless to say, we are still fishing in troubled waters. That's what everybody knows. So, what do we need to know is that TB, despite being even if you have pan-sensitive TB, it requires multi-drug therapy. That's where it complicates and the duration is still cumbersome. The population of bacilli varies and the pattern of drug resistance also varies. And there is very fast emergence of drug resistance, especially if there is inadvertent monotherapy or de facto monotherapy as it is called. And there are two phases which we have. As far as the lung is concerned, everything is in two phases. You have a lung window, you have a mediastinal window. In a CT, just like that, the concept of the intensive phase is to reduce the failures. And the concept of the continuation phase is to take care or tackle the recurrences. In this regard, when we move to shorter regimens, what happens is there's a fusion of the two phases. That's the first thing. If we don't understand this, then all that we take to the patient is only this kind of a thing. Just wanted to briefly touch upon the bacillary populations. There are currently 4 types of bacilli. The rapidly multiplying bacilli, as you all know, where any of these drugs can act. And still INH holds the key to eradication or elimination of this rapidly multiplying bacilli. Whereas the slow multiplication bacilli and the intermittent multiplying bacilli, rifampicin takes over. And that is why drugs like rifampicin, pyrazinamide, the quinolones, which are actually called sterilizing agents because they act on these persisters. Persisters is nothing but the population of 2 and 3. They are very vital for shortening TB treatment. And the last one is the dormant bacilli. There are reports that delamanid and bedaquiline have an effect on dormant bacilli based on the Vaini anaerobic model, but still no convincing evidence as such as emanate. Now, to add confusion to this is the intralesional biodiversity, as it is called, which was by the Clifton-Barry group. They found out that the characteristics of the cavity, especially what they called as dirty cavities with coalescing coagula, and those are the patients who actually are more prone for or vulnerable for recurrences when we shorten TB treatment. So having we have done extremely well with COVID. Now what happens with the bug is that we should understand that the bacteria, the Mycobacterium tuberculosis also has been actively evolving over the 2005 years in which it has stayed with us. So why should we shorten treatment? The longer the treatment, we know that the attrition rate is more. Majority of patients do not require longer schedules. If you look at the paper by Rada Savic, very clearly she has said, and there are multiple papers from the Dick Menzies group also, that 80 to 85% of patients do not require beyond 4 months. 10 to 15% cannot be curtailed with 4 months. That means they require 6 months. And the 5% of this group may not even, may have to extend the treatment even beyond 6 months, say 9 months or 12 months. But the problem with physicians and program officers is that which of these patients are going to fall in which of these characteristics is a billion-dollar question. The third thing is, as rightly pointed out by one of the previous speakers, it's a socio-economic disease. So patients complain to us saying that you have cured us, but what about our occupation? What about our, we have to go back for work. So these are the things. These are the things which we need to give a careful look into. And better adherence and lesser toxicity whenever you have a shorter regimen, and the feasibility of implementation in the program. Every activity, like what Bernard has said, science does not create solutions without creating 10 more problems. There are hindrances to shortening TB treatment. One is there's a mixed response because of the varied bacillary population, which I told. Could you mute the other people, please? It's distracting. The second thing is that the severity of TB itself has its own gravity or weightage, which means that those patients who have more than 3 plus smears, zones more than 3, they have a cavity, all of them are more prone for recurrences. Again, the problem of HIV. Diabetes, peculiarly, we have also found that we have data that diabetes does not cause a very severe problem with proper therapeutics. We have seen from our own trials that there may be more chance of developing rifampicin resistance. The serious adverse events which are related to diabetes could be more, but they are non-inferiorly responsive to TB treatment. So not much of a problem with respect to diabetes compared to HIV. The main therapeutic problem is the recurrences and the zeal or enthusiasm for using newer drugs. And when you use newer drugs, we get lesser options for future treatment. Now, these are the problems which we need to. So, Michison, I don't have to elaborate this. Again, it just shows that the persisters, the activity of persisters based on the drugs on the persisters is given below. So, what happens actually is, I'll just take you through the journey of 12 months to 2 months. The problem is that it's not just that we are very happy in trying to reduce it to 12 months. you will see that the radius of the spheres are directly related to the complexity. What I mean is that as and as you go to newer drugs, we have more complex regimens which are coming through. And we need to look at the toxicity profile. We need to look at drug interactions as well. So going from the first study of ICMR NIRT, which was previously called TCCS, Tuberculosis Chemotherapy Center, this was a 12 months regimen which compared home and sanatorium, where patients were treated with once in the domiciliary environment and one with sanatorium with special care. Probably the first non-inferiority design RCT which was conducted globally. But what I would suggest is the importance is not just showing that they were non-inferior. What was important, which was demonstrated, is the transmissibility to the contacts were also non-inferior or more or less the same. This was more important for us to deduce that yes, we could treat these patients at home, and this was done at a time when sanatoriums were full and there was a waiting list, a long waiting list for admitting patients. Now, this was the first revolution which was made by ICMR and ART. And the short course chemotherapy, most of the people think that short course chemotherapy means 6 months. Short course chemotherapy means less than 1 year. And these regimens have been tried not just with pulmonary TB. They have been tried with all sorts of TB in the previous years by ICMR, NIRT. But due to the shortage of time, I will not be going through all of them. I'll stick myself to pulmonary TB and drug sensitivity. So what are the pathways which are being experimented if you look into it? The major pathway which has been, which people have tried are just remove ethambutol, which is a bacteriostatic drug or INX, and then add quinolone in that place. Use rifampicin or high-dose rifampicin. Now there is an emergence of pan-TB regimens. There are new statistical models to help in shortening TB treatment. Apart from that, the renewed interest in using PET-CT, the SUV levels, as well as biomarkers for trying to predict who will be more prone for recurrences. Now, these are the various ways which are being adopted to reach the milestone of 2 months therapy. So if you look at that, so this was the first study, the home science study, and then was the 3 and 5 months treatment using with and without rifampicin. What they found was rifampicin, unless given throughout, the recurrences were more. And then came the study 18, which used ofloxacin for 3 months in the intensive phase, and found that a 3 months and a 5 months regimen had a recurrences of 2% and 4%. Then came the study 24, which was headed by Dr. Jawahar, where they found out that a moxifloxacin regimen without substitution of the first-line drugs, but addition of moxifloxacin along with the first-line drugs were able to give recurrences of only 2%. So just to go by the quinolones, in fact, I was surprised, and people may not know, it's our duty to tell that ofloxacin was having antimicrobacterial action, was known to this world through ICMR and NIRT, where we found that quinolones were given could very much effectively reduce recurrences. But when we tried it in the intermittent phase, because at that time the periodicity was intermittent rather daily, what we found was, even though culture conversions were superior, because of the lack of lag phase, quinolones did not fit into the intermittent model and had to be given daily to reduce recurrences. Then what happened to the global trial evidences? Parallelly, there were very many studies which were started, and where we found that the oflutop, the Remox, and the Rifaximin, all of them published in the same journal of NEJM. Multiply, what they tried to use was substitute the quinolones for either ethambutol or INX, and use rifampicin, and found that there was they could not achieve non-inferiority. The only study as of now, the trial as of now, which had put was TBTC 31 by DOG. But then when we teased out the differences, what actually happened? Most of the three foremost trials were done in a population with very heavy HIV load. Those patients had severe TB, and the biggest problem or challenge was recurrences. The only regimen which actually succeeded was the regimen which not only contained rifampicin but also moxifloxacin. So it goes to show that, like the two wheels of a bicycle, Primarily giving just rifampicin or only quinolone is not able to achieve its desired effects. So then came the Boris dreams of high-dose rifampicin. As you know, the curve, which you can see, that AUC is actually determining your bactericidal activity above the MIC. And that way, we also found from various systematic reviews that the best dosage of rifampicin was 25 milligram. In fact, it is contested. In India, we found that 25 milligram is more than 25 milligrams is not tolerable, but the Africans were able to tolerate up to 35 or 45 milligram per kg polymeter. So based on that, the hepatotoxicity review also showed that 25 milligram was optimal. And this was proved by the study which was done by, a trial which was done by ICMR NIRT, headed by Dr. Bhavani, where they found out that a 25 milligram had the same sputum conversion and sterilicidal effects at higher doses and had comparable toxicity with respect to the conventional dose. The study by Amita Jindani very clearly showed that just giving higher doses of rifampicin, they had used 1200 and 1800 milligram, which gave an average dosage of 22.3 to 23.8 milligram of rifampicin, 1200 arm, and around 23 to 25.6 of rifampicin in the 1800 arm. And what they found was, even though high dose rifampicin was used, unless you use the fifth drug, they were not able to show non-inferiority, which means that recurrences were more if you are not going to use, if you are just going to use high dose rifampicin alone. The Truncate trial was a very ambitious trial, a 2 months regimen, which was given, and what we found was that in these, the only regimen which came out highly successful was the one with Beta-lactam and linezolid. Of course, you'll see that now that the newer drugs are being used in this regimen. But what is more important is that when we excavated the data, the outcome of Truncate was a little peculiar. It said that at 96 weeks, you are not supposed to have TB. If the patient was retreated once again, there was no problem. But that is the problem which India will face, because recurrences are almost a quarter as which came out from the survey done by Dr. Shriram and CTT, where they found out that almost 20 to 23% of recurrences were actually, that is, patients were proved to be microbiologically positive, came from recurrences. So this is one biggest problem with the Truncate trial of 2 months. So what are the other alternative approaches if you see? One of the favorite approaches is stratified medicine. You can't manage a milder disease with an advanced disease in the same platform. The milder disease will, if you suppose you give 6 months of treatment for a milder disease, the patient suffers from toxicity, whereas for an advanced disease, if you think of reducing the duration, you will get recurrences. So we have to balance between both. And this was the paper by Imperial et al., where they found that cavitation, smear grading, greater than 2 zones in the X-ray, bilateral HIV were very, very significant factors for unfavorable responses. We did the same exercise among NIRT trials, which showed that except for bilateral, all of them were identical. That means we also had the cavity, smear grade, greater than 2 zones, and HIV as important factors. The only thing was that whether it's unilateral or bilateral, if it's greater than 2 zones or having a cavity, they were actually, they belong to the severe category rather than mild, which means that shortening durations will have more recurrences in that group. So this was the other study of non-severe TB, which was done, the SHINE study, which was headed by Dr. Syed from here. This was a multinational study where they found out that a 4 months regimen was good, but the definition of minimal TB was a little complicated and was not directly translational. That is why probably it was very difficult for us to take it to the program state away. The other important point is there were only 14% of patients who had culture positive TB, which means that is confirmed TB was only 14%. So when you categorize into limited and extensive, why should we stratify? If you do that, what we see is that whether it's limited or extensive, there are comparable success rates with respect to regimens. This is what is important. And what we find is, whenever there's extensive disease, the margin widens. And that is the reason why whenever you are tackling severe disease or extensive disease, you need to augment the therapy, whatever you are giving. You cannot give the same regimen for a shorter duration. So then came the birth of pan-TB regimens. We have lots of newer drugs which are coming into the market. They are being tested. One is these are early studies by Otsuka, the Epistat, where they had only 3 drugs. The only problem was recurrences were more, and here their main primary aim was to look at sputum culture conversion, which was non-inferior. So the objective was not to look at the recurrences actually. So it was non-inferior based on the 3 drugs. Again, there are also the sorficolin and delpazolate, which have been very much useful in reducing the toxicity of linezolate. We are able to see that one of these are again in phase 2. They have already proved to be useful in 2 months regimen, but we have to see with respect to the phase 3 and recurrences. The other is alternate statistical approaches. If you look at all the trials which have been happening, wherever it happens, you can see that the number of years which has passed because of this is too much. And everybody is actually looking at the duration, which is very, very important. Now we no more give filter coffee, we give instant coffee. Just like that, the duration is very important. And that gave rise to what is called from statistical design, static designs to adaptive designs. The basic idea is very simple. In a static design, you have the data accrued, you are not looking at anything else, and you are not looking at the data which is getting accrued and come to a final analysis, which means that you are not actually using this data to redefine the pathway. Now, the advantage of the adaptive designs is that you make an interim analysis, and accordingly, let's say a fellow is not doing well, you reduce the recruitment to that fellow. If a fellow is doing extremely well, you increase the recruitment to fellow. That is precisely the idea of the adaptive designs. So paradigm is one of the adaptive designs where we are trying to look at almost 18 regimens to find out which is the best regimen in phase 2B. And then look at durations of it's actually the phase 2Cs of varying durations we are going to start. Thanks to Dr. Ursi ma'am and CTD for giving us the support apart from ICMR, and we are trying to see if which of the durations can be helpful and the best duration can be used in trying to reduce these recurrences as well. And also this will also help us to give us a pan-TB regimen which can be used in MDR-TB as well. There are newer parameters to predict recurrences. Of course, nothing is in biblical language, nothing is a golden bullet. I should say that these are all helpful in various ways, but we are not able to still say which of these patients will recur with confidence as of now. The other alternatives are trying to give a long-acting injectables. The idea came from the HIV field, where now after the successful virological suppression, you give a long-acting injectable of antiretrovirals and seen that you don't have to daily take treatment. It's just one shot in a month for the course, and that makes life easier for the patient. In the same way, what about giving a 2 months regimen and then giving a long-acting injectable? That is what is being looked into. Again, depot caplets. Depot caplets, again, we looked at because thanks to the TB Innovation Summit, which was organized by ICMR, what we found was that there are certain institutions like Chitra Ethanol which are come out with these kind of drugs which are implanted, most importantly in pot spine or in tuberculosis, where you do not have to prolong the treatment for more than 6 months, but just impregnate along with the bone cement, so that there is a slow delivery of these drugs at the site of the lesion, so that neither have you to increase the duration of treatment, nor have you to but the efficacy is maintained. But most importantly, the bigger disadvantage is what happens when there is toxicity. How are you going to remove these caplets? So that is, again, there are certain vaccines which are being developed for post-treatment prophylaxis. So with this, I would again thank the organizers, especially Madam. She always been a source of encouragement and support to us. And if there are any questions, I'll be glad to answer. Thank you so much.
Thank you for the wonderful talk, Dr. Pal. If there are any questions on the Zoom, are there any questions on Zoom? No. So we are running this live on Zoom as well as YouTube. Incidentally, there are no questions. Possibly, if any further questions come up, we'll share it with you on the email. But we have some of our ID fellows with us right now here. Would any of you like to ask a question? So I guess your talk was quite lucid. Yeah, please.
Now, have you tried any trials with Terizolid in place of Linezolid for?
Give them a mic.
Good morning, sir. Thank you so much for the talk. Have any trials been done with Terizolid, in replacing Linezolid and assessing the neurotoxicity? We generally have a lot of problems, so we'll have to bring it down to 300 and CKD and these patients as well. So,
see, ideally, there are 3 or 4 oxalidinones which have come into the market. Madam knows that she's also a favorite of these oxalidinones. But Terizolid, I'm afraid that after the initial phase 1, there has not been many trials. But Sutisolid and Dalpasolid have come into the DECODE trial has just completed, and they have found out that it has 1 by 1/50th of the hematotoxicity and almost 1 by 20th or so of the neurotoxicity. So those drugs, Dalpasolid and Sutisolid, have already started coming for phase 3 trials. Terizolid, as such, to my knowledge, has not gone beyond phase 2. In fact, it's still in phase 1.
So I guess in the near future, we may have more knowledge about this. Dr. Gopal and I just have one small question. You beautifully covered all the shorter regimens and the failures and the successes of all of these. The TBTC 31 did not use rifampicin. It used rifapentin, which is a longer half-life, So the point I'm trying to make is you elaborated on, moxifloxacin and its relevance in shortening. Probably what is not working is the combination of rifampicin and moxi. And what worked is the rifapentin and moxi. What are your views on this? In fact,
that's an excellent question. Actually speaking, there may be interactions we don't know. As you rightly said, more PKPD data will be able to help us out in this. But the unfortunate thing is that even though TBTC 31, which was done on 2,591 patients, equally distributed with almost 12 sensitivity analysis, everything was done, did not have the pragmatic success. It was tried in San Francisco and it was tried in New York. They have both this thing. Even though it was a smaller group, there was very severe toxicity, and America itself is not propagating TBTC 31. That is the truth.
And they did not have long-term outcomes. They did not have long-term outcomes. At least in the first paper, they were not published. So we are not really aware of the relapses that it may, that we have.
The long-term outcome paper also has not been published yet. You are right.
Yeah, and rifapentin, of course, is an expensive drug for a developing country like ours. To give it as a rule to all patients will be tricky again. So treatment shortenings for now, I guess we'll need some more time with some newer trials. So thank you for the lucid talk, and thank you and your institute for a lifetime of research in the field of TB and for leading tuberculosis research in the country. Thank you.
Thank you. Thank you.
This we move on to our esteemed colleague who will be speaking on pediatric TB. Professor Amita Sharma, the former director of NITRD and the head of TB Pediatric Department at NITRD, Delhi. Please go ahead.
It is my privilege to introduce our next speaker, Dr. Sanketa Sharma, Professor and Head, Department of Pediatrics, National Institute of Tuberculosis and Respiratory Diseases. With over 124 publications, she is an expert member of the WHO Guideline Development Group and Global Drug Resistant TB Initiative Core Group. I invite Dr. Sanketa Sharma to share the valuable insights on pediatric TB management recent advances.
So, is it visible?
Yes, ma'am. Yes, ma'am.
Right at the outset, I would like to thank my dear close friend, Dr. Urvashi V. Singh. She has always been a pillar of inspiration, I would say. With such elaborate work on TB diagnostics, and I would now be talking essentially on TB treatment. What is new in children? What are the recent advances? So, as you are aware, children constitute 1.2 million out of a caseload of 10.7 million as per the Global TB Report 2025. That is almost 11% caseload is in children. But what is heartening is that, the mortality is 96% in those children who do not get access to TB treatment. So that is very disheartening. And now coming to the TB success rates, when you look at the TB success rate in new and relapse cases. So, uh, uh, children, they always fare better than adults. If you're looking at TB, drug sensitive TB or drug resistant TB. For drug sensitive TB, all ages 88.5%, while children it is 92%. And when you're looking at the success rate for MDR, it is 61%, while for children it is 77%. So, but what is important is that the global coverage is very less, that is almost like 58%. And it is worse even for global treatment coverage as regards to MDR-TB in children. That is only 14%. So now coming to the preventive aspect, global coverage in context less than 5 years is just 38%, while more than 5 years is 20%. So we are, having gaps as regards to prophylaxis. Over the years, the largest increase has been for ages who are receiving TPT more than 5 years, and the slowest progress is for children who are less than 5 years. And the slowdown has occurred when you're looking at people living with or children living with HIV. Probably they have already achieved the WHO target. So we have the case detection, the treatment and the prevention gaps. As I already highlighted, what we are concerned about is that majority of children, the deaths which occur are in those 96% who do not have treatment access. And same is true for TBT prevention, that is two-thirds of the children, they do less than 5 years, they do not have access to TPT as per the WHO global data 2025. Now, we are all aware about the WHO NTB milestones 2025, which was supposed to be reached, in which the target was that we were to, treat children out of the 40 million. The target was that 3.5 million children had to be treated, and we have just treated 2.5 million, that is 71%. And when we are looking at MDR-TB, this is lower, that is only 19% of the MDR-TB expected caseload is put on treatment. So what is important is we have the newer diagnostics coming up, we have the newer treatment and preventive regimens which I'll be discussing now. But the most important thing is that we need to improve access. And to improve access, for diagnostics, they need to be made near point of care tests or point of care tests, which I will not be elaborating because my talk is essentially on the treatment aspect. And for the treatment, we need to look at those regimens which are looking towards shortening of the TB regimens, be it treatment or prevention. So there is an urgent need for innovation to meet these challenges in the TB management as regards to children. So the union had formed a group in which we looked at the clinical standards, how we can improve the access to children, and 8 clinical standards were shortlisted suggested, in which there was that the treatment initiation needs to be urgent, especially in those cases in adolescents with or children with presumptive the disseminated disease, TB meningitis, and we also need to include adolescents as a separate group, and they need to be given priority. Now, also we had brainstorming sessions on what are the policy practice gaps which need to be addressed as regards to TB preventive treatment. So over here also the gap was that we need to improve the access and also take care of the MDR-TB TPT. So even at the union this year, it was my privilege that I was invited to chair this session, and it was a interesting session in which we discussed the newer diagnostics, the TB treatment, the preventive strategies, and also hear from the TB survivors. So and majority of my talk now would be based on the overview of what is new in the treatment as regards to TB treatment regimens, the drug susceptible, the drug resistant TB regimens, the preventive treatment regimens, drug sensitive and drug resistant, and what are the overarching conditions when you're looking at these regimens and their selection as regards to patient. And just a word about the newer TB vaccines where the children are also involved. So we are all aware that we have this goal to end TB, and I would now be focusing that where we are actually, where we are right now, from where we started. So for drug sensitive treatment, we started, we are all aware that the 2-HRZE4 HRE, it was recommended by WHO way back early in 1980. And, so the question which lies is that can we go shorter? Can we have one regimen irrespective of the disease severity? So we are all aware of the drug sensitive treatment TB, the famous SHINE trial which was published in NEJM, in which almost 1,200 children were accessed. There were two arms. One was given the shorter regimen, the 4-month regimen, and the 6-month regimen in the control arm. And these children, they were followed up for 72 weeks. So the encouraging results were that non-severe TB, by non-severe TB I mean the criteria have been defined. That is, for those children who are smear negative, they can be culture positive and even NAT positive, but the severity of the disease needs to be limited to less than 1 lobe without any cavities, and if there is pleural effusion, it should not be complicated. That means there should be no thickening or pockets in the pleural effusion, and if there is mediastinal lymphadenopathy, it should not be causing any obstruction. So such children were labeled as non-severe, and they were given the 4-month regimen of the SHINE trial, and the control arm was given 6 months. So it was a non-inferiority trial which highlighted that for non-severe TB, this is a regimen which can be undertaken. So, but under the program, we have not included this in our NTEP. The reason being, because for us, there is limited accessibility of a chest X-ray, and also the biggest issue is the chest X-ray interpretation. So even for the SHINE trial, the limitation, the gap, which was that in these children, almost 171 chest X-rays which were reviewed by separate experts, they labeled that they had the severe TB, and it was misinterpreted as non-severe in the beginning. So keeping this in mind, we have not adopted this under our NTP. Now coming to the next trial, that is the 4-month rifapentine regimen with or without moxifloxacin. So over here, the study 31 again it found that this regimen is effective for children more than 12 years who have just pulmonary TB. And this included 68 adolescents. These are the two regimens which are there. Now coming to the WHO, the WHO recommendations are for the three regimens. The two for the non-sphere, as I have discussed, that is the 4-month regimen, 2 RSZE, 2 RH, and the second regimen, the rifapentine based regimen, that is also again for 4 months, and then the 6th month regimen for TBM, supposedly which is drug sensitive, in which ethambutol is replaced by ethanamide, and that is a 6-month uniphasic regimen. For TBM. But again, the concern over here, which I had during my interactions with WHO, was that the TBM regimen, I'm not quite happy, because there is no separate data which tells us about INH sensitivity, because we are giving two drugs, we are giving INH and ethanamide, and both until and unless we know about the INHA and the CAT-G resistance, I don't feel comfortable, in starting this for a disease which is the severest of forms of tuberculosis. So that is the reason we have not adopted these regimens under our program. Now coming to the so where we are, have we gone shorter? The answer is yes. The regimens recommended by WHO, there are there. That is, as I've already said, these three regimens adopted by, which have been recommended by WHO, but they are not been adopted by a program, where the concerns which I've already highlighted. So coming to the DRTB regimen treatment, from where we started was that, we had, more than 1 year treatment, which included injectables. So again, the question mark was that, can we go shorter? Can we go all oral? And are there any acceptable regimens which have more acceptable drug formulations? So for this, again, TB experts, we made a strong recommendation that there is a strong case for all oral shorter regimens for children with drug-resistant tuberculosis. And for the baseline of this was these two meta-analyses of, luckily I was part of both of them. That is the first meta-analysis which led out to the phasing out of the injectables. This was published in PLOS One. This led the WHO to phase out the injectables, because it clearly the data showed that children who are subjected to injectables, 25% have a hearing loss, and that can lead on to even learning disabilities later on. So the second one was the recent, the largest meta-analysis which has happened over the years for drug-resistant tuberculosis, and over here almost 23,000, more than 23,000 children. The pool data, it showed that the newer drugs, that is bedaquiline, moxifloxacin, levofloxacin, linezolid, they can be used in children, as they are fairly safe. So they need to be included in the drug-resistant TB regimens as regards to the children. So with this, now the WHO has come out with the recommendation that we have, we are all aware that there is BPAL or BPAL M, but that is reserved for adolescents more than 14 years. And for younger children, we have BD-LLC. That is another regimen which has been recommended by the WHO. If that is not possible to, because they have got the inclusion criteria of BD-LLC, then the next regimen is the 9 to 11 months regimen, which includes the shorter MDR-TB regimen, which we are already aware we have been using, in which now ethanamide has been replaced by 2 months of linezolid. Again, we are giving that for children children. And the other regimen recommended by WHO is the 9 to 12 months. The NTB regimens, they are for all ages, but again, the candidate has to be fluoroquinolone sensitive. So both these shorter regimens, that is the 9 to 12 or the 9 to 11 month regimen, they are reserved for those children who are FU sensitive. For all other cases, the crossover, the use over is the last, and that is the longer and preferably individualized regimens, and preferably oral if we are able to make it. So these are the, as I said, the NTP regimens. These are the 9 month, that is, and if you see, the first choice is the 6 month regimen, that is BD-LLC, and then the next are all, the second choice is the 9 month regimen, and they are all pyrazinamide based. All the three regimens of the NTB trial, they have pyrazinamide, and they are 9 to 12 months. So with this, the answer that have we made the regimen shorter? Are they all oral, and are they more acceptable with better formulations? So the answer is yes. The data has emerged that 6 to 9 month all oral regimen for children of all ages, and then we have BPAL or BPAL M for children who are more than 14 years, and then finally Delaminid in longer all oral regimen has been recommended by the WHO for all ages. Now coming to the shorter bideclin containing regimens, BDQ was recommended in adults in 2013, for children more than 6 years in 2018. But now in 2024, WHO has recommended bideclin to be used for children of all ages. Now, over here, the next question is, have we adopted these under NTP? My answer is still we are struggling with the approvals. Dr. Urvashi tried her level best, when she was our DDG, to get the approval of Bideclin from the DCGI, because right now we are able to use Bideclin only for those children who are more than 5 years and weigh more than 15 kg, and Delaminid is recommended by approval DCGI to be used for all ages, but the weight has to be more than 10 years. So but the sad part is that the data which is on the basis of which the WHO gave the approvals for these drugs, Bideclin and Delaminid, to be used for all ages. The data was data was from India, with my colleagues from Mumbai and myself contributing to that data, which the WHO accessed, and then they gave their recommendation. But we are bound by DCGI, so that is the reason we are still struggling with our approvals. Now coming to the next part of my talk is, that is prevention. So regarding prevention, where we all know that we have the age old, that 6 or 9 months of monotherapy with INH way back in 1950, that is, and then 3HR, that is recommended by the WHO from 2018. But now the recommendation, that is 3HP once daily by the WHO, was for adults in 2018, and then came this recommendation from WHO that it can be used for children more than 2 years. This recommendation came in 2020. But what is the status now? Where we are? Can these regimens be used for children less than 2 years? And then we are all aware that we have another regimen which is rifampicin based, that is for emergency situations if the patient has deficiency, organ transplantation, or a cancer patient. So in those situations, prophylaxis can be done by 1 HP. That is a daily regimen of INH and rifampicin. So what is the status as regards to children when we are looking at use of 3 HP in children less than 2 years and 1 HP in children? So this is the TC, that is Tuberculosis Trials Consortium, which included children less than 2 years, in which there were 2 cohorts, less than 1 year and 1 to 2 years. while the other cohorts are, we are all aware, they are for older children. So the results which emerged was that, these drugs, they are safe, and they're fair enough to include them in the preventive regimen. Now, next comes the use of that is the age based. Now comes the weight based, that can these regimens be used for children weighing 3 kg and above. So the answer again is yes, and this has been included in the module 1, that is the TB prevention module by the WHO. Now coming to the 1 HP trial, as the trial as regards to children. So the PK, the safety data of 1 HP is still emerging, and this trial will be opening in 2026. So, this is the current status right now, that now we have 3 HP dosing now available for all ages. So, we can use them for all age. The only thing is that the ratio of INH with rifampicin, it differs in the lower weight bands, and therefore the single dispersible tablet cannot be used. So, we need separate tablets for INH and rifampicin if we are to include these children, and we have to start them right from the birth. So coming to the adult FDC, that is the 300 INH and 300 rifampicin, that is for older children, and the age weight based approach for weight bands less than 10 kg, there are different dosing for based on the age, that is less than 3 months or more than or equal to 3 months. So and for children who are weighing between 3 to 6 kg, and then again from 6 to 10 kg. Over here again, both the criteria, they need to be taken care of, that is the age and as well as the body weight. So but whatever it is, now these recommendations have been revised, and WHO recommends that all these regimens, that is 3 HP, is suited for children, newborns with a weight of more than 3 kg. So, rifampicin, now can we use the crush tablet? The answer is yes. The crush tablet can be used for rifampicin when swallowed, suspended in water. So, overarching conditions for these regimens are that we need to be working upon the availability of these drugs, the dispersible combinations. Now the last part is, that is TB vaccines, because there are few vaccines which are for the prevention, then for the recurrence of TB, and for the disease. So even children are being included in these trials. There are 17 newer vaccines which are being tried. Active trials right now are limited to these, as I have shown in my presentation. So these are actively recruiting, with 4 in the phase 3 trial. So to end my talk is that our road to goal, that is NTB. So where we are, we have come a long way as regards to, we have achieved significant gains in the last 20 years. But where do we want to go? We want to have shorter, stronger regimens for TB treatment and prevention. Like the world community is moving towards a 2-month regimen for drug-sensitive TB, a 4-month regimen for drug-resistant TB without need for disease stratification. And these regimens, they need to be safe, they need to be all oral with FTCs available as dispersible tablets. And ideally, there should be a single TB vaccine, that is for point of infection, prevention of infection, prevention of disease, and prevention of recurrence. So this is what our dreams are sitting over here, and hopefully I think the road to goal will be with all the commitments which we have from my fellow colleagues on the TB field. So with this, I would like to end my talk and conveying my thanks to all those for your kind attention. Thank you so much.
ये अनम्यूट कर दीजिए,
हाँ, बोलिए बोलिए।
अनम्यूट कर दीजिए।
Thank you so much, Dr. Sangeeta, for the lucid talk. You covered all aspects, you covered all recommendations, WHO, and
All the committees which have been actually behind the pediatric TB treatment, and so you brought out the issues that you may be facing in treating patients with MDR-TB, which I'm aware your institute under your guidance is treating a lot of patients, a lot of children with MDR-TB, and you're also looking at salvage regimens for some of these patients. We're actually, thankful to you for sharing your experiences. And if time would permit, I would ask you to detail on your experience with children who need salvage regimen. Yeah.
Yeah, if a short answer, right now we are conducting this ICMR funded trial in which we are, because whatever the question which comes under NTP is that, are the recommendations which the WHO has given, are they applicable to our NTEP? So, at my institute, I'm conducting this trial in which we are, comparing the longer MDR-TB regimen, that is the 18 to 20 month, that is either bedaquiline or delaminate based regimen with a combined PDQ plus delaminate 6 to 9 month regimen, and the results, they are really encouraging. Although, I mean, we are now, except for 19 children who are still ongoing treatment, rest all have completed and we are in the follow-up stage. The only problem which I've had is like I have lost 2 children in the treatment follow-up. So, that is a big question mark. The complete data when it comes out, we are doing the 6 months follow-up due to paucity of time. So, let's see what the results are. Right now, all the three regimens, they are comparable, with a slight shade better being the shorter regimen, that is BDQ plus delaminate. And the other good part is that I'm recruiting all children because, being center of excellence, we get children with disseminated TB, with TBM, so with comorbidities. So I've included all the children and it's a randomized control trial. So let's see the final results are, and you are, Dr. Urushi, you're a part of that trial. So, and with all your encouragement as DDG TB, so this trial is running very smoothly and we are like, we'll be ending this trial with the follow-up in next year.
So, I have witnessed her commitment to these children and how much hard work she puts behind, ensuring that every child is cured. Of course, it brings us a lot of satisfaction when our patients get cured, but kudos to her, commitment and the pains she takes to take care of each and every child that comes under her care.
Thank you so much, Dr. Urushi, for your kind words. I don't think I deserve all this appreciation, but thank you
But we
anyway.
have seen very closely how much. Dr. Sangeeta, one more question.
Yes,
What is your opinion on the BDLLC regimen?
Again, the answer remains the same. The regimens which are recommended by WHO, we need to field test. So BDLLC is indirectly what I am doing. So, as I said, it's a good regimen.
I'm sorry, but you're also including CC, right?
Yeah, I'm including, mine is CC because we are also including cycloserine. But I would say that for our country, even with BDLLCC, I've had failures. I've had 3 failures of this regimen. So maybe, our inclusion criteria, because the kind of tuberculosis which we have in our country. So we have to assess everything on that aspect also, the severity of disease and the kind of patients we get, having severe moribund, severe malnutrition. So all those points, although HIV is not a problem, I've not even had a single seropositive child in my 219 cohort, 73 per cohort each. So, but I feel that, for adopting this shorter regimen, the only criteria which needs to be looked at and which we are looking at is the post-treatment follow-up. as I highlighted, I've lost 3 cases, in the post-treatment period. So we need to look at that aspect, that how many relapse and how many, although the children, they were cured. I mean, let the trial be over, then I'll be in a better position to give you my answer on your question, please.
Just one more angle to this. Were you able to do pharmacokinetics for these children? Were you able to see the levels of drugs reached in these children? Why I bring this is, when we look at the older population, the adults, often the levels of drugs are not reaching the desirable levels. And even, often we also see that low BMI population, often diabetics, such like patients may not achieve the levels. It's possible that the undernourished do not absorb the drugs adequately. So, were you able to incorporate PK? Because I know NIRT, NIPRT, and NAMES are two sites which have the PK facilities.
Dr. Urvashi, right now, not under this trial, we have not done the PK, but we are actually doing PK for those children who are non-responders. And, I published some of my data and it is in the public domain regarding linzolid, that is with the Benefit Kids trial, and also with NIRT Chennai, in which we, looked at the PK levels. And you are absolutely right, the PK, there is it is true for children also that some doses they need to be revised. But one thing which emerged out of linzolid, which I want the house to know, is that even in my trial this holds true, that if we start linzolid at a hemoglobin level more than 10, the chances of myelosuppression are significantly lower. That was in the linzolid PK study, which was published in the Benefit Kids. I was a part of that, and it is also true for this trial which I am running. That is the MDR-TB trial. So I always make sure that I start linzolid only when the hemoglobin is more than 10. And for me, myelosuppression has not been a major issue. In fact, peripheral neuropathy is more common for linzolid in my children. So that is one take I would like to, share with the house.
Thank you so much, Dr. Sangeeta. I would also like to touch upon another angle. When you said 11% children are being diagnosed, I guess we need to work more on diagnosing more.
Yeah.
We started the morning. Yeah, we started the morning today with a beautiful talk by Dr. Puneet Dewan, who delved on screening. He went on to say best would be we could actually reach population level screening. Now, there, my point that I was trying to make in children, the question is, are we able to screen all of them? When we talk to experts who are serving in tertiary care centers like you and me, they're of the opinion, some of them said, why screen everybody? But the debate here is, since we are not diagnosing all the children who may be affected, since a good number of children may be low BMI, at least in the risk groups, we can start offering them screening, possibly using the same handheld X-ray, which does not have a lot of radiation exposure. And like I mentioned earlier on during the meeting, that the capability under the program to offer handheld X-ray has gone up many-fold. We started it when we rolled out the TB Book Bharat Abhiyan, the effort to do after-case finding in the vulnerable risk groups. But children was one group where we were not able to, actually focus much. So, what is your opinion? We should go ahead, screen these vulnerable children. Possibly we'll pick up more with the disease.
Yeah, I totally agree with you, Dr. Urvishi. I'm totally for it. I mean, if there are marks more than 100, I would give more than 100 because we are seriously missing on those children, you know. And I strongly recommend that we need to focus on children. Let's start from somewhere, you know. Let's start with vulnerable children in the vulnerable areas, and then finally we can even think of, you know, opening it in school camps. You know, we have annual school examinations, and now with this handheld chest X-ray, which is also AI powered, you know, we can have at least with limited radiation. So with this handheld, now the radiation exposure is very less. I think it is worthwhile to even include it in the annual school health examination, which each and every child who goes to the school has to undergo. So I'm strongly for it. You know, we need to start because we are actually missing. And if you look at the WHO global data, it tells us that out of those 1.2 million, 31% are in India. You know, the total TB data is 25% total. But if you look at the split for children, 31 to 32% of the global caseload is from India. So Indian children, you know, we are seriously missing 12 to 13% should be our average notification, but we are still struggling at 6 to 7. So I am strongly for it, you know. We need to start for children.
Thank you so much, Dr. Sangeeta. When I, as my earlier DDG position, we try to tie up with the
Yeah, you would like a lot,
school health,
Dr. Rishi. Yeah.
school health program, and let us try and push this.
Yes.
We must screen more children to find more disease and treat them well in time, so
Yeah.
we have less MDR-TB being generated because of delays in diagnosis.
Yes. And less
Thank
spread
you, Dr.
also.
Sangeeta. I think there are a few questions in the hall for you, and we'll check if there are questions in the Zoom.
Okay.
Mike, please.
Thank you, ma'am. Thank you, ma'am, for the talk.
Please introduce yourself.
I'm Dr. Kangsha Advania, final year resident of infectious disease. I had one question, ma'am. Like most of us, when we sit in the DOTS clinic, we always see that a patient adult patient who's having MDR-TB, years later we see the children presenting with the same symptoms, having diagnosed as MDR-TB. So first question is, do we advise fluoroquinolone in children in contacts of MDR-TB? And second, in patients where we have the FQ resistance, we are usually at lack of options of what to prescribe them. So what do we do in those cases?
Yeah. You're absolutely right. You know, now 6 months of levoflox or moxiflox is recommended for MDR-TB context. And if you have INH resistance, then we have 4 months of rifampicin. But right now, you know, there is, you are absolutely right. Right now, there is no WHO recommendation, although the trials are going on for use of bedaquiline and with parazinamide. Then there is another trial which I know for XDR, in which they are assessing delaminid for as a TPT. But all these are under trials which are occurring in children. But right now you're absolutely right, we have no preventive regimen as regards to pre-XDR or XDR.
Thank you, Dr. Sangeeta. If there are any further questions, are there any questions in Zoom? The program has rolled out for the adults with contacts of adult contacts of MDR-TB. 6 LFX is being given, but like you said, for children we still are not really.
No, we are giving, Dr. Rishi, we are giving, yes, please.
We're giving 6
we are giving 6 months of levoflox.
Yes. So that answers your query. Yeah. So with that, a big thank you to you, Dr. Sangeeta, not only for the talk today,
thank you so much,
but also for years of your service towards children with TB. Thank you, Dr. Sangeeta. It's been an honor to have known your work and you. With
And
this,
it's
we
an
move
honor
on
to know you, Dr. Urvashi. I mean, I'm feeling so belittled in front of you. You are such a icon in yourself. I mean, words of praise fall short, you know. I mean, you're a source of
Thank you.
inspiration for me, always, and will remain always. Thank you so much for inviting me. Thank you.
With this, we move on to the next talk. Here again, we bring the programmatic perspective. Dr. Sanjay Mattu, I request.
Please share your PPT. Can you share the
Thank you, ma'am, for the insightful talk. Building on the discussion, it is now my pleasure to introduce our next esteemed speaker, Dr. Sanjay K. Mattu, Joint Commissioner at Central TB Division. He is a distinguished expert in tuberculosis control and public health. Dr. Mattu brings a vast experience in TB elimination strategies, drug-resistant TB management, and healthcare system strengthening. Today, he will be speaking on advances in tuberculosis treatment and updates.
So Dr. Mattu would have joined us in person, but the National TB program is launching the TB Mukt Bharat Abhiyan 2 in the evening today. Honorable Minister of Health will be launching the program, launching the Abhiyan in the evening. So my program colleagues are busy with the arrangements there. He has shared his recorded talk, which if you would just give us a split second, we'll share with you.
As the HIV intensity decreases, the position of the TB community is better as compared to other countries. We still understand here about 1/3 of the total MDR-TB cases occurring which from India and all overseas is compared. We know that United Nations organizations has set the SDG target. One of them is incidence reduction, and as we are comparing the rate of incidence reduction in the global protection, we are have used almost at double pace. Mortality reduction.
As the global reduction is there. Another important factor, you can understand the commitment from the government of India, the political commitment and the governance commitment, where the proportion of the domestic funding has increased, and you can understand we have reached near about the 97% of the funding is from the domestic funding of the total fund consumed in the national TB program. We are having a national strategy which includes the 4 pillars. One is the detect, treat and prevent. We all understand that India is focusing along with the detect and treatment. The prevention is also important pillar where we are giving the TB prevent treatment, and we are focusing on the air infection control and prevention measures. Build is the overarching component with over the 3 pillars where we are having infrastructure development and the capacity building throughout the country, and from topmost health institution to the peripheral most health institutions. Further to detect, we can understand earlier it was a 2-pronged strategy where we were having a passive case finding and the active case finding. Current strategy along with the passive case finding where the patient is coming to the health facilities, we are having health facilities based intensified case finding where we are having vulnerable population clinics like HIV clinic, diabetic clinic, the tobacco cessation centers, NCD clinics and other vulnerable populations. And not only the intensified case finding is to be done in the OPD but IPD also. For the active case finding, what we have changed, we are along with the symptomatic TB cases, we are finding the asymptomatic TB cases in the vulnerable population. You can understand so that we can find out all the tuberculosis. India has changed strategy from 4 symptoms to the 10 symptoms so that maximum number of the TB cases can be identified. It includes the cough, fever, night sweats, blood in the sputum, chest pain, shortness of the breath, weight loss, loss of the appetite, fatigueness, and swelling in the neck, plus if they are the symptoms of the other extrapulmonary TB. You can understand our national TB survey has shown that near about 40% of the tuberculosis were asymptomatic. They were not knowing their symptoms. So India has also included a strategy to find out the asymptomatic TB. As India is a big country and whole population cannot be covered, so we are doing asymptomatic TB in the vulnerable population. It includes the age more than 60 year, malnourished person where BMI is less than 80 kg per meter square, the diabetes, HIV, smokers, alcoholics, person with history of the tuberculosis in past, and when they are the household contacts of the active TB cases. This slide shows the development and evolution of the diagnostic technologies and the newer initiatives. I will not take you through this slide because this must have been discussed in the diagnostic presentation. So this slide shows a type of the tuberculosis based on the DST treatment and drug resistance testing, and on the right side you can see we had a national drug resistance survey where we wanted to have the position of the drug resistance across the India, and on the left hand side it is the programmatic data which is showing near about the 93% of the TB cases are the DSTB cases and near about the 7% are of the drug resistance TB cases. When we are going for the type of the drug resistance tuberculosis, we understand one category is the H monopoly. It includes when the resistance is to INH drug only, or there are the along with the INH drug resistance to other first line drug other than the rifampicin. MDR-TB cases become the special case when the resistance is to the INH plus rifampicin is occurring together, and it is a special case. We all understand all the RR cases, rifampicin resistant cases, when detected, they are considered as the MDR cases because rifampicin resistance alone is not occurring and it is very rare. So it is assumed that whenever RR is there, it needs to be considered as the MDR-TB cases. Pre-XDR includes other than the MDR resistance to fluoroquinolone drugs, and then when we are having this XDR-TB, it includes along with the pre-XDR resistance to more second line drugs which include the bedaquiline and the linezolid. This slide shows the evolution of the TB treatment and development of the TB treatment. When we all understand in the pre-93 era, the standard were non-standardized and there was quite a large variation in the public and private sectors. Monitoring was not proper. In 1993, WHO declared it as a global emergency, and we had piloting of the DOTS, directly observed treatment short course chemotherapy. In the late 90s, this DOTS was scaled up and we had a 3 category of the treatment, category 1, category 2 and category 3. From 2016 to 17, we focused on the daily dosage treatment, and you can understand why the daily doses were taken up by the program, because it was showing a modest but consistent better outcome as compared to the intermittent regimen. Intermittent regimen was difficult to implement and it was having more chances of the failure. There was a recommendation from the WHO also, which made that we followed up this taking up of the daily regimen, and currently we are using the FDCs for the treatment of the DSTB. This slide shows the what were the category 1, category 2 and category 3 treatment. Category 1 was the sputum positive new TB cases, plus we had the a severe extrapulmonary tuberculosis. It included 4 drugs for 2 months and then the 2 drugs for 4 months. In category T, it was retreatment challenges where the failure and the retreatment cases, loss to follow-up cases were there. It included, along with the 4 drug, the streptomycin was added for initial 2 months. For 1 month, it was 4 drug, and for next 5 months, it was the 3 drug combination which were given. And category 3 was the new cases where the sputum negative and the less severe extrapulmonary tuberculosis cases were there. For first 2 months, 3 drugs were given, and for next 4 months, the 2 drugs were given. When we had the MDR-TB management earlier, it was very difficult to manage the tuberculosis. You can understand that treatment duration was very long, and many times it was extended to up to 30 months or to the 36 months. The injections were being used. There were the severe toxicity. The success rate was very low, and adherence was also very poor. Now, this slide is showing our new integrated diagnostic and treatment algorithm, and this is the current one which we are using. And you can understand we are having 2 samples are to be taken, sputum samples or the samples from the TB, where 1 sample is to be sent for upfront net, and second sample is to be sent culture DST laboratory for LPA, which include the first line LPA and the second line LPA test, and for the culture based drug susceptibility testing. We all understand microscopy is nowadays is for follow-up, and for diagnosis it is rarely used, where in cases the upfront net testing may not be made available. On the basis of the net testing, there will be rifampicin resistance which is detected, and the report may be that rifampicin resistance is detected. So rifampicin resistance is not detected, takes us to the left arm of the right arm of the this algorithm, where we are having a treatment for the DSTB. Immediately we are starting the treatment for the DSTB, but simultaneously we are doing a test for the H resistance. When the H resistance is detected, we are giving the regimen for the H monopoly, and if it is not detected, we are continuing and completing the treatment for the DSTB. When rifampicin resistance is detected, it is to be considered the MDR-TB, and for the MDR-TB, first criteria to see what regimen is to be given is the age of the patient. When age is less than 14, and we have assess the person as per the inclusion-exclusion criteria, BPAL-M becomes the choice of the treatment. If BPAL-M is not given, then we have to assess patients for the shorter oral regimen, if patient may fit into the shorter oral regimen. And when the this BPAL-M and shorter oral regimen cannot be given, last option is the longer oral regimen, which is the last option, and all patient who are not fitting into the any regimen is to be provided this particular regimen. Now coming to a 6 to 9 month BPAL-M regimen, and you can understand this slide is showing the inclusion and exclusion criteria. Age is the first criteria. Next is the drug exposure. We are having 3 main drugs, the bedaquiline, predominant, and the linezolid. If exposure is more than 1 month of this drug, this BPAL-M cannot be given. BPAL-M still can be considered if a patient has taken drugs for more than 1 month and or even completed with these 3 drugs the full course previously. But we are having the drug susceptibility report, and DST is showing that all 3 drugs are sensitive. Then ECG is another criteria we have to consider, and the QTC interval is to be assessed after correction with the Frederick criteria. And you have to remember 2 figures. In male it is it should be less than 450 milliseconds, and in female it has to be less than 470 milliseconds. If it is more than that condition, you have to consider electrolyte level, and if serum electrolyte are imbalanced, you have to correct first and again do the ECG and assess. And if they are fitting, then the person may be given the BPAL-M regimen may be given. In pregnancy and lactating mother, this BPALM cannot be given, and there are some other exclusion criteria where if the liver function test is to be assessed, and you can understand if a liver function test is showing it is more than 3 times of upper limit of normal, it cannot be given. Other than this, you have to consider that disseminated TB and extrapulmonary tuberculosis, severe extrapulmonary tuberculosis are contraindication for this particular BPALM regimen. And in extrapulmonary tuberculosis and disseminated TB, you can understand it can be when more than one organ is involved, and miliary tuberculosis also type of the disseminated TB. Other conditions which you need to consider for the exclusion is the cardiac abnormalities, where the conduction abnormality and the severe other cardiac disease are there. Under those conditions also this regimen cannot be given. This particular slide is showing relative contraindications, where you have to consider if patient is having some drugs which are having some interactions with the BPALM drugs. Those drugs should not be given simultaneously, and they need to be stopped. And after their action is removed from the body, then only the BPALM is to be given. Then you have to consider the blood cytology also, where anemia, thrombocytopenia, and leukopenia is the conditions where you cannot give these conditions. There are having the number of the cells. If the level is beyond that, you cannot give. Kidney conditions is also one of the condition where you have to consider severity of the renal failure conditions. Under that conditions also it cannot be given. And if person is having already occurring the severe neuropathy or visual impairment, then also the patient cannot be given this particular treatment. We all understand BPALM, which is the 6 to 9 month regimen. Age is the only criteria where we can consider that BPALM cannot be given. But if you want to consider the dosage for all the weight bands, the dosage remains same, and this slide is showing what are the dosage of the bedaquiline, preterminate, linezolid, and moxifloxacin. There is another drug which is the pyridoxine, and it is given as a prophylaxis to the peripheral neuropathy, which is mainly due to the this linezolid, and it is given as per the body weight band. When it is less than 30, we are giving 50 milligram, and when it is more than 30 kg, the 100 mg of the pyridoxine is to be given. Another conditions when we are giving BPALM you need to consider is the follow-up, and for follow-up we have to see the clinical improvement, radiological improvement, and the microbiological improvement. Along with that, we need to do the follow-up for the visual impairment and the adverse drug reactions, where cardiotoxicity and other things are to be followed up. And you have to see the kidney assessment, pregnancy status also need to be assessed. The electrolyte are also to be done in the follow-up. When we are having culture as a follow-up, you can understand that in culture, if any culture for the sample which has been collected at the 4 month or later, and if they are coming positive, then patient need to be declared failure. And you can understand that 4 month culture report will be available by the time the patient must have completed the treatment. Still the report is to be declared as a failure, and patient need to be sent to the nodal DRTB centers for further assessment and exploring the next option of treatment. For this BPALM regimen, you need to understand that baseline DST. So sample is collected for the baseline DST, and it needs to be sent to the CDST lab. But we need not to wait for the report to start the treatment. Patient can be started the treatment immediately after assessing the inclusion-exclusion criteria and seeing the age of the patient. And when the report is coming, which comes near about after the 8 weeks, at that time, as per the report, patient need to be assessed at the nodal DRTB centers if they are the resistance to the main drugs like bedaquiline, preterminate, and linezolid, and then to be assessed for next eligible regimen as per our new treatment algorithm. How to manage the missed dosage? You need to consider that we have to make that adherence is very important factor, where all the drugs are to be given on the daily basis. The observations and supervision of the dosage is also very important. But when there might be still rare occasions when the dose may be missed, so how we have to make up the dosage? The number of the dosage are to be made by adding the same number of days, and same number of doses are to be given as are the missed doses. And there are the two important conditions you have to see in the missed doses. If patient has missed up to the dosage which is up to 2 weeks for the consecutive period, and missing doses are up to 2 weeks, then patient can be considered for continuous of the BPALM. Another condition is non-conjunctive cumulative period. If it is still up to the 4 weeks, then also patient can be considered for continuation of the BPALM. If it is more than 2 weeks of consecutive interruption and more than 4 weeks of non-consecutive intervention, this BPALM regimen cannot be given, and patient can be sent to the nodal DRTB center for assessment and further starting of the next regimen. Now coming to the regimen modification, so there are the two things in the modification of the regimen of the BPALM. Can we drop any medication of the BPALM regimen? So of the three critical medicine, bedaquiline, preterminate and this linezolid, we cannot drop them. Okay. Only moxifloxacin can be considered for dropping if there is the severe adverse drug reactions are there, but program is not giving dropping of the moxifloxacin if we are finding resistance, and there are the certain advantages where the relapses are less and having better outcomes when the moxifloxacin is compared and continued irrespective of the resistance. And there are the evidences for this also where in the literature from the TB practical regimen. Then after this dropping, we have to see the dose modification. Can we decrease the dose of any drug in the BPALM? So you can use the bedaquiline, protamine, linezolid and moxifloxacin. 4 drugs are there. Out of these 4 drugs, we cannot reduce the dose of 3 drugs, bedaquiline, protamine and moxifloxacin. We can consider a linezolid dose for reduction, but we have to see one point, that every person must take 600 milligram of the linezolid up to 9 weeks. If it cannot be tolerated up to 9 weeks, then we cannot continue this regimen, and patient to be sent to the nodal DRTB center for assessment and for further giving the next regimen. If person has taken 9 weeks of the 600 linezolid, and after that person is showing toxicity to the linezolid, in that condition you can understand that we can consider dose reduction, and dose reduction in that case will be 300 milligram. Now coming to the conditions, we understand that normal duration of the course of the BPALM regimen is the 26 weeks. It can be increased to 13 more weeks directly in 2 conditions only: when we are dropping moxifloxacin because of the severe toxicity, and when we are decreasing dose of the linezolid to 300 milligram after 9 weeks of the completion of the treatment with linezolid and having 600 milligram of the linezolid. So these are 2 conditions. We have to condition the peripheral neuropathy is one of the common side effects with the linezolid, and our experts has shown the grading of the tuberculosis. This table is showing some common symptoms which shows grading, how when you can think that it is grade 2, grade 1 or grade 3 and grade 4 of the severity. And experts has said that when you have to take the intervention to consider stopping or reducing the linezolid doses, grade 1 or grade 2. If grade 3 and grade 4 has occurred, it is very late and we cannot have the reversing of these adverse drug effects. This particular regimen is showing the shorter oral regimen, and you can understand we are having two options are there. In the both options we are having 4 month of the intensive phase and 5 month of the this continuation phase. In the continuation phase drugs are same, but in intensive phase A regimen is showing which is the newer regimen, some changes as compared to the B regimen, which is the older regimen. You can understand that in this. So new regimen we have replaced linezolid which need to be given for the 2 months, and earlier in older regimen it was the this ethionamide which were given, and we can understand ethionamide was teratogenic, it could not be given in the pregnancy, and this linezolid containing shorter oral regimen can be given in the pregnancy. Other benefit is we needed to have the baseline thyroid function test because ethionamide also affect the thyroid functioning. So these are the advantages with the new regimen where linezolid is there, it can be given in the pregnancy. And this slide is showing a dosage of the drugs for the shorter oral regimen, and you can understand the doses are as per the body weight of the patient. This is also when we are giving a shorter oral regimen which is the choice of the regimen for the persons who are having age less than 14, because in the less than 14 you cannot give the longer oral regimen. So this Beta-lactam cannot be given the persons having age less than 14. So when we are giving the linezolid in less than 14, we have to give the dosage as per the body weight, and this particular slide is showing a dosage of the linezolid when as per the body weight of the children who are having age less than 14 years. Next regimen, which is the longer oral regimen. So we all understand this regimen is eligible when the shorter and the Bipal regimen cannot be given. We are having 5 drugs are there. First drug is the Beta-lactam, which can be given for 6 months or the longer month, and then there are the levofloxacin, linezolid, clofazimine, the cyclosin, 4 drugs which need to be given for 18 or 20 months. We can understand we have to assess the patient at the 4 month and 5 month, and if the microscopy is showing smear positive, then the regimen can be increased maximum up to the 2 months. That is why the maximum duration for this treatment is the 20 months. This slide is showing dosage of the drugs, and right hand side table is showing as per the body weight of the patients the dosage of the drugs, how it is to be given. Left hand side table is showing the categorization of the this second line drugs, which include the category A and category B. Category A has the 3 drugs, category B is having the 4 drugs, and in standard longer oral regimen we have to include all the 5 drugs of the category A and B. When you cannot make the standard regimen from category A and B, category C drugs are to be given. The table is showing the sequence how replacement is to be done with the category C in case A and B cannot make the standard regimen. In India, we are using the separate sequencing for the category C of the replacement, which start with the dilaminid, amikacin, and the pyrazinamide, ethionamide, PAS, ethambutol, and the PNIMs are the drugs, which is shown as a red color in this slide. In H monopoly regimen, H is replaced by the levofloxacin, which is to be given by the 6 months. There are the conditions where persons may be increased duration from 6 to 9 months, include if person is having extensive pulmonary disease or uncontrolled comorbidity is there, or if we are having the severe form of the extrapulmonary tuberculosis, or if patient has smear is positive after the 4 months of the treatment. This slide is showing if along with the H there are the other drug resistance, how the patient is to be treated. So if levofloxacin or pyrazinamide cannot be used, we have to replace it with the linezolid. If linezolid also cannot be given, we can give both clofazimine and cycloserine are to be added. If both levofloxacin and the pyrazinamide cannot be given, what is the choice? So out of the 3 drugs which include the linezolid, clofazimine and the cycloserine, 2 drugs are to be added. whenever there is the rifampicin resistance is occurring in H monopoly cases, we have to treat as a MDR-TB cases as per our new algorithm. This particular slide is showing how to treat the MDR-TB in the pregnancy. So whenever pregnant ladies are having MDR-TB, we need to advocacy for termination of the pregnancy, and if they are willing and the MTP has been done, then the patient can be considered for the Beta-lactam or the 9-month shorter oral regimen or the longer oral regimen as per eligibility and exclusion and inclusion criteria using this our new algorithm. If patient is not willing to pregnancy, or if the duration of the pregnancy is 20 or more than 24 weeks, in those conditions the we may consider the shorter oral regimen, which has to be linezolid containing regimen, and if it cannot be given, then we have to consider for the longer oral regimen. For the children, we understand Beta-lactam cannot be given in less than 14. So in less than 14, we are having criteria where the different age groups are there. 5 to 14, where we can give the standard shorter oral regimen and the standard longer oral regimen. Because bedaquiline in India is available more than 5 years of age only, and it is not available for less than 5 years. In less than 5 years, so we have to, in shorter oral regimen, has to use the amikacin or kanamycin instead of the bedaquiline. You can understand initially the shorter oral regimen was having the injections, and these were the injections which were being given, and all oral shorter oral regimen came after the second stage. So you can understand it is the only regimen where we are giving in less than 5 years the injections are still being used for the treatment. Otherwise, no other regimen is using. In the longer regimen, still in less than 5 years, the bedaquiline is not available, and we have to replace it with the delaminase, the first choice for the replacement. You can understand, and if further changes are needed, then we have to use the sequence as it was discussed in the longer oral regimen. Other regimen where we are considering, you can understand, is we are having shorter regimens which was advocated by WHO based on the SCIENT trial. So it was considered by our national technical experts, and field feasibility, you can understand how to define the less severe disease and form of the less severe disease is very difficult. So it was considered that this cannot be started, and field feasibility was not possible. So this is one condition. HFMG also, it was showing more lapses and failure, and it was not having a fixed dose combinations. FDCs were not available, and these were some of reasons which were considered by the program. And BDLCC, the program is looking for the more substantial evidences, and you can understand at presently in India we are not implementing these regimens under the program. Now, another important aspect is that along with the anti-TB medicines, program is looking that we have to give the differentiated TB care. Before I go to the differentiated TB care aspect under the program, I will take through this mortality spectrum which is occurring because of tuberculosis in India. In India, we had a national this TB death survey was done. It was all mortality death survey done by Central TB Division and the PHFI, and it was a countrywide survey among the 10 larger states. It was done. You can understand near about 13.5% cases are dying, which were having tuberculosis before diagnosis. Near about 16% were dying after the diagnosis but before the start of the treatment. Then near about 5% after treatment they were started but they were lost to follow-up. The deaths were there. And you can say the 28% who were diagnosed are on treatment and or registered on the Nexus system, they were dying. And you will be amazing and shocked that near about 26% were on treatment but they were not registered on the Nexus. And then almost 13 or 12.5% deaths were occurring in the post-treatment. So you can understand, to reduce the mortality, we have to cover up all the aspects, and right hand side of the slide is showing different strategies where we need to focus, and one of them is the differentiated TB care. So in differentiated TB care, we are advocating if TB patients need to be assessed and triaging is to be done as per the criticality of the patient, and then we want to save life of the each person who is suffering from the tuberculosis, and we need to maintain the proper referral services, health infrastructure development. You can understand how we are advocating. So we are having level of the health facilities, and we are having the timing of the diagnosis. So level of health facilities, we are suggesting that not only at the health facility, but we want to have this differentiated TB care assessment and referral at the community level also, family level also. And then each type of the health facility, which include the sub-centers or the TB units, or we are having where we are having the medical officers like PHCs, CHCs, or the sub-district hospitals, district headquarter hospitals, or medical colleges and the tertiary level hospitals. Timing, you can understand, we are having the pre-diagnosis also, because whenever some presumed TB cases, if they are in the critical condition, they need to be referred to the right kind of facility, so that before diagnosis also these deaths may be decreased. And then we are having at the baseline and then during the follow-up. So the baseline assessment also we have to use, and then routinely follow up. We are advocating more frequent in the initial 2 months, because most of the deaths are occurring in initial 2 months after the treatment starting, and then after that we are advocating monthly assessment for this differentiated TB care. You can understand that for triaging for community level, we are keeping the easy criteria. We are given suggesting red flag criteria, and these red flag criteria are made in such a way which are including assessment of the common causes of the TB deaths. So you can understand that these are covering those, and if patient is confined to bed, if patient is showing respiratory symptoms like breathlessness is there, and we have to make them understand in the common language that breathlessness at rest, or if they cannot speak and complete the sentence with a single breath, or if they are not able to perform their daily routines like going to the toilet, washrooms, if there is severe pain in the chest or abdomen, or if there is the altered consciousness or disorientations are there, convulsions are there, weakness in the limbs are there, if patient is coughing out any amount of the blood, or if there is the recurrent vomiting and diarrhea, or if there are the symptoms of the adverse reactions. So we need to explain these red flag criteria to the community level. Further, at the health facility level, we are keeping the mandatory activities where assessment for the red flag criteria plus some blood testings, X-ray investigations are to be done. Then we are giving beyond this the suggestive list where assessment of the adverse drug reactions and other liver function and kidney function tests are to be done. And then we are giving the suggestions for the disciplinary activities where the health facility on basis of their expertise, clinician expertise, and the services available in the health facilities, they can, as per their own experience, include more investigations to assess the patient and see if patient is fitting into the differentiated TB care. Other important aspect is when we are considering the differentiated TB care is to consider that the after assessment, when patient is going to the health facility, we need to make and ensure the availability of the bed. If patient is needing admission, then the bed need to be made available. We are having over differentiated TB care guidelines has been available over this TBC India website, and you can go and details can be taken from those guidelines. And we are having newer version of the guidelines, so please see, there was the older version also, and we have removed that, and now it is the newer version of the differentiated TB care, which may be referred at the TBC India websites. When we are considering, so we are having certain aspects and considers for referral, like triaging is the first step. Then we have to refer each TB patient to the right kind of facility for further detailed examination and assessment. After that, we have to do the proper counseling, the proper management, stabilization of the patient is to be done, as per the seriousness of the patients. And after discharging the patient, at the time of discharge, we have to again motivate and do the proper counseling for further follow-up, and routinely doing this assessment for the different TB care and bringing back the TB patient if they are having some problem later. This slide is showing a diagrammatic representation of the different TB care which we have discussed. You can understand that every TB patient, after the assessment, they need to refer to the different kind of the health facility. After the assessment, the patient may be categorized into the serious and non-serious TB. Non-serious TB where patient does not need the admission, and after only day care or providing some supportive treatment and counseling, patient can be referred to the back to the home for a proper follow-up and the treatment. And the serious patients need to be given the admissions, and admission, after the admission establishing, patient can be discharged. We are expecting that every person should have the favorable outcome which is shown in the green box as a successful treatment. There might be still a certain evidences, and a few cases will be there where death may occur. On those cases, we are advocating to have the a death audit, where we want to have in the death audit there we are having the two component, TB verbal autopsy and social autopsy. TB verbal autopsy is giving insight into the standard of the treatment if there was some lacuna shortcoming in the standard of treatment, and social autopsy is giving insight into the this social determinants which might have led to the death of the TB patients, like patients dying in the home, why they did not come to the health facility, if some poverty was there, some other transportation issues were there, some other comorbid conditions were there. So those will lead into the some insight. And after having the proper insight of this TB verbal autopsy and social autopsy, further it will help out for further detection of the tuberculosis in the TB patients. So these were the some topics which I would like to highlight when I wanted to make the update on the treatment and the strategy which is being followed by the program. You can understand I was rushing through the slides, but topic was large and I wanted to complete each aspect of the this treatment update. I hope that I have made some topics made understandable, and some key message has been delivered to the audience. Thank you very much for giving me the opportunity to complete this presentation. Thank you.
The latest guidelines, these are all available on the Central TB Division website, and the scientific evidence that is left to these guidelines. Also put these into practice, and with this we can move. If there are any questions for Dr. Mattu, he's not here with us, but we can try to take those questions, or you could share the questions and we'll respond to them via email. We would now like to move to the next session. I request Dr. Tamanna to kindly introduce our next speaker, please.
I invite our next esteemed speaker, Dr. Nivedita Gupta, Scientist G and Head of the Communicable Disease Division of ICMR. Dr. Gupta is a distinguished expert in virology and emerging infectious diseases with extensive contributions to disease surveillance, outbreak management, respiratory and vector-borne diseases, and also vaccine research. She has authored over 140 peer-reviewed publications with significant citations and is a recipient of the IVS PGI Oration Award 2023, as well as a fellow of National Science Academies. We are honored to have her with us today. I now invite Dr. Gupta to kindly take the podium and share her valuable insights.
Thank you very much. And first of all, my heartfelt thank you to Dr. Urvashi and her entire team for organizing this very important webinar on World TB Day. I would just start sharing my screen. I hope my slides are visible.
Yes, ma'am.
We can see them.
Okay. So I'll just briefly take you through the new innovations in the space of TB diagnostics. Some of them are available in India, many of them are not available in India, but we as ICMR are committed to support the Central TB Division in the TB elimination program, and we are very actively scanning both the diagnostics available in country and globally, and trying to bring them into the country to support the TB elimination goal. So just quickly, we all know that there are different tests for different stages of TB. Latent TB, when we do not have any symptoms, we hugely rely on immunology-based tests. That is the tuberculin skin test as well as the interferon gamma release assays. For subclinical TB, where we have low bacterial load, imaging and molecular tests, imaging both chest X-ray, CT scan, and NAT tests are the mainstay of diagnosis. And for active TB, in addition to all the tests that we use in subclinical TB, we also use culture and smear as confirmatory tests. Now, there are a lot of emerging biomarker-based tests where we use RNA signatures, T-cell activation assays, and urine lamp tests to detect or do the risk stratification and progress the do the progression assessment of the TB disease. If we look at the holistic ecosystem for TB diagnostic tests that is now available and emerging, I'm not talking about the conventional tests, that is culture and smear positivity, but besides that, there is a lot of work going on in different spaces where definitely beyond the gene expert based molecular tests, we are also looking at the next generation sequencing based tests and detection of drug resistance markers in abundance. There are biomarker based tests, which are urine lamp tests, as well as blood based IGRA tests. Then also tests which rely on RNA as well as proteomics. Then the digital and AI based tools are also finding a lot of application in TB diagnosis. I would say not only TB diagnosis, but in all kinds of infectious disease diagnostics, wherein artificial intelligence based X-rays, cough AIs, as well as computer aided tools are finding a lot of application in the space of diagnostics, where particularly these can be very effective in low resource settings where the healthcare workers as well as the specialists are low in numbers. There are a lot of novel platforms as far as molecular tests are concerned. There are CRISPR-based tests that are now coming up. Biosensors are finding an application. And very interestingly, there are a lot of portable diagnostic tests, handheld devices, and point of care tests that are emerging as potential solutions. Then besides sputum, we all understand that sputum has its own limitations, wherein every patient is unable to produce sputum. And in pediatric TB patients, it becomes a huge limitation. So there is now a lot of interest in looking at urine and blood as viable samples for TB detection, oral swabs, tongue swabs, as well as, and they are all directed towards pediatric TB assessment primarily, though they do find a place in adult TB testing also, where sputum becomes a limitation. Then point of care devices definitely have a lot of interest, particularly with the changed or the revised program strategy of doing community screening and finding more and more TB patients from the community in addition to the healthcare setting. So that's where definitely point of care devices do have a need, and there is a lot of work going on and lot of active development of such devices. So once we have all these diagnostic tests within our, I would say, arsenal, we would be really able to augment a TB diagnosis. It would be very rapid. Early detection would really help us in early treatment and preventing the transmission of disease. Drug resistance detection also can be done using these newer tests that are emerging, and also access to care can be facilitated and fast-tracked, and definitely transmission is reduced. So coming to the cartridge-based tests, all of us are aware of it, and these kind of tests integrate sample processing, DNA extraction, and real-time PCR amplification into a single automated step. So the whole effort is to reduce the manual handling of the sample, to reduce the contamination, and also improve the integrity of the nucleic acid. So definitely this has a lot of advantages in terms of minimizing human errors. It is faster than conventional methods and minimizes exposure of the laboratory worker to the pathogens. But there are certain limitations of each of these tests. So definitely a reliable uninterrupted power supply is something which needs to be ensured even at the lowest level of healthcare where these machines are placed. These are single-use cartridges, and also I would say increase the reliance of the user on a single vendor or a manufacturer. So there are available tools in the system. Gene Expert is there, PathoDetect is there, and TrueNat is there. And there are other also newer technologies that are coming up from other companies based in India. So this was a recent addition which was validated by ICMR and recommended to program. That is the PathoDetect MTB RIF INH assay for detection of TB and MDR-TB together. This is a high throughput system where you can test 32 samples together along with drug resistance detection for both rifampicin and isoniazid. So it definitely offers an advantage of INH resistance detection as compared to the earlier versions of Gene Expert and TrueNat, where you could only detect rifampicin. And there's a room temperature reagent storage also, which gives a certain advantage. And also, as you see at the bottom of the slide, there are other global manufacturers who have made similar kind of diagnostic tests. There is a lot of emerging interest as far as open RT-PCR based technologies are concerned. And as I said in my previous slide, that the single closed system cartridge based test really increase the reliance of the user on the manufacturer. And and actually it also reduces a very healthy competition. So there is a lot of interest in looking at open RT-PCR based technologies wherein these kits can be used on any PCR machine and have a kind of the same turnaround time and also cheaper because the cost of machine and single-use cartridge is also not adding to the cost here. So definitely these systems have advantages in terms of flexibility, they are cost effective, and they are also suitable for high throughput screening. But at the same time, there is a limitation that since there is manual handling to a certain extent, there is a possibility of cross-contamination, and you really need a very well-trained laboratory staff to conduct these kind of tests. So there is an advantage in terms of cost and flexibility, but limitation is that you really need very skilled workforce to avoid cross-contamination so that the positive control is not mixed with the patient samples and you start getting false positive results. So there are issues in terms of training, but this is a very viable option. ICMR has already validated 2 of the open system PCR tests, and they have been recommended to the Central TB Division. And definitely there are efforts to understand and try to place them at an appropriate level of healthcare under the TB program. There are many others in the pipeline and they are under validation. So this is one assay which we validated, the first one, wherein we could see that this assay had 86% sensitivity and 96% specificity when compared to the gold standard culture. And it is indigenous, low cost, and there is a 2-step quick lysis method for DNA extraction, which is inbuilt with the test. Now, the other very important technology that is finding lot of interest in the TB program, and I would say globally, is targeted next generation sequencing. And this is a technique which enables rapid and comprehensive detection and drug resistance profiling. So far we are just focused on looking for drug resistance for rifampicin, isoniazid, and now fluoroquinolones. But this targeted NGS really gives us a capacity to scan the MTB genome and look for all kinds of resistance markers which already are emerging as a threat or can become a future threat. This particular technology has high sensitivity and specificity up to 99%. It is able to detect even low frequency variants. That is really a very huge advantage. So something which is hiding in the sample, we can also pick it up and detect it very timely. Heteroresistance detection is also a possibility that we can detect from this system. It has a much faster turnaround when you compare to culture. We are able to also do a high throughput up to 96 samples in a single run. And the more number of samples you do in a single go, the more cost effective this technology becomes. And as I said, there is a broad drug resistance coverage in terms of multiple drug resistance genes. And you can keep on adding and tweaking this technology as per the requirements. It can be done on sputum and quick DNA extraction, then target amplification, preparation of a library, sequencing. But at the same time, this is a very high-end technology where you really need a very strong bioinformatics team. Unless you have a good bioinformatics analytical team, the sequences that you get and the correct interpretation out of it becomes extremely difficult. So this is an essential component. Besides sequencing, you really, NGS machine, really need a very strong bioinformatics team. So the key applications of this technology, very promising technology, is that you can preemptively detect MDR, XDR, TB. Treatment decision support can be guided by this technology. And you are also able to resolve the discrepant results that you get from different platforms in use. And WHO recommends use of this targeted NGS for drug-resistant TB and reference labs. They should definitely have this. But as I said, there are limitations. It requires an NGS platform and bioinformatics skills. It is definitely much more expensive currently as compared to the traditional NATs and NPA. And panel of mutations is currently restricted to the known mutations. But as our systems evolve, there is definitely a possibility of improving the number of genes that are detected. And by supplementing it with whole genome sequencing, we can also use this technology for detecting whole genome sequencing. We can use for detecting the evolving mutations and then plug this particular platform to also look for those evolving mutations. So it has a scope for even detecting the evolving mutations once it is aligned with the whole genome sequencing. So this is promising, but very expensive. And we are also setting up validation of this technology within our country, validation centers. But we hope that as the use of this technology improves, the cost will also eventually come down. So there are a lot of available tools in our country. As I said earlier, I would not go into the names of each, but there are a couple of these which are used on different NGS platforms, some on Nanopore, some on Illumina, some on Iron Torrent. And we are trying to develop validation protocols for different kinds of targeted NGS-based tests and the platforms used. So this is currently work in progress for us. The other very important technology that is finding application is the LAMP, loop mediated isothermal amplification based assays. These are the main reason for interest in LAMP based assays are that they do not require a thermal cycling machine and have the potential to be introduced as point of care tests. So definitely PCR as well as LAMP assays can be introduced at different levels of healthcare. This can be point of care, community, or near point of care tests for community level screening, whereas PCR based tests only have to be done in a specialized laboratory setup. So there is already a WHO recommendation that this should be used as a replacement test for sputum smear microscopy to diagnose pulmonary TB in adults with signs and symptoms consistent with TB. So there are a lot of advantages of this particular LAMP assays. They have a high sensitivity. They have a very high turnaround time. 30 minutes, you can really have your test result in front of your eyes. And there is a minimal requirement of laboratory infrastructure, and there is no temperature variation required for getting your results. But there are limitations in terms of TB LAMP assays do not provide information on resistance to antibiotics. So you can only do TB detection, whereas drug resistance detection is a challenge by using TB LAMP assays. There are already available tools in India, which we have validated and hope that they will find a place somewhere in the community level screening where the TB positives which are detected can further be screened for drug resistance markers. There are others also in development in our country by different companies. And this is one example of a palm top device which we validated at ICMR. And we compared the tongue swab with the sputum results, and culture was the gold standard here. And we could see that this particular test had a 68% sensitivity with respect to sputum culture when we talk about a tongue swab, and 71% concordance with the NAT test. Specificity was close to 95%, and this test was very much matching the criteria which have been laid down by WHO for non-sputum based tests. So we also recommended this particular test for use in particularly in pediatric population. But now we are looking at expanded bridging validations for this particular test, wherein we also look at pediatric population, immunocompromised people, and increase our ambit so that this test can be very well included in the program. There are also a lot of tests which are coming for detection of latent TB, which we all are aware, and this has been a major challenge, finding an accurate test for detection of latent TB. And conventionally, the tuberculin skin test, TST, has been used, which is read in 48 to 72 hours. And this has been widely accepted due to its advantages of having a low cost and wider availability. But it has a lot of limitations in terms of the number of false positives, and it requires 2 visits, one for injecting and the other for reading. The interferon gamma release assays, the IGRA-based tests, have really provided an advantage in terms of high specificity, no interference with BCG, and this test can be interpreted in a single visit. So they have advantages over the conventional TST, but there are limitations in terms of higher cost and requirement of a specialized laboratory structure for conducting and reading this test. And there are a lot of emerging tests and a lot of work which is going on in this particular area, where people are looking at host biomarker-based tests, wherein you look at blood RNA signatures and also predict the risk of progression. There are T-cell activation assays, but they can differentiate between latent versus active TB. But again, you require a flow cytometry-based laboratory setup for conducting this test. Then novel skin tests, which are based on biomarkers, and the CYTB test, which has been recently adopted by the program, which is based on the ESAT marker, is also a promising technique. Now, the key points here are that there are no direct tests which detect dormant bacteria, and diagnosis primarily relies on the immune response. IGRA is preferred in BCG vaccinated populations like ours, but TST still remains important because we also are a resource limited country. So both do find a place, but definitely IGRA-like tests are much more preferred if we have the adequate laboratory setup and the potential to bear the costs. There are, as I said in my earlier slide, that this is a huge area of interest and lot of work is going on globally to look at host biomarkers, the role of host biomarkers in TB diagnosis. And you can see in this slide that there are an array of biomarkers which are based on exosomes, metabolites, chemokines and cytokines, genetic biomarkers, protein biomarkers, RNA biomarkers, and all of these are being reviewed and being researched by different people in the world to see, and definitely all of them have shown some promise in serving as biomarker based tests for TB diagnosis, but validation and clinical utility of these biomarkers is also an active area of interest. And particularly these tests can differentiate between active TB, latent TB, as well as they also are able to differentiate. They are sex specific diagnosis can also be obtained by use of these biomarkers. You can identify the immunosuppressed state, and also treatment monitoring is an area where these biomarkers are being seen as a very useful tool. And microRNAs, long coding RNAs, as well as circular RNAs are the primary targets here, wherein a lot of interest, global interest is there, and people are trying to find a place for these biomarkers in TB diagnosis. As I said earlier, digital tools also have a lot of potential and promise for the TB program in terms of computer-aided detection of TB on chest radiography, cuff-based applications, point-of-care ultrasounds, particularly for extrapulmonary TB, digital stethoscopes, and biomarkers I already spoke about. So these are other promising tools which are there. And most of you would be aware that ICMR did validate ultra-portable handheld X-ray devices and recommended them to the program. And I'm very pleased to say that they have been widely adopted in the program. And there are 4 of them which we validated and recommended, and another pipeline is there under validation. They really improve the ability to go to the community, screen them actively for TB. And also, in addition to this, ICMR was able to work with Plasma Institute, Institute of Plasma Research at Gandhinagar, and develop a AI-based chest X-ray tool, wherein the handheld X-ray, whatever images are generated, can be read by this tool and classified as abnormal and normal based on the chest X-ray film. And further, the abnormal X-rays can be taken up for screening for TB. And this tool is undergoing refinement to further classify abnormal X-rays as TB or non-TB. But as you all understand, this is a tricky one because you need a very standard and well-characterized data set for training this AI tool. And currently this work is ongoing. There is also interest in CRISPR-based assays for TB diagnosis. And definitely the advantage of CRISPR is over the conventional NAT test is that it is much faster as compared to our NATs which we are using in the program, and the cost is low, and this again can be supported by very portable and adaptable systems. And there is a fluorescence-based signal on which you are able to detect. And CRISPR-based technologies also have the advantage of not only incorporating the TB detection part, but also the drug resistance detection part. This is also an emerging area of interest, wherein stool-based tests for TB detection really need to be standardized. There are protocols for stool-based testing, but we need to validate them and standardize them on our current NAT systems, that is GeneXpert and TrueNAT. And this will definitely be a non-invasive, low cost, and very useful method for children. But there are challenges in terms of sample variability. There is a risk of contamination and growth of other pathogens if we are not collecting, storing, and transporting stringently. The sensitivity is also low, so definitely methods of enrichment and improving the sensitivity have to be undertaken. But this is one promising method which really offers an advantage of improving TB detection if we are able to standardize it and introduce it into the program. Then again, so far, we have been using LAM-based urine tests for detection of TB in HIV positive individuals. But there are recent global efforts to also use this test for detecting tubercle bacilli in even HIV negative TB patients. And there is a technology wherein by using a nano cage and a LAM binding bait, the concentration of LAM in this nano cage can be improved by using a urine sample, and you can get a reliable positive result even in HIV negative TB patients. So this is also a promising technology which will definitely come into the arena in some time. There is also a very promising blood-based test, which is a lateral flow point-of-care TB triage test. It's a rapid antibody test. It detects TB-specific antibodies, and it overcomes the limitations of use of serum-based tests, due to which the CDSO in India had banned the use of serum-based tests in India. And this is a single finger prick assay. And there has been some work which this particular company has been doing with ICMR, but we are committed to fast track and look at the utility of this particular test for incorporation into the program. It's a 20-minute test, no lab required. It's low cost as well as minimal training is required. So this is something which is of interest and needs to be explored. I would end by saying that we organized a TB Innovation Summit in last year in March only, wherein we also had a unique experiential walkthrough, wherein there were a lot of exhibitions. 217 innovations were showcased under different categories of detect, treat, prevent, and build. And you would see in the detect category, which was mainly focused on diagnostics, we had 71 different innovations which were showcased, and we have reviewed all of them, and we are trying to take the promising ones ahead by giving them whatever they require or facilitating them in terms of their requirements. And lastly, to inform the esteemed attendees here that ICMR has now established a TB Research Accelerator program. And our goal in this TB Research Accelerator, this is a dedicated program within ICMR, wherein we are committed to integrate all the research and development efforts ongoing in TB in India and accelerate their translation, along with building very strong and well-aligned partnerships in TB research. And these are the domains of the TB Accelerator. There is a dedicated funding which has been put in by ICMR, and this has been launched with effect from February 2025, and we will be able to fund a lot of promising innovations starting from April 2026. So that's all from my side, and thank you very much for the patient listening.
I think I was mute. Dr. Nivedita, if we still have you.
Yes, I'm there, Dr. Bashir.
Yeah. So the question that one of the participants is asking on the YouTube live is that TB screening digitally will be a key for fast-track population screening. He says, can we get an idea of the cost of the CRISPR test?
So as per my understanding, the cost of the CRISPR test will be close to it will be less than 200 rupees, maybe 100 rupees in future, because one of the ICMR institutes already is developing a CRISPR based assay, and it will be very, very cheap. But also, we all need to understand that the cost of a test depends upon the demand of the test. So more the demand, lesser is the cost. So they are also inversely related, and that we really need to keep in mind. Thank you.
Thank you again, Dr. Nivedita, for the wonderful talk and for joining us. With that, I think we'll close this session because we're running late, and the next speaker has to rush to another meeting. So we'll move on to the vaccine session. So I request Dr. Nitya to please introduce the next speaker.
I would like to extend my welcome to our next speaker, Dr. Harish Iyer. He is the Director, Digital Innovations, Health R&D, AI, Gates Foundation, India Country Office. He showed his support in development of pediatric combination vaccines and has contributed significantly in open source TB test development with use of digital tools to understand TB patients' journey, including use of AI in development of tools to triage X-ray images. I invite Dr. Harish Iyer to share his insights on TB vaccines pipeline update.
Sorry, I'm not able to switch it on, but maybe I'll continue and find a way to switch it on later on.
Please continue.
Yeah, thank you. So as you can see, this is the TB vaccine pipeline from the Stop TB partnership. There are many vaccines here, and I'll talk about some of them, but clearly there is not enough in phase 1 and phase 2. Normally, the way it would work is that you have a lot of vaccines in phase 1, we'll have a fewer in phase 2, and sort of finally a small amount. So this reflects a serious problem for us from a vaccine perspective. And I'll try and talk about towards the end of my talk, the challenges in developing a TB vaccine, which are quite well known, but I'll sort of make sure that we have some path forward because you also want to talk about opportunities here. So you would have all heard this well, the TB natural history and the clinical trial approaches. On the left-hand side, you have the bacterial burden over time. You have the prevention of infection vaccine, which is BCG, H4IC31. The prevention of disease vaccine, which I'll talk about a little bit with M72. And then, of course, there are ideas around possibly therapeutic vaccines or prevention of reinfection, recurrence vaccine. So this is just to give you a quick snapshot. Most of what I'll talk about is POD, this is prevention of disease. And I'll talk a little bit about one slide on the result on the prevention of recurrent infection, recurrence of the vaccine. What is the major goal of most of this work is to find a way to prevent pulmonary TB in adolescents and young adults who are the key, because this age group is the main source of TB transmission. And you have below a graph of estimates of TB incidents disaggregated by groups. And you can see it also all spikes around 15 to 34. So, youngish people who've got TB. What are the major challenges of TB development? I'll come back to it back and forth through the course of this conversation. There's a limited understanding of the mechanism of protection and the protective antigens. As you can see from the picture on the right, the organism is inside a granuloma surrounded by lots of immune type cells. It's a very, very clever organism that's evolved with humanity for a long, long time. It's able to trick the immune system to be comfortable with you. In fact, if you are a perfectly healthy person, you may be actually okay. Nothing might actually happen to you. It's only when you run into other risk factors such as malnutrition and so on that this thing gets activated quite significantly. So that's one big challenge. There's no correlate of protection for vaccine-induced prevention of disease. Everyone will remember how COVID, we could develop so many vaccines. Why have we not able to develop vaccines for TB? Because, of course, correlates of protection are a big challenge, and I will come back to that. Equally, no animal model seems to predict TB disease well in people, and we'll come back to why that we believe is also the case. Some thoughts around that. But, again, unlike flu, influenza, where there are pretty good correlates, good animal models, you almost don't even need to go into humans before you can get a flu vaccine out every year. Very, very dramatically different sort of species and pathogens. The other thing is the TB itself has a very low rate of progression from infection to disease. So between POI and POD, there's between infection and disease, there's a long period of time. It's a very low number, and you will see that in some of the phase 2 results that I'll show. So it takes a long time to record enough cases, large number N. That makes all these trials quite expensive. And so exactly the point, large clinical endpoint trials, unlike HIV and flu, there is no significant quote unquote dual market. Therefore, the incentive to fund such vaccine development becomes lower and lower, certainly in the high income countries, and which essentially says we have to do much more of it in the low income world. So very quickly, epidemiology in terms of vaccine development. More than 10 million people fell ill with TB in 2024. You would have heard it throughout the day. Over 1.2 million died. Approximately 5% of infected people develop TB disease within 3 years of infection. So small number of people developing, but given the large denominator, a lot of people are unfortunately dying. And why do people progress to develop infection? Some of the causes I've put on the right hand side of the chart. We know this well: undernutrition, TB, HIV infection, smoking, alcohol use disorder, of course poverty. It's a classic disease of the poor, so significant problem. Some of this you will reduce just by reducing poverty. So poverty elimination has got so many additional benefits, including better nutrition, better housing, and so on and so forth. So very, very critical to understand this as the underlying social causes and social determinants of progression in TB. So in 2025, 2 important phase 2b trials were published, and there was one phase 3 trial that was not published yet. I'll briefly go through these 3 quickly with all of you. The first is the BCG revaccination of IGRA negative, HIV negative adolescents, and to see if people did not convert to IGRA positive. So you can see from this slide that the 2 curves of BCG and placebo sort of follow each other very, very closely. Not significant difference between both. In fact, arguably there was slightly higher conversion in the BCG vaccine arm, but very, very close and not statistically significant. So clearly, if you're IGRA negative, you do not prevent yourself being converted, and the conversion is assumed to be assume that you've gotten infected in some way with the BCG. If you look at the H56 IC31 study to look at reducing the rate of TB disease recurrence, this is a recurrent study in HIV negative adults. You can see it's a bit more risky, in terms of TB vaccine development. You can see that the cumulative probability of people who were on the test arm, the number of events is actually more than that of the placebo arm. So this also makes you worried that, hopefully will not cause any harm. So extra caution is required for how these vaccines are tested. Obviously, this is a trial, it's double-blind trial. We have to try everything we can. This is also elicits, clearly points out some of the risks in developing TB vaccine. The phase 3 trial that's not yet been published is the VPM 100 trial. This was a study that was sponsored by ICMR. Thanks to Dr. Nivedita, who is also, I believe, online and gave a great talk before. This is trying to understand, could a vaccine that is somewhat analogous to BCG but a modified version of it, can it prevent TB in healthy household contacts of newly diagnosed smear positive pulmonary TB patients? The primary endpoint indicated a vaccine efficacy of 16.97%, not statistically significant. And so there was recently an expert committee at the DCGI where they had a post-hoc analysis. They looked at the secondary endpoints of the youngest age stratum. Does it make a difference? And I think they finally concluded that that serum would have to probably do an additional study based on the secondary outcome. So I think this story is probably still open. We'll have to figure out where this story moves forward. I'll talk a little bit about the phase 3 trial. This is a product M72ASO1, which is with GMRI, the Gates Medical Research Institute, working closely with GSK and the Gates Foundation in terms of a completely new vaccine. But this is a recombinant fusion protein vaccine. It's not a whole cell inactivated or weakened attenuated whole cell vaccine. It is looking at 2 different antigens, MTB32A and MTB 39A, 2 different TB associated factors, and a complex adjuvant system called ASO1. This is a GSK proprietary adjuvant system. And this in the phase 2B trial that was published recently showed that there was roughly 50 to 55% efficacy over 36 months for the M72 vaccine. But if you look at the left axis, this again shows one of the problems we have over 3 years from, probability of 1 to 0.98. So, small number of events, it takes a long time to show the curves diverging in a statistically significant way. So important to keep in mind, but this is the best at this point that we have that's on the front line, and that's currently in phase 3. The additional challenge is, how do we interpret the results? You can see on the M72 paper, there were multiple definitions of what would consider progression to TB infection. And you can see that there are two different definitions that I've highlighted on the top of this line. Is there a single positive sputum test, or are there two positive sputum tests? It's kind of interesting. If you look at it, it looks like it's 50% efficacy if you only had one positive sputum test. If you had two positive sputum tests, it was 68%. So very tricky in terms of how one interprets this, and you can have multiple sorts of definitions and what your definition means. On the phase 3 trial, we have taken the most stringent case definition of greater than or equal to 2 positive sputum tests, which means, of course, these things are quite close to the border. You want to really nail it in terms of what you think is the most likely protection number. So in the ongoing phase 3 trial, I will add that I've laid out the assumptions here. 20,000 subjects in a 1-to-1 randomized placebo-controlled double-blind trial. 2 doses of the investigational product, both given intramuscular 1 month apart, and correlates of protection. This, I will come back to this correlates of protection question, really trying to understand what are the correlates of protection. That's a key aspect of the study, which caused it to be quite expensive. The primary endpoint analysis occurs once 110 cases of lab-confirmed TB are observed, greater than 90% powering to demonstrate a vaccine efficacy of 55%. So this is the basics of the study. In terms of the 20,000 subjects, on the right, you can see how they are split up. Mostly an IGRA positive cohort, mostly HIV negative. There is a small IGRA negative cohort as well as part of the study. Where are the sites? The sites are in Indonesia, Kenya, Malawi, South Africa, and Zambia. 20,000 participants in 13 months, already completed enrollment, rapid enrollment, lots of interest in this participating in the study. More than a year back, the enrollment has been complete. We expect, so I'll just jump to the quick next slide. Lots of different things are being measured in blood samples. Going back to the correlates question, right? We want to understand, what's the T cell picture, what is the cytokine picture, what is the expression picture of mRNA in a lot of these samples that we are getting from patients, ultimately hoping to find correlates of protection between efficacy. Hopefully we will get greater than 50% efficacy, and also what can we pull out from that. So again, this slide reflects the many assays that have been built up as part of the study. It's a lot, and you can please go through the slides in the papers. I've referred to all the papers at the bottom of this slide, and you can take a look at them to see what else is being measured. I want to talk about MTB vac. So moving to a different vaccine. This is a live attenuated MTB that's being used. This is actually, unlike BCG, this is a human strain that's been slightly modified, and you can see from the picture on the left, this is between BioFabry, which is a Spanish company, and Bharat Biotech, and I think ICMR is also involved in one of their studies, in a phase 2A study. Today, the big main study is PO Prevention of Disease study, which is actively recruiting. This is clinical trial sponsor is IAVI, and most of this work, I think, is happening in Africa. But you also have Bharat involved in a phase 2B study looking at 4,300 IGRA positive. So this is a vaccine that BioFabry has set up a collaboration with Bharat to co-develop. And I think the idea is for us to make sure that we have good access to a vaccine like this if there is a positive result here. The primary endpoint in IGRA positive subjects is bacteriologically confirmed pulmonary TB in IGRA positive patients from a intent to treat population. And the primary vaccine endpoint here that's been assumed is 65%. And the primary efficacy analysis likely in 2028. Just for the sake of the audience, I've sort of put on the right how MTB vac differs from BCG and how it's been developed. MTB vac, this phase 2A trial is also going on in patients living with HIV. Again, a different study, which is sort of more for the HIV positive. And of course, as I mentioned, product development in India with Bharat Biotech on the bottom. Just quickly on the table on the right, how does MTB vac differ from M72? Routes of administration, the kinds of doses, what we expect immune response to look like, and whether it mimics infection or not. But just because we say it mimics infection, there are still additional challenges. We know that we'll have to figure out once the results come out what we see in these results. So what are characteristics of promising vaccine antigens and vaccines? One is a critical one. This is the paradox of MTB. There's usually a massive cell response and often non-specific T cell response. And we don't know which specific T cells are protective. And this has been a big challenge. And that's the reason I think the models often take us to the wrong place. So we do need to look at what is protective and essential for MTB, right? We often find immunodominant antigens being expressed. Immune system reacts to the immunodominant antigens, but they don't necessarily result in protection in humans. This is our current best understanding, current theory certainly. So it has to be conserved. A promising antigen vaccine has to be conserved across relevant MTB lineages, limited cross-reactivity with commensal bacteria and host cell. Obviously, it has to have tolerance. And so this is again going back to what we're trying to understand in the M72 world, understanding the kind of responses you're getting, inflammation. So will be if M72 works, it's a great opportunity for us to study this much, much better. So what are the kinds of, what does the immune system actually target, right? It targets typically the secretion system, which is basically what the bacterium secretes into your into the human being. So it's not a complete surprise. Obviously, this is what you'd expect. Therefore, immunogenicity doesn't equate to protective mechanism. We need to find additional different antigens that can be picked, which are not specifically what MTB is throwing into the body. MTB obviously, again, making it somewhat anthropomorphizing MTB here, the TB antigen here, the organism here, it's evolved, it knows that the human will act against it, so it's trying to decoy and find ways of avoiding, getting shut down. And it's comfortable if you're well, you have good nutrition, you don't have HIV and other risk factors, you could go for a long time without developing the disease. So under this criterion of looking at essential factors, you can see on the bottom left, I have put down some of those essential factors which we think may be critical. There are some vaccines in the phase 1. So this is a BioNTech vaccine, which is in phase 1A, which has got 8 MTB antigens, but presented in the form of 4 mRNAs. You can see the construct on the right. And there are 2 RNA platforms being tried. There's a modified RNA and an unmodified RNA. In my mind, this sort of tells you how little we know about what sort of parts of the immune system are involved in this response, that we have to try both modified and unmodified. 3 doses of IP, and this is an ongoing phase 1A in South Africa and Mozambique. There's a Staten Serum Institute vaccine as well. This is a protein-based vaccine. Again, similar MTB-specific antigens, not shared with BCG, possibly increased TCR repertoire, and expressed in Ecology. So this is a protein vaccine. The previous one was an mRNA vaccine, so it's a different one. But they've also added adjuvants to see how the adjuvants can play a part in improving the robust response based on results people have seen in the non-human primates. So this is a quick snapshot of that. In India, there is a couple of different programs. One which we are briefly working with CCMB in Hyderabad, looking at 8 humanized MTB antigens in mRNA and in the encapsulated in the LNP. This is very early work. LNP optimization is going on. T-cell assays are being optimized. And again, TB talent studies are being planned in animal models. There's the Genova TB vaccine program, which is also in very early stage. These antigens are also picked up from low dose challenges in mouse models, but with the caveat that it's not clear if mouse models are truly indicative of protection. We'll have to understand that better. Will they do something better than BCG? These are meant to be, these exceed in quotes BCG protection in multiple mouse models. We don't exactly know what that means. Again, I'm just wanting to be cautious in these cases. So our sense is we may have to move beyond immunodominance, and I'm happy to talk about that at some future point, basically leveraging human TCR based correlates of protection. What does human protection truly mean? So humans being protected from infection may give us insights into how what could be protective from the antigen perspective, and I won't talk about it too much today. So what is the major challenge? And this is the last but second slide. The central bottleneck for us is the absence of immune correlates. So any study we do in TB, it will be great to understand better what are the immune correlates. I showed you a smorgasbord of correlates that we are trying to measure in M72, which makes it very challenging. You need to develop a lot of assays to be able to do that. So this is critical, and therefore we don't have, that's why your phase 1 looks so dismal. It doesn't look good enough as a strong pipeline. So we need to have a paradigm shift to maybe an accelerated COP driven trial. So this is just one suggestion that we should think about as we look at new vaccines. And of course, a large number of patients. I love the idea that ICMR has had about looking at household contacts. Are they high risk patients? If they get protected, would we do well? So there's a lot of interesting ideas that we are working on in India that ICMR is working on. So very excited to continue to do that. The key take home messages for me, this is my last slide. Prevention of disease vaccine for adults key, anticipated to play an important role. 2 late stage POD vaccine efficacy trials are expected to read out in 2028. So that's the thing we can look forward to. But in terms of preferred characteristics, today M72 is the only one that seems to have had the results we want in a phase 2B. Clearly, the early clinical pipeline needs additional investigation vaccines to ensure that a safe and effective TB vaccine becomes available and accessible. Thank you very much, Chair, for the opportunity to speak.
Ma'am, we could not hear you. I think you are muted.
I'm so sorry. Yeah. I was saying no questions in the Zoom and the YouTube, but if I may add 1 or 2 aspects to what you covered earlier, Dr. Harish. The trial published in NEJM from South Africa enrolled patients who were IGRA negative in a high burden setting. So IGRA and the other currently available tests for infection are, as you're aware, very poor. I mean, not a good sensitivity, doesn't even meet the TPP. So they would obviously miss out a good number of patients who are infected but not IGRA positive. So the point I'm trying to make is that in a high burden setting, to do a POI will be tricky. So you've already dealt with several aspects of this, and in fact, I was able to publish a response to that article in NEJM. Coming to the trial, you mentioned that the ICMR is conducting. It is now accepted and will soon be online in BMJ, the BMJ. And this was actually envisaged in my office. We were discussing how to carry out a trial with the vaccines available in India. So we laid out a plan to have we plan to have 3 vaccines, and then incidentally, the 4 vaccine could not be taken on board, so we did with 2. And you've already said that there was this meeting, the EPTAGI meeting, where results, and the CDSCO meeting as well, the CGI meeting. The results will soon be available for all to read, but then possibly we may plan another trial going forward using the VPM. You also mentioned about, you mentioned about the interpretation of the data. In fact, we had Dr. Manjula Singh was to talk on the Prevent TB trial, but she's not well. She's had an injury, so she's excusing herself. So, one question for you. The talk was, in fact, covered all the basic aspects as well, the basic science aspects. So it was a wonderful talk. Thank you so much for that. What bothers us is, in fact, my talk, which I will see if there's time, which actually talks about, the journey from innovation to elimination. And what always bothers the experts, I'm sure, including you, is the time taken from once we have the proof of concept, the validations are there, the time it takes to reach those who need it. So, it's a tricky question, I know, for you. But then it really concerns us. We know 3 vaccines which are doing, I say 3, because I also want to bring in the GAM-TB, where the phase 3 trial is running in Russia. So these 3 vaccines which have promising results on phase 2B and are currently in phase 3, what is the window you think it would take for, the high burden settings, at least to begin with, to have at least one of these vaccines made available? For example, I would say for India, for example.
Thank you, ma'am. I think you raised many very important points. I think a key aspect of us to have a platform. One idea would be, have a platform where multiple, and now I'm talking from India perspective, bring in multiple vaccines. And I think the Gates Foundation can certainly think about how we can support the government and the TB division and the researchers in India on, and of course the patient community. Let's not forget, the most important is the patient community. It's been painful to listen to all the talks, right? So many patients are going through so much suffering as a result. So they are foremost in all our minds. I think would love to figure out how we could work together with you. We're trying very hard to bring M72 into India in an acceptable way. Most importantly, is in an acceptable way, not Indian patients as just subjects, but actively India owning that vaccine. So that is a big negotiation that we're doing internally, and we want to ensure that India gets access. But even the newer vaccines, ma'am, this is about, and you would have seen that we have actually supported CCMB to develop some of their the new vaccines. We are working with Genova to see what we can do with Genova, but certainly the BioNTech vaccine as well. How can we bring more of these platforms and then accelerate? I think your main point is about how do we accelerate?
Absolutely.
And the accelerate question is the right design, the platform where we can, this is a country level conversation. Obviously, I can make some suggestions here, but country level conversation. Do we have a platform like Intent or other platforms where you can get to try either medicines combinations or vaccine combinations? I know that there is a meeting in April that I think it's in April or that's around.
Yeah, we'll move to 18th April.
Yes, 18th April. So I think, ma'am, that's a great opportunity that we have to, in order for patients, in service of the patients, we need to really discuss how can we do it much more, strengthen the labs, strengthen the clinical trial networks, and continue to pull in. And whenever people have ideas, this translation question, I think the clinicians are ready, ma'am. My sense is the clinicians are ready, We are all waiting for these new vaccines to come, but the funding and the correlates of protection, which was one challenge I will mention. But if there are cleverer ways, we should, in my mind, show the world how we could think outside the box and accelerate. So I think it will be a joint conversation. Happy to participate in it. I think that's going to be the key. What would India do differently? We don't have to necessarily go by what the world is doing. We can do things differently. I mean, we saw that in the vaccines you've tested in India, you know, the VPM and so on. So this whole quick accrual of endpoints and how do we read it out quickly? But now you're saying, where are the other vaccines? What are the future vaccines? The pipeline, where is the pipeline is also your question. Your question is, how do we do it quickly, but where is the pipeline? Happy to talk to you, ma'am, separately and figure out what ideas you have. And, you know, the broader community, of course, you know, participating, will be happy to do that for sure.
So with this, thank you so much for sparing the time to address, you know, be part of this webinar and sharing your thoughts and for the beautiful talk.
Thank you so much, Dr.
Thank you. Bye-bye. So with this, we can move on to the next session. Oh, I would like to briefly, so the next talk was meant to be by Dr. Veena Dhawan. You know, I wanted her to cover on the BCG revaccination trial that the program did. Unfortunately, she's also caught up with the launch in the evening. So I will be covering that very quickly so we don't really, you know, lag behind.
Yes.
ये भी उसी से नोट होता है सेम से
हाँ जी
Thank you, Dr. Harish, for the insightful presentation. Continuing with our session, it is my privilege to introduce our next esteemed speaker, Dr. Urvashi P. Singh, Professor and in charge of the Tuberculosis Division, Department of Microbiology at AIIMS, New Delhi. She is a highly respected leader in the field with former roles as Deputy Director General of NTP and Director of the National Tuberculosis Institute, Bangalore. She has authored over 200 peer-reviewed publications and has led numerous funded research projects while contributing actively to national and international scientific committees. We are truly honored to have her here with us today. She will be sharing her insights on the theme BCG revaccination as a TB prevention strategy, a programmatic study among vulnerable adults in India.
Thank you, Dr. Tamanna. You know, Dr. Harish mentioned about the trial that was published in the NEJM last year. And so I will briefly allude to the program's initiative where BCG adult vaccination. It was a BCG revaccination trial. So this was a BCG revaccination trial under the program. And so vulnerable adults were actually revaccinated. We call it revaccinated because all of us do receive BCG vaccination at birth. So the evidence of BCG vaccine at birth was ensured and this population was vaccinated again. Now, this is the TB mortality. I'm going to move on because I want to keep the time in control. We're already running late. So why the BCG? Now, there have been a lot of doubts raised by several different groups. I just want to alleviate those doubts with some basic evidence. So the BCG manages to elicit a strong innate immune response, including activation of monocytes, dendritic cells and natural killer cells. There is enough evidence, a lot of publications. This is a summary of all. I've kept a very brief presentation. It also is capable of inducing trained immunity in NK cells via epigenetic reprogramming. It has a booster effect. Revaccination enhances, in addition to the NK cells, monocytes, dendritic cells. It also enhances polyfunctional Th1 and Th17, CD4 plus and CD8 plus T cells, and increases interferon gamma, IL-2, TNF alpha. Studies from India, a few studies have also shown heightened cytokine production post-revaccination in adults. BCG revaccination boosts the HLA-DR4 CD14 high monocyte effector responses, which takes care of the PAMP, that is the pathogen-associated molecular pattern stimulation. Now, by inducing this trained immunity, BCG may have a therapeutic potential far beyond TB, and potential benefits in conditions such as autoimmune diseases, cancer, and viral infections are known. You're all aware where BCG instillation into the bladder is used for, as a treatment for bladder CA. So just to go over the immune response induced by BCG, the trained immunity that BCG ensures, it activates macrophages, neutrophils, dendritic cells. The dendritic cells presentation to the CD4 and CD8 lymphocytes initiates an adaptive response. It also does epigenetic programming. I already talked about it. Increases production of cytokines and metabolic reprogramming, that is, elevates glycolysis, supplying energy, and so on and so forth. In fact, a few publications have clearly shown that the lung mucosa is lined with NK cells post BCG. So it is the NK cell that is enabling, along with the other actions that I just talked about, enables protection for acquiring a new infection or for breaking down into disease, that is progression from infection to disease. Now, also, like I mentioned, earlier on, what we did, it was a multi-centric study with ICMR support. This was the idea was generated here in AIMS. And with my colleagues, I think Dr. Rakesh and Dr. Anant would be online. This was an initial trial we planned to do for VPM and for, the MW vaccine, the MIP, which we discussed earlier. So what we are basically trying to push is, use the available vaccines, and with so much scientific evidence in favor of protection with BCG vaccine, we thought, why not, So, and also this is the only licensed vaccine available for TB. You're all aware we are vaccinating our small children on 0 day when they're the most susceptible, immune response, because we know it is a safe vaccine, because we know it will protect them against the disseminated disease, severe disease, TB meningitis, and miliary TB. And at the time point when the BCG was adopted in the country, the only trial that happened in our country gave 0% protection, while the trial in the UK gave 80% protection. So despite that, we adopted the BCG for our neonates, for our small children, because it was a safe vaccine which would protect against sinister miliary TB. Now, 80% of incident, again, we've talked about this earlier, that the TB prevalence survey as well as the NICSHE data shows us that the vulnerable adults, that is, the patients with TB in the past, those who are household contacts, those who are geriatric or elderly, those who are low BMI, those who are malnourished, BMI less than 18.5, smokers, diabetics contribute about 80% of the incident TB cases annually. There is a recently published retrospective analysis of the Chingalput trial. I refer to the Chingalput trial, which had earlier showed a 0% protection. But, lately, Dr. Padma, who was the director of NIRT, along with the ICMR team, published in 2023 a reanalysis, a retrospective analysis, and showed the BCG to confer 36% protective efficacy on revaccination. Now, multiple modeling studies indicate that the introduction of a vaccine We'll have another talk from a leader in modeling in the afternoon. So even with moderate effectiveness, especially when prioritized for the most vulnerable, could achieve substantial reduction in TB burden and avert TB deaths. So BCG revaccination was identified as a programmatic, scalable, and evidence-aligned intervention. And what we did was just to share with you what has been completed. Again, a phenomenal coverage of more than 1 crore, that is 10 million population of vulnerable adults has already been achieved. And the intervention is already over. What we did was programmatic cluster randomized parallel arm trial with nested test negative case control study. 575 districts across 24 states and UTs in India were included. 288 of these were intervention districts and 287 were comparator districts. Countrywide programmatic study was launched on 10th January 2024 and concluded last year. 11.2 million beneficiaries have been vaccinated. Those who had a history of TB disease, close contact of TB patients, elderly more than 60 years, diabetics, history of tobacco, and the low BMI population. So this is just, this has been covered very well by Dr. Harish. So the three vaccines he mentioned the M72 and the MTB vac, and I mentioned the GAM-TB, which is, these are the three vaccines in phase 3. GAM-TB is also, all three vaccines, and we'll be eager to take them here. And like Dr. Harish said, we've been discussing that proposal of, having a 3-arm trial if all the three vaccines are available to us. But like we discussed earlier, there are delays. Now, this again has been covered, so I'll quickly move forward to my concluding arguments, concluding takeaway points. The analysis of the outcome, you see the trial, the BCG revaccination just concluded last year, and we have to, follow up these patients for a breakdown disease for another at least 3 years post-vaccination, post-revaccination. So the interim analysis has been initiated last year by us, and ICMR NIRT is supporting us in the ICMR NIE along with NIRT are supporting us in that analysis. That will be the interim analysis, and the final analysis after the completion of 3 years of follow-up will be done. So the key takeaway points are for those naysayers. There has been a lot of debate, in fact, in social media also, that why BCG? You're subjecting our population to something that doesn't help. That is what I want you all to go back with, that there is adequate immunological evidence and epidemiological studies that suggest BCG revaccination can boost both adaptive and innate immune response. Several countries were continuing to do BCG revaccination, especially in the Europe. The other main thing is, when we do not have a vaccine that makes a difference, I mean, we do not have a good vaccine with us today. And the BCG could also offer something that we know as a prime boosting. That is, we have a primed, we all have been primed with the initial BCG vaccine. A booster may possibly, just boost the immunity of the primer. Modeling studies clearly indicate positive health impact by averting millions of deaths. And like I said, if 80% of the burden is coming from the vulnerable population, and the vulnerable population are, managed to have a prevention of disease reactivation, there it is. We are reducing the TB burden. That was the idea behind rolling this, the revaccination study. Frankly, there is very limited real-world data on, offering protection to the vulnerables. So this is, again, first of its kind. So India's BCG trial is designed to provide the first large-scale evidence. So you can see the numbers, 11.2 million, on the effectiveness of BCG revaccination among the vulnerable adults. So while we wait for the outcomes of the phase 3 trials of the 3 ongoing, the vaccines which have done well in the phase 2B, this is where we are. We have to await the interim analysis and then the final analysis after 3 years. If this is the protective vaccine, prevention of, if it prevents against disease reactivation, then we possibly have the answer already. And we may not even have to go for the next trial with the 3 vaccines that we just talked about. But fingers crossed, the analysis will soon be over and published, shared with everybody. Thank you for the patient listening. If there are any questions for me, please. So I guess that is a question. Right. So the first question says, what is the immune mechanism of BCG vaccination in adult to prevent subsequent infection or disease? So basically, I think I'll have to go back to my initial slide when I talked about the sum of where all the immune system is activated. It elicits a strong innate immune response by activating the monocytes, dendritic cells, and natural killer cells. And I mentioned to you, so in my references at the end of the presentation, the references are there. It also induces strained immunity in NK cells via epigenetic reprogramming. It boosts the effect by by enhancing polyfunctional Th1 and Th17 cells, which are actually instrumental in containing the TB, immunity against TB, increases in interferon gamma, IL-2, TNF alpha. And, there's a recent study from India which has shown heightened cytokine production post-revaccination as well. It also enhances monocyte effector responses, which take care of the pathogen-associated molecular pattern stimulation. So I think I've summarized, and the evidences I'll share with you, the references that are referred here. The second question is, what are the policy barriers to introducing adult revaccination? So I would say, like I said, this was one of its kind, or the first such trial where we decided to protect our vulnerables from having a breakdown to disease. So frankly, I am not a proponent of latent TB infection. In fact, I concur if you've read Beher et al. 2018 article, where not only Beher et al. He summarized all evidence in favor of disease would occur in the first 2 to 3 years of exposure, most likely in the first 6 months to 1 year. So what we are trying to do is just enhance the immunity and ensure that there is no disease breakdown. So the question to me was, what are the policy barriers? I think we have to have the evidence in hand before we can lay down the policy. It's always its evidence has to be in the favor of rolling it out. Once the analysis gives us confidence, I promise you there will be no policy barrier. Like we adopted BCG for our children, for our neonates, despite 0% protection was shown in several studies. But since we knew it protected against severe disease, we were able to adopt it. Similarly, if we get some positive data from the current the study, we will be able to adopt it. The third question is, how does BCG revaccination compare with new TB vaccines under development? So very valid question, and I think Dr. Harish did justice to it. So for the sake of time, basically all these vaccines, what they're doing is enabling the immune response to be stronger, to deal with the bacteria if they are inside us, which like I said, there are groups which believe in latent TB infection and those who do not really. So the effect on the immune response, all the vaccines are trying to do that. And BCG revaccination doesn't really. So you focus on this slide and the evidence in favor of the immune activation by BCG, and you'll be convinced for yourselves. Another question is there sufficient safety data for adult revaccination, especially in immunocompromised individuals? A very valid question. So you see, the protection, that is why I already gave you the simile of a newborn child, a 0-day child. We do not want to lose the child. By losing, I mean, say the child doesn't come back in a poor community, say the child doesn't come back to the center for receiving his vaccine shot. We ensure that because of the high burden in our country, we are giving him a 0-day shot. And the immunity of a 0-day child is, as you can imagine, he's as good as an immunocompromised child. So the safety is something which is not in question. But yes, what we have done in the study, we have not included PL-HIV because this being a live attenuate. we did not. So there are instances of BCGosis in patients who receive BCG as a therapeutic, vaccine, for example, in bladder cancer, and in some children who have, inherited immune compromised states, BCGosis reports, which are very few, have been there. So we have not included PLHIV in the study, and only the other vulnerable risk groups have been taken. And so far, in fact, there was no time to cover all the outcome, all the so that we have not really come across any adverse effects, if at all, very minor adverse this thing. I think the questions go on pouring. So another question is, can BCG vaccination reduce NTM infections? Another brilliant question. So again, evidence will have to be generated, but you see, the BCG is basically enhancing the cell-mediated immune response, as we can very well see on the screen. And the non-tubercular mycobacterial infection, when they cause invasive infections, it is the CMI which will take care of that. As long as, if we are talking about colonization of the lung mucosa, etc., of course, NTM being environmental source, and it can also form, biofilms, etc. And that leads to the post-TB lung disease with NTM. It starts with a biofilm and moves on to actually an invasive disease. So I am of the belief, yes, the BCG will be able to have a protection against the non-tubercular mycobacterial disease as well, because of the very effect on the CMI of the patient. So with this, I thank you all. One more question from the hall, please.
Analysis of this.
So the interim analysis has just been rolled out. Like I said, the ICMR continues to support the national TB program in a big way always. So the analysis has just been rolled out, and we will learn soon. Thank you. So thank you for the patient listening. With this, I think we can move on to the next session, please. Thank you.
It is my pleasure to introduce our distinguished speaker, Dr. Gyanu Lamichhane, Associate Professor in the Division of Infectious Diseases, Johns Hopkins University. His area of interest include TB drug discovery and development and drug resistance mechanisms. With over 150 peer-reviewed publications, he is an internationally recognized TB researcher with work on novel TB drug targets and therapeutic strategies. He continues to do pioneering work in the field of treatment of non-tuberculous mycobacteria. Today, he will be sharing with us his valuable insights on new strategies for treating non-tuberculous mycobacterial disease.
Today, I'm going to talk to you about non-tuberculous mycobacterial infections and new strategies to treat them. Specifically, I will focus on Mycobacterium abscessus and Mycobacterium avium because their incidences are rising around the world. For example, in the United States, the incidence of these two diseases alone is higher than that of tuberculosis, and similar trends are happening in places like Japan and South Korea. But unlike Mycobacterium tuberculosis treatments, there are no FDA-approved treatments for these two indications. So I will focus on first section of this talk. We'll focus on Mycobacterium abscessus and beta-lactam antibiotics. So let's talk about beta-lactams. Beta-lactams, all beta-lactam antibiotics have this specific core, chemical core. And the first set of beta-lactams that were developed for clinical use were penicillins, followed by cephalosporins, and then carbapenems being the latest ones. Beta-lactams as a whole are widely prescribed antibiotics comprising more than 50% of global prescriptions. And in the United States, actually, their use has been increasing in recent years. Despite their very high significance in medicine, the historical description of how beta-lactams work is incomplete and contains substantial misconceptions. So what are those misconceptions? I will walk back a little bit of basic science here. This is cell wall peptidoglycan that I'm showing you. It is a structure that encapsulates the bacterial cell and provides it with protection. It is the exoskeleton of bacterial cells, determines the cell shape, and is essential for viability of bacteria. And its inhibition of its synthesis is how beta-lactams work. Beta-lactams inhibit synthesis of this particular structure, and in doing so, kill bacteria. So based on the historical model, there is one enzyme that makes the cell wall peptidoglycan. So I'm going to animate to you how the cell wall peptidoglycan is synthesized in bacteria. In the cytoplasm, the subunits of the cell wall peptidoglycan is first synthesized, and it's transported out to the periplasm, where this enzyme that I'm showing you in blue color, please remember the color coding here, makes this linkage 4th to 3rd amino acid in 2 peptides. Again, there is one enzyme that makes one type of linkage, and this polymer eventually becomes the orange structure that I'm showing you, the peptidoglycan. Beta-lactams work by inhibiting the enzyme. In fact, penicillin was first used to determine this mechanism. That's why the enzymes that are bound were called penicillin binding proteins. Later on, other beta-lactams were also shown to bind to this enzyme, but they're still called penicillin binding proteins. According to this model, there's only one enzyme class, again, penicillin binding protein, that synthesizes peptidoglycan. So based on this, use only one beta-lactam at a time to treat bacterial infections. That particular modality was established, and clinical use of beta-lactam was informed. So again, based on this historical model, there is one enzyme class, penicillin binding protein, which makes only one type of linkage, 4 to 3 amino linkages. Now, contradicting evidence began to emerge in the 1980s. Here, this particular paper on mycobacteria showed that mycobacteria, in fact, make 2 types of linkages in their peptidoglycan, 4-3 linkages and 3-3 linkages. So now we have an evidence showing that in mycobacteria, in addition to 4-3 linkages made by penicillin binding proteins, there is an additional type of linkage. But this work was ignored because it did not fit the model that said there's only one type of linkage and there's only one type of enzyme. Additional contradicting evidence came from E. coli. In this study, they showed that in slow-growing E. coli, it uses 3 to 3 linkages rather than 4 to 3 linkages made by penicillin binding proteins. Again, this work was also ignored as it did not fit the model that said only 4-3 linkages are present in bacterial cells. So now the historical model is no longer accurate. For that reason, we need to discard the historical model. And here is the revised model that shows both linkages, 4-3 and 3-3. 4-3 on your left and 3-3 on your right. 4-3 made by the enzyme in blue, penicillin binding protein, and the red enzyme makes the 3-3 linkage. So now here's the evidence that with regards to the new enzyme class. This is Mycobacterium tuberculosis wild type that causes disease. When we grew this on strain on agar, it grows laterally, it's flaky, dull looking, and flat. Then we isolated a mutant which looks very distinct from the wild type. Instead of growing laterally, it grows aerially, it looks shiny and oily, and looks more like a modern city skyscraper city highline rather than more lateral flat growth for the wild type. Next, we looked at what particular gene it was lacking. It was lacking this gene called MT2594, and when we characterized its function, what we were able to show was it was the protein encoded by this gene that made this 3-3 linkage. The presence of 3-3 linkage was known much earlier in 1974, but the enzyme was not known. And the existing model only said there was one enzyme that made 3-3 linkage. Now we have two different enzymes that account for two different linkages. This work was already published. This has been published in 2010. So when we looked at the cell surface structures for the wild type on your left, healthy-looking cells, rod-shaped cells. When you look at the mutant that lacked the LD transpeptidase, this new enzyme, which the field ended up naming as LD transpeptidase, LDT, when Mycobacterium tuberculosis lacking this particular enzyme looks what you can see on the right. There are depressions and bulges and scars around the lateral surface, and these cells do not look healthy. So next we asked this particular loss of this enzyme, which alters its cell surface morphology, does it also alter sensitivity to drugs? Here I'm only showing you one specific data where we tested whether the mutant that lacks this particular enzyme is susceptible to amoxicillin. There were two groups of mice that were infected, one with wild type Mycobacterium tuberculosis, another with mutant that lacks only this particular enzyme. And the entire experimental setup was identical for both groups, except the two different strains that were used. And they were treated with amoxicillin. Both groups of mice were treated with amoxicillin. And as you can see, only mice that were infected with mutant, which lacked the LD transpeptidase enzyme, was susceptible to amoxicillin. So that led us to conclude that if there is an inhibitor of LD transpeptidase, then we could bring in amoxicillin. The combination of amoxicillin and LD transpeptidase would be effective against wild type. So again, the conclusion is a beta-lactam and an LD transpeptidase inhibitor would work against M. abscessus. So how can the new enzyme be inhibited? The LD transpeptidase. We continued the study further along, and here is the revised model, right? So there are two different enzymes that make two different linkages. Because penicillin binding proteins are inhibited by beta-lactams, we questioned whether LD transpeptidases are also inhibited by beta-lactams because they do similar reactions in a very similar pathway. So here are different beta-lactams that I showed you earlier. Also, we reacted different beta-lactams with LD transpeptidases from different organisms. Here, this work was done by Dr. Pankaj Kumar. On the first column, we're showing you LD transpeptidases, LDT, from Mycobacterium tuberculosis, MT, Mycobacterium abscessus, MAB, and then from Klebsiella pneumoniae, cloacae, and Pseudomonas aeruginosa. So a range of LD transpeptidases from a range of bugs were exposed to different antibiotics for different subclasses of beta-lactams. The first second column shows amoxicillin. I'm only showing you one drug here at a time, but we generated multiple sets of data for this particular study. But this data captures the essence of it. What it shows is penicillins, represented by the second column, rarely inhibit LD transpeptidases. Wherever you see red, that means inhibition. Then you move on to cephalosporins. Cephalosporins inhibit a few more LD transpeptidases. But then you move on to the fourth column, doripenem, and the fifth column, farrapenem, which are carbapenems and penems, very similar subclass. They are the ones that very effectively inhibit LD transpeptidases. So based on this study, which was also reproduced by multiple other groups, what we know now is penicillins are good at inhibiting penicillin binding protein, but carbapenems are better at inhibiting the new enzyme LD transpeptidase. Now I've written CBP here just for the sake of this particular talk, I'm calling it carbapenem binding proteins because carbapenems bind them better. So now we have two different enzymes that are relevant in terms of generating cell wall peptidoglycan in mycobacteria, but they are differentially inhibited by different beta-lactams. So that led us to this particular hypothesis. Can a combination of two different beta-lactams that differentially inhibit the two different enzymes exhibit synergy? So because bacteria use both of them, and the two different enzymes are inhibited differentially, can we use combination of the two beta-lactams specific against these two enzymes and expect synergy? So we put that hypothesis to test. This work was done by Dr. Story Roller, where she combined various beta-lactams. Each square here represents a combination of two different beta-lactams, and and then she exposed these combinations of beta-lactams, dual beta-lactams, to Mycobacterium abscessus in vivo and looked at their survival. What this data shows is there are multiple combinations here shown in dark blue that exhibit synergy, which means less than combination comprising of less than 1/4 dose of two beta-lactams is just as effective or better than full dose of one. This work was followed up by multiple other groups also demonstrating synergy, in vitro synergy with of two beta-lactams against Mycobacterium abscessus. Next in our lab, Dr. Mezen Calda, using a mouse model, demonstrated that this synergy that is occurs in vitro also occurs in vivo. Using a mouse model, she was able to show that down here, the last curve on shown in red is mice were treated with half doses of imipenem and ceftinir, and the outcome is just as good, if not better, than full dose of imipenem or ceftinir. This idea of dual beta-lactam caught interest in the clinical field, and here is a paper showing use of dual beta-lactam for successfully treating Mycobacterium abscessus infection in a child. There multiple papers have emerged recently. Here's another paper of using dual beta-lactams and bacteriophage to treat M. abscessus external wound infection. So now I'm going to switch gears here. Again, so far I discussed how beta-lactams could be used in a new way, that is combining two different beta-lactams specific to your bug to gain synergy. So far I've shown you that specific dual beta-lactams are effective against Mycobacterium abscessus. So now I'm going to switch gears to Mycobacterium avium and question the current treatment modality. The current treatment modality is based mostly on tuberculosis treatment, which utilizes a combination of multiple drugs. The standard of care is multi-drug, similar to that in tuberculosis. So here the combination for Mycobacterium avium is clarithromycin, ethambutol, rifampicin, and plus or minus another drug. Again, the treatment modality is borrowed from TB with emphasis on limiting drug resistance and improving efficacy. So let's visit these two criteria independently, one at a time. So limiting drug resistance spread. However, unlike in TB that is disseminated human to human, M. avium is largely acquired from the environment. So a patient with drug-resistant M. avium is not a threat to the public. So we question whether this criteria should apply to M. avium also, whether multiple drugs should be added just for to limit drug resistance. The second reason given is expectation of improved efficacy. But there are multiple papers. Here's a paper showing rifampicin has no role in treating Mycobacterium avium, and perhaps clofazimine should substitute rifampicin in treating avium infection. And there are several groups that have reported similar findings. So we started to build Mycobacterium avium treatment from the scratch. And what we did here was we went after what would be the minimal amount of drug that can be used to effectively treat M. avium infection and limit resistance and be just as good as standard of care. So we infected mice with Mycobacterium avium, allowed the infection to go for 4 weeks. Again, this is pulmonary aerosolized infection. And the mice were randomly separated into 4 different groups. The first group, shown in red, was treated with just saline PBS as a control of no drug, negative control. The second group, shown in green, was treated with standard of care, which is a combination of clarithromycin, ethambutol, and rifampicin given each day, all 3 drugs given each day for the 3-month period here. And third and fourth are experimental groups. There are sequenced monotherapy. What we reasoned was give 1 drug at a time, which also improves tolerance and adherence to the treatment regimen. So mice received clarithromycin only for the first month, and then received bedaquiline, and then was followed up by clofazimine monotherapy in the 3rd month. And in the 4th group is the same 3 drugs in reverse order, with clofazimine in the 1st month, bedaquiline in the 2nd month, and clarithromycin in the last month. And here is the efficacy data based on lung avium burden. So as you can see, at the end of the study, you can see mice that did not receive any antibiotics, shown in red, have progressive disease burden. But when you look at mice that received multiple drug standard of care, shown in green, their lung burden resulting from standard of care is similar to mice that received only 1 drug at a time. So what does this show? This shows that using 1 drug monotherapy and sequencing through phases, 1 drug at a time, is just as effective in terms of efficacy as using multiple drugs at a time. The second criteria for using multi-drug therapy is to limit resistance emergence. We also tested that. We recovered colonies from mice, M. avium isolates from mice, and determined MIC of each of the drugs against those recovered colonies. And here we saw that we were unable to isolate drug-resistant mutants, demonstrating that the chances, the risk of increasing resistance by simply using 1 drug at a time is not higher than using multiple drugs at a time. So again, I will end my talk here. What this particular study shows is that perhaps there is another path that uses fewer drugs, which can improve compliance, which can actually improve treatment outcome in the end, is just as effective in terms of efficacy and minimizing drug resistance in Mycobacterium, in treating Mycobacterium avium lung infection. So with that, thank you very much.
That was Dr. Gyanu, a very esteemed colleague and collaborator. We have together published the effect of synergistic action of combining rifampicin with ferropenum in Mycobacterium abscessus in the past, which clearly demonstrated that the MIC of rifampicin was brought down when it was combined with ferropenum. So that is the strength of synergism of combination regimen, and possibly that is why we use a combination regimen for treating TB. Though the DST is done to individual drugs, which to my mind is incorrect, we should always be having a checkerboard, but that is not the current recommendation. Nevertheless, I wanted to bring out the synergistic effect of a combination regimen, and that is why we rolled out the BPAL-M to those patients who are showing FQ resistance in addition to rifampicin resistance as well. And let me tell you, the outcomes of the BPAL-M are very promising. We're getting more than 90% success rate, and soon again this data will be in print in some ways. It will be published soon. So since Dr. Gyanu was traveling and could not join live, there are two questions which I'd like to address. The first question is, in WHO guidelines, there has been one term introduced that is viable but not cultivable MTB. Could you please explain in the context of cell wall? So let me first talk about the first part of the question, that is a new term is being introduced in WHO guidelines. But let me take you back. If you read, in PubMed, the word VBNC is several years old. It is not a new term for, microbiologists and for those who deal with whether it's mycobacteria or other bacteria. The viable but not cultivable stage is the stage where the complete bacterium is not getting formed and the culture doesn't grow. That is, you're not able to see colonies, but the organism will remain viable and can replicate and go on. So in terms of cell wall, I think we'll refer your question to Dr. Gyanu, but the answer, the gist of the answer is that the cell structure doesn't, form completely. So most probably the cell wall would not be forming, while the cell membrane, it will be something like an L form, like you must have read in your early days. But yes, that was a very good question. And for those of you for whom this concept of 3-3 linkages was new, again, I think you can go back and read more, and that is the way the carbapenems act. Another question, again, a very good question online, which is, in a microbiologically established drug-resistant TB case, if NTM has been isolated in follow-up samples, what will be the clinical relevance in context of DR-TB management? Now, this is a very good question, and I get to deal with a few different aspects of this question. So in the first, let me allude to it like this, that there are times when an NTM is misreported as an MDR-TB, because even gene expert will pick NTM when they are surplus in numbers. When they are in large numbers, gene expert will give a positive report, right? So also there are times when the culture grows in a lab and instead of confirming it as Mycobacterium tuberculosis, sometimes the report is sent out as Mycobacterium tuberculosis and as NTMs, like we are talking to, our environmental organisms, they are inherently resistant to a lot of anti-TB drugs, right? So there can be a misreporting because of, lapses in one or two steps. So at the outset, it may not have been an MDR while the patient has been treated for MDR. That can be one, a situation. The other, of course, what you actually alluded to was it is a DR-TB patient, and the DR-TB patient has had a long-standing TB and has left behind, there's a cavity which is fibrosed and is not healing. In such a cavity, a biofilm due to non-tubercular mycobacteria could easily form, and you could isolate non-tubercular mycobacteria even post DR-TB treatment, like we have Aspergillus infections. Similarly, we can have non-tubercular mycobacterial infection, and that is not so uncommon as may be thought of. It is just underreported. In fact, if you look at the latest IJTLD, the latest, March edition, the March volume, there is article which talks about coexisting TB and non-tubercular mycobacterial infection. There was another article last year where coexistence of both TB and non-tubercular mycobacteria has been shown. The catch is, how do you prove the non-tubercular mycobacteria is the pathogen? That is where, we do not have a technique to actually prove that the NTM is causing invasive disease or just colonizing a cavity. Nevertheless, how we deal with it is we look for, 3, so if it is a sputum or non-invisibly collected sample, we do 3 subsequent samples. If it is a biopsy or a BAL, we rely on 1 single sample. If you read the ATS guidelines, the standard ATS guidelines of 2007 and 2020 guidelines, again for pulmonary NTMs, you'll be able to understand how the guidelines have been laid out with this by this esteemed group. So again, we will have to ensure that the patient's DR-TB, back to the question, the drug-resistant TB has been taken care of and there is no longer any DR-TB involved. And then with, you will deal with the NTM as per the American Thoracic Society guidelines, which is also the IDSA American Thoracic Society guidelines. And frankly, there's a lot of work in India which has been published and experiences in treating the NTMs are, are again in the public domain. Rest, if there are further, corollaries to this question, we can take it offline. Moving on to the next talk because we are actually running late. So
it is an honor to introduce our most distinguished speaker, Dr. Igor Mokrosov. He is the head of the Laboratory of Molecular Epidemiology and Evolutionary Genetics at the St. Petersburg Pasteur Institute, Russia. His area of interest includes phylogenomics, evolution, and drug resistance. He has authored over 220 peer-reviewed articles and has an H-index of 43. He has received several honors and awards for his extensive contribution. He also serves as a senior editor for leading journals, including Tuberculosis and BMC Microbiology. Today, he will be sharing his insights on genetics of Mycobacterium tuberculosis, adaptation to selective pressure in vitro and in vivo.
Dear colleagues, good morning or good afternoon, depends where you are now. So I would like, first of all, to thank Professor Urvashi Singh for inviting me to make this presentation at the World TB Day in India, in All India Institute of Medical Sciences. And I will present some of our results on our research when we study genetics of MTB adaptation to selective pressure to different compounds in vitro and in vivo. This is a collaborative study with our colleagues and friends from TB Institute in St. Petersburg and our colleagues from research institutes in universities in Bulgaria. But just as a brief reminder that we coexist with TB bacteria since many tens of thousands years, and it accompanied humans since throughout all our prehistory and history. It was a very serious disease in Europe in 17th, 18th century. It was very high level mortality in Russia even as early as 20th century, but it was a historical situation. After this, we had BCG vaccination, we had antibiotics. But anyway, now we have a new challenge, emergence of multi-drug resistant TB, extensively drug-resistant TB. That is maybe incidence in many world regions is decreasing, but it is increasing. For example, the rate of MDR-TB in Russia is 37%, as you can see on this slide. And in absolute numbers, India, China, Russia, Indonesia are among the top countries in case of, in terms of estimated number of people who developed MDR-TB. But again, few words about, I like this slide. It's just a one-page article about the first paper about the structure of DNA by Watson and Crick. And in the end of this very short paper, they had a sentence, they put a sentence, important one, that it has not escaped our notice, that the specific pairing and so on. Well, you can read about coping mechanism. What we observe is a suggestion about possible coping mechanism for genetic material. But when you have a mechanism, this mechanism may go wrong some way, may be broken. And for case of genetics, it's a spontaneous errors, and this mechanism can lead to mutations. Mostly these mutations are useless, but sometimes they may be under some changing environment. These mutations may become helpful and can help for bacteria to survive. And this slide I took from the paper. You can see at the bottom the reference to the article in Nature. It was not about TB, but anyway, it is useful also for us who work on MTB to systematically look at these different ways how bacteria can withstand antibiotic treatment. This is, as you see, timeline of use of antibiotics, starting with different kind of bacteria, susceptible or resistant. You can see in different colors. And the important thing is now it's more and more studied is that drug tolerance. In fact, drug tolerance means, as far as I understand, a low-level resistance, and there are no genetic mutations directly mediating resistance. But anyway, there are changes in the bacterial metabolism. They can make them able to survive for a long time. The action of the drugs, they multiply more slowly. They are small colonies, and they can anyway survive, even if they decrease their numbers, the bacterial cells. And when we speak about not slowly but non-dividing bacteria, is the last point in this slide is persistence. A subset of non-dividing bacteria, they can survive antibiotic treatment for a long time, and after there is no more drug action, because treatment is anyway does not last forever, these bacteria can start to multiply again, and we have the case of relapse. And just yes, as I was saying, and again to emphasize about tolerant bacteria, that the important reactions that are considered as a part of antibiotic tolerance, decreased growth rate, metabolic shifts, and increased efflux. Of course, efflux pump activity is very important part of drug tolerance. And there is also interesting terminology, recalcitrance. I think it is similar to resilience, also recently suggested. But again, it's all more or less the same about tolerance and persistence, but through other kind of mutations that can help bacteria to survive in the more general way, let's say. Well, anyway, my objective will be not to discuss everything, but rather to present briefly our results of our studies of MTB genetics, of MTB response to selective action of first candidate anti-TB compounds in the in vitro model. When we studied such compounds applied to reference strain H37RV, and we had spontaneous resistant clones that we studied by whole genome sequencing. And other, it's a study already of the mice infected with real clinical isolates. Mice were infected, they were receiving correct chemotherapy, and after we studied at the end of this chemotherapy, they isolated bacterial isolates from the lungs of these mice, and we applied whole genome sequencing to these isolates to see what actually happened during this long-term treatment. So first of all, it's like a preface to remind that when we consider real human patients that undergo long-term treatment with new drugs like Beta-lactam, we have, well, just briefly say about our finding of we can have consecutive isolates during treatment of these patients, and after we can again subject these isolates to whole genome sequencing, can see how resistance develop, how it can develop. We had this study in the northwestern region of Russia a few years ago. We had 11 patients. They were receiving very complicated treatment. They were MDR or XDR, and they were receiving bedaquiline, for example, and linezolid. But in this study, we looked only for bedaquiline resistance mutations. So we had 11 patients, and we had 45 isolates from these patients. And what we observed that in 6 out of 11 patients, we observed resistance mutations. Different mutations, mostly in this gene RV0678, and the point that the treatment green line at the bottom means the treatment, and you see in some patients it was interrupted treatment. And yes, because of this, in most cases we had emerging mutations. In one patient we did have a mutation already, but in other patients we had these mutations emerge during treatment. So on this slide you can see, well, let's say scientifically interesting patient treatment of patient. You see the information, the pre-treatment isolate was resistant to maybe some 10 or 11 drugs, and the treatment included also, you see in the left bottom part of the slide, the treatment included so many different drugs, but itself the treatment was 1 month in the beginning of this 9-month observation, and also short few-day treatment periods during this time. And you see we had 6 isolates, and you can see the green is a wild type in the very beginning, but after we could observe different kind of resistance mutations, frame shift mutations in bright colors, and in some cases what we see there were coexistent mutations. And when we looked at the reads, sequencing reads, it was MySeq, it was long reads, 250 base pairs, we could see that the different mutations coexist, but they were present on different reads. And in some cases, some mutations were emerging 3 months after the treatment was ended. So this is a summary of that study a few years ago. That when we in case of long-term and interrupted treatment, we see that these resistance mutations, in case of bedaquiline resistance, they do emerge quite rapidly in the RV0678 gene, and we can have cases, usual cases of hetero resistance and mutations that emerge after the end of chemotherapy. Actually, we have now a new study that we run right now, not yet published, but I can say that what we see, the situation is slightly, but not slightly, but really changed. That 4 years ago we had mutations emerging during treatment. Now we have patients who have already isolates already resistant to bedaquiline, and it looks like that there is a spread of such bedaquiline resistant strains in the population. It's really very worrisome finding. But now back to the actually major topic of my presentation, our studies in vitro and in vivo. It was a study run in collaboration with colleagues from Bulgaria about candidate anti-TB compounds that belong to the class of aryl hydrosomes. But as a brief introduction, well, just as I was saying, and we know it very well, that there are spontaneous resistant mutants that emerge, and very small percentage, normally, usually, spontaneous errors, but sometimes these mutations can be beneficial. And when, for example, we culture bacteria on a medium with elevated concentration of some compound, we can get finally some clones that will be growing on this elevated concentration, and if we do whole genome sequencing, we can probably find some clues why these clones emerged On the left, it's a control without compound. On the right, it's a quite many colonies actually we observe at 8-fold MIC of some compound. This is just an example. In this way, we can understand how microbe can react as a primary response to the action of compound. We can also understand, perhaps get some insight into the mechanism of action of this compound. Of course, there are many more directions to study in this sense. Not necessarily we will find mutations that would be fixed. It may be transcriptomic study that will be helpful, but we did not do this study. We did just whole genome sequence. And these RL hydrozones, they have this hydrozone group. You can see it in the red color. They are similar to INH, isoniazid, and the mechanism of action involves also inhibition of INHA, reduction of mucolic acid synthesis, and disruption of the bacterial cell wall. But unlike INH, they are not prodrugs, they are already active. So in this study, we used two RL hydrozones that were already found useful in terms of cytotoxicity, MIC values, for example, designed in the Medical University of Sofia, and we applied them to H37RV. So these MICs, you can read, they were detected by a Resazurin method for H37RV reference strain. So it was a classical selection, the study designed a classical selection of resistant colony that were cultured at elevated 4 to 10-fold MIC concentration of these compounds. We had ATCC H37RV strain, and after 1 month of experiment, we picked up some clones, extracted DNA, and did whole genome sequencing. Can compare it. Also, we did the same whole genome sequencing for the original strain they used in our laboratory. And after we compared this to the reference genome, well-known genome, using different online tools. So the conclusion was that we find mutations in some clones, and we found that the different clones had different mutations. And this is a summary of these genes. There were different genes that belong to different categories and have different functions. They're proteins, I mean. And this is the summary about these particular mutations. And the last column writes about the likely role in brief. So 2 mutations were frame shift, in 2 cases they were non-synonymous and actually not really significant if you look at these SIFT-P and PAM1 values. But all of them, what is interesting that all these mutations that are related, what we looked in the literature about these genes, looks like all these mutations are related to efflux or generally, more generally to drug tolerance. This one, for example, this interesting mutations, it's a strand slippage during replication. Additional C is introduced. This is a frame shift, glycerol kinase gene, GLPK, and this was described already as conferent transient drug tolerance. In this paper in PNAS, Safi and co-authors wrote that they did find this mutation in GLPK, leading to small colonies that exhibit heritable multi-drug increases in MIC. And as I mentioned, the key MTB response to drug pressure include, in particular, reduced growth rate. So I think that indeed may be possible that this inactivated mutation that was found not in 100% but in 83% reads could be selected in response to the action of this particular RL hydrozone. Other mutation, it was also frame shift, also important gene PPGK, that encodes polyphosphate glucokinase. It is essential gene, and it is likely associated, according to the published literature, to the starvation-induced drug tolerance and MTB persistence in mice. Yes, also its PPJK gene network includes sigma R factor. It's a very important transcription initiation factor. So perhaps inactivation of this gene could be beneficial for MTB survival, and perhaps hypothetically activated a more general stress response and directly leading to tolerance. But when we looked at these 5 genes, where we found mutations in different clones, we find that there are no connection between these genes. They participate in different pathways, but all of them are involved in drug tolerance, including efflux. So this is a conclusion from this study, that the short-term in vitro effects of the study compounds on the slow-growing, I emphasize this slow-growing MTB, mostly lead to emergence and selections of mutations in various unrelated genes that create conditions for survival under external stress. And these are no specific tolerance mechanisms. That is, the strains start to fight against, the bacteria start to fight against action of this external pressure from compound in all different ways. Unfortunately, we could not continue this study at that time. Normally, we should have, of course, recultured these clones and to see if this primary response would be really inherited in the consequent generations or not. But the primary response shows this exactly as I was saying. Counteractions in all possible ways. Maybe some ways would be helpful, and the strain on the whole will survive. And the last part of my presentation is about our study in the mouse model of experimental TB and chemotherapy. When we studied the clinical isolate from the lungs of mice after long-term therapy with new drugs. So experiment run with our colleagues from St. Petersburg TB Institute, experimental TB laboratory. We used resistant black mice, intravenous injection in the tail of mice. They had 2 groups of animals, and we had 4 strains. This time we studied clinical isolates, important Beijing genotype and Lam genotype strains. Some are they were previously studied in the same mouse model, and some were low virulent, other were highly virulent, but all these strains were MDR or pre-XDR. And so the treatment included new generation drugs like moxifloxacin, linezolid, and bedaquiline. And the experimental group was treated almost 6 months, 5 times a week, and 177 days. And there was a control group, of course, that was infected but not treated. Yes. So there were many experiments during this study. I don't discuss them in detail. You can find, we have recently published an article about this. But for my presentation, important that we have recovered from these mice, 6 mice per each group were euthanized, and we had isolates after 2 and 5.5 months of treatment. We did whole genome sequencing. We tried, first of all, to find if there was emergence of resistance mutations linked to resistance to the used drugs. And what is good, indeed, that we didn't find any resistance mutations, even in the negligible percentage that could emerge in response to these drugs, because the treatment was really not interrupted 6 months, and it was correct treatment, multiple new generation drugs at the same time. when we looked at the changes in MTB strains in the genes not related to drug resistance, that is, we looked at the whole genome data, we found two interesting cases. Indeed, there were not many mutations at all. We just found two really reliably emerging mutations. First mutation was in the gene TGS3. It was the stop codon mutation. It's an important mutation because the gene is just disrupted in half. And it was detected in all isolates from lungs of mice infected with hypervirulent Beijing strain that is endemic in Russia, in Russian region of Buryatia in the Far East, in animals that were receiving chemotherapy. In all groups, after 2 months, after 5 months of treatment, all of them had this mutation, but they didn't have 100%. They had it at around 65% of reads. This mutation was observed. So there was some molecules of this protein that were not completely inactivated. But when we looked at the original strain that were used for infection, we found that indeed it did have 9% of this mutant allele. So there was already some amount to start evolution, let's say, evolution of survival of this strain. In the conditions of treatment with new drugs and immune response from the host. And this was fluctuating. You can read these details here, and also you can read our article. This proportion increased after 2 months. It increased to even 200% in some isolates, but it slightly decreased to 40–80% in the end of treatment. So there was some dynamics. And what is interesting about the gene, that it is important for lipid metabolism, energy storage, and adaptation to stress. Below at the right, you can see the reference to the article about, in particular, about this gene. And what was found about it, this TGS3, that its change expression could, its increased expression helped increase the growth of MTB A37RV and could contribute to MTB drug tolerance. And why? You can read increased production of these triacylglycerols contributes to MTB adaptation via dormancy. So our hypothesis that when this gene is switched off through stop codon mutation, this may lead to enhanced growth. And the particular mode of adaptation of this highly virulent strain to the drug action, to the immune response together. So this is our hypothesis. And the other mutation was found not in many, but in one single isolate from animals infected with low virulent lump strain. MDR, but low virulent strain. In one isolate in the end of treatment, after 5 months of treatment, had a mutation, non-synonymous mutation in the gene coding for oxidoreductase, 80% of reads, and when we checked by in silico analysis, it seems that this mutation is really important. It does influence the protein function. You see CIFT-P and PAM1 values seem to be significant. And this mutation was completely absent in the parental strain. It was absent in all other isolates isolated during treatment. But in one isolate, it was present. What is interesting about this mutation, about this gene, that this oxidoreductase gene, coding for short chain dehydrogenase gene, and it is required for growth on cholesterol. Normally, cholesterol, capacity to import cholesterol, it's not important for initial infection of the strain. When strain infects mice, it does not need it. but it is essential in case of persistence. At the time of persistence, after long-term infection, bacteria start to use host cholesterol as the source of carbon. And indeed, this mutation could be beneficial for this isolates in this animal. So I'm sorry, maybe I'm out of my time, I don't know. But anyway, these are general conclusions. Just to reiterate what I was saying, that in real life patients with interrupted treatment, maybe sometimes wrong treatment, the mutations leading to resistance to the drugs can emerge rapidly, at least as far as beta-acculin is concerned. And indeed, we see in vitro model that the response of MTB to the action of different compounds, candidate compounds with anti-TB action, is multifaceted, it's rapid. There were different genes involved in counteracting this external stress, and mostly, as far as primary response is concerned, these mutations are related to drug tolerance and efflux pumps. And when we look back to the in vivo, when we study this adaptation of MTB to the external stress in vivo in mice, we see that well, the situation for us, for humans, is not so bad when if a patient can observe long-term treatment as a compliant patient, there is no risk of resistance to emerge, which is good. But unfortunately, bacteria can counteract this external stress in other ways, through selection of beneficial mutations in the genes that are not directly related to resistance. And this adaptation is different. It may be follow different ways. In highly virulent strains, we see mutation in the dormancy gene. That is, dormancy gene is switched off. So likely bacteria start to grow rapidly. And in the low virulent strain, the situation may be different. There is a mutation in the gene that is helpful for bacterial persistence. So maybe the genes may be considered as drug targets, for example, when we develop new drugs. Well, anyway, that's all what I would like to tell you today. I would like to thank our collaborators from Russia and Bulgaria, the grant from Russian Science Foundation, from our laboratory, and I thank you for your attention. Thank you.
Dr. Igor has kindly shared a recorded presentation because he was also occupied in a meeting in another city. So we are indeed thankful to you, Dr. Igor, for lucidly explaining how mutations are generated and how they may or may not always make a difference because of maybe an epistatic mutation or some other reasons. So thanks for this beautiful talk. There are a few questions. I will try to address them here. So the first question is, in heteroresistant population, if liquid culture is attempted, which population will grow earlier in liquid culture medium? How to detect? Okay, that's the second part. So the answer to this, Dr. Sebastien, I was just trying to answer a few questions from the previous talk. If you bear with me for 2 minutes, please. So in the heteroresistant population, the population which will be more rapid growing will grow first, and incidentally, you will not wait for the second population to grow because the culture is already grown. And like Dr. Igor also shared in his experiments also,
some organisms, some of the population, that is the heteroresistant population, was growing earlier than the other. So you have just witnessed that. Let me quickly go to the other questions, so the second question is, can any mutant with a particular anti-TB drug will clinically respond with higher dose of that particular antibiotic? This is a very tricky question and involves a lot of understanding of the PK/PD of all drugs, so all drugs act differently. Some are concentration dependent, some are time dependent, killing is involved. And the, the drug level achieved in the serum is what is salient again. How many times of the MIC is the drug level achieved in the serum? And what is the therapeutic window really? So can you actually increase the drug dosage? Now, what we traditionally do in TB treatment is we give high H and we give high MOXY, because we know the therapeutic window for these two drugs will work, and the low-level drug resistance in the case of INH as well as the low-level drug resistance in the case of fluoroquinolones can be overcome by using high-dose H and MOXY respectively. But this may not be applicable to all drugs. So the PK/PD of each individual drug will have to be looked into. Another question is, if any strain of MTB does not have any antibiotic exposure history, how could mutation develop in such a strain? So this takes us to the basic science of, mutation is a naturally occurring phenomenon, and only when these naturally occurring mutations are selected in a large population of, say a cavity, will it, clinically present as drug resistance. And for that matter, even in vitro, only when the culture will grow, you'll be able to actually discern a resistant from a sensitive population. But again, to reiterate, mutations are naturally occurring phenomenon, as is known. Resistance to rifampicin will occur in 1 into 10 to the power 8 replications, while in INH it will occur in 1 in 10 to the power 6 replications, and hence the frequency of mutations to rifampicin is lower than that in INH. This is why, rifampicin is used as a surrogate of MDR-TB, because that is less frequent. In fact, in 95 to 96% of rifampicin resistant strains, there will be coexistent INH resistance as well. Small percentage, they could be mono-resistant to RIF, and of course, a larger number of mono-H we know are reported. So I hope that addresses your concerns. If not, please write to us and we'll let Dr. Igor deal with your questions. Thank you. Over to, we'd like to, like Dr. Tamanna to please introduce Dr. Igor, Dr. Sebastien Gagneux, and I'm so thankful for him to join. There's a time gap between us and where Dr. Sebastien is from Switzerland. So please, Dr. Tamanna.
Thank you, ma'am. I would like to invite our next speaker, Dr. Sebastien Gagneux. He is a full professor of infection biology at Swiss TPH and University of Basel. His work focuses on the causes and consequences of genomic variation in the Mycobacterium tuberculosis complex and on the ecology and evolution of antimicrobial resistance. Professor Gagneux has published over 250 papers. He has been honored with several awards, including the Gardner Middlebrook Award from the European Society of Mycobacteriology for his lifetime achievements. Today, he will be speaking on epistasis and the evolution of MDR tuberculosis.
So, good afternoon for you. For me, it's good morning, good afternoon for you. Thank you so much for the invitation. Let me see. Presentation mode. Do you see the presentation mode?
Yes, we can see that very well.
Okay, excellent. So let me quickly. Right. So thank you for the introduction. And so yes, I'm going to talk about epistasis. I don't need to do any introductions in terms of TB and MDR. I think you're all experts on this. So I thought I'd just take 1 minute to introduce this concept of epistasis, which might come across as a bit of an esoteric term, but I will try to convince you that this actually matters for our discussions on multi-drug resistant TB. I'm going to show you 3 examples of it. But so it's really a very generic genetics term, and I'm going to introduce it in the context of in a very simple model. So essentially, if you have a mutation, could be a resistance mutation or any other mutation, that's going to lead to a phenotype 1. And that could be an MIC, we just heard, right? Isoniazid resistant mutation, or LPOB, etc. They lead to different MICs, but it could be also differences in a virulence or transmission of a given TB strain. And then you have a mutation number 2. And what can happen is if there's an interaction, a so-called epistatic interaction between these 2 mutations, the phenotype will change. So now we don't have phenotype 1 anymore. We're going to have phenotype X because we don't really know how different it's going to be, and it could be anything. And this is, of course, the simplest mode of epistasis. In reality, of course, we have many more than just 2 mutations. So you can imagine how complicated this can become very quickly. But essentially, that's the concept. And why this is relevant, partially also because, again, this you all know, because MTB comes in different flavors, right? You have these different lineages around the world. The latest count is 10 human adapted lineages, and then a bunch of other lineages causing disease in animals, but I won't talk about animal TB at all. The other thing we all know is that these lineages are non-randomly distributed around the world. And this recent review we wrote, we also attempted to re-estimate the global burden caused by these different lineages. All of this we will see is going to be important for the epistasis part, but just as a quick introduction. And maybe you mainly being sitting in India somewhere, you will be not surprised to learn, and maybe you've seen this, that and be not exactly the first one to show this, that in terms of absolute numbers, lineage 1 is actually the winner, if you count absolute numbers. And that's partially because India obviously has a huge number of TB cases, and a large proportion of those are lineage 1. But so are the Philippines. By the way, the Philippines is the country with the highest incidence of TB. Maybe you know that, based on the latest TB report. And there, what's very interesting is that essentially almost 80% of TB is lineage 1 for reasons we don't understand. But that's actually the starting point. So this lineage 1 is really interesting and important. It's also interesting because, and here I'm advertising another recent review for those of you who are interested in lineage 1. There's not much known about lineage 1, so here we try to put everything together we know about lineage 1. And one thing that we know about lineage 1 is that it's also extremely diverse. So in fact, there are at least 5 so-called sublineages, which are indicated here in different colors. So I'm just showing lineage 1 here, right? Don't get confused with the previous map. And these pie charts around the world are essentially the proportions of these 5 lineage 1 sublineages. And interestingly, there's also phylogeographical substructure, as you can see, towards the Philippines and like Ireland, Southeast Asia. You have more the pink version of lineage 1. Then the Southeast Asia, it's kind of the green one, and then India, South Asia, but also East Africa, you have the other ones. So this further variation there. But now let's get to the epistasis point, and it actually has to do with lineage 1. And it also relates to what I just heard one of the questions or one of the discussions that you had about isoniazid MICs. And as you might know, or as you know, is this the low MICs, right, that are having discussed are usually associated with these INH promoter mutations. And that's a very old study we did a long time ago with some strains in Switzerland. Very low numbers, but that was essentially the starting point. And we kind of revisited this idea that classical INH promoter mutation associated with low MIC to isonize it, and the classical CAG mutations 315 associated with high level of isonize it. And that's essentially true. However, there were some outliers, and that was particularly true here. So if you look at, there's some instances where you have INH promoter mutations only, and still you seem to have a higher MIC than what you would expect. And interesting, there's really tiny numbers, but it just barely reached statistical significance. And that these lineage 1 was overrepresented in these outliers. In other words, lineage 1, even if they have only INH promoter mutation, still some of them will have a high MIC to isonize it. And so we recently revisited this with more data, which is essentially available around the world, and we really see this to be true also when we add many more isolates. So for some reason, we don't know the mechanism, it appears that among strains that have only INH promoter mutation, some can actually have a high MIC to isonize it. And these are overrepresented in lineage 1. And why I'm saying this is an example of epistasis, because that's exactly what it is. In other words, we have the same mutation in different strain backgrounds leading to different MICs. So essentially, that's my first example of epistasis. And why this matters, you can immediately imagine, right? If we say, okay, you have an INH promoter mutation, go ahead and with your isoniazid, just increase the dose. Right? That's essentially the recommendation. Now, if you're facing a lineage 1 strain, perhaps this won't work because some of lineage 1 strains, despite of only having INH promoter mutation, will have an MIC. So that's out there to be tested further. But that was my first example. Second example has to do with something that we have been working for a very long time, which is the so-called fitness, the Darwinian fitness of drug-resistant strains, or rather the cost that some of these resistant strains pay when they become resistant. That could be in growth, in reduced virulence, or more importantly, in reduced transmission. So you have an initial mutation which leads to resistance. From drug susceptible, you go to drug resistance, and that often, not always, but often leads to a reduction in Darwinian fitness in absence of the drug. But because evolution doesn't end there, you have a second mutation, a so-called compensatory mutation that can come up and mitigate this negative effect. So you end up with a highly drug-resistant strain, which at the same time is again highly fit. In other words, maybe equally virulent, also equally transmissible. And so that's a kind of something we have been talking about for a long time, or studying for a long time. But it's important to realize that this is also an example of epistasis, right? Because you have an interaction between the initial resistance mutation with the compensatory mutation that comes later. So that's a clear example of interactions between mutations. And as you might know, 10 years ago, a bit more actually, 14 years ago by now already, we discovered some of these compensatory mutation in RNA polymerase, and this was then also found by others in many strains around the world. But at the time we published this paper, we were kind of criticized in the sense that, you did this in the lab and who cares, and how, you should put these strains into mice to show whether, the virulence is affected. And then we said, you know what, actually, we don't really care about mice. Let's go straight to humans. Now, of course, we cannot do experiments in humans, but what we can do, we can take advantage of natural experiments. And which is the reason we went to the country of Georgia, which is here, for those of you who don't know. And you see, it's it used to be one of the high MDR burden countries, which WHO published in these maps. Very dark red countries have a high proportion of multi-drug resistance among new cases. And Georgia used to be part of that when we started working there, but again, more than 10 years ago. Now it's doing much better. But at the time, that was very much true. And that was the reason we went there, because specifically we wanted to test whether this criticism was true. What we had found in the lab was actually only a lab artifact, or on the contrary, was actually relevant for the real world in terms of transmission of multi-drug resistant TB. And this is essentially the team of the National TB Center in Belize in Georgia who helped us with this study. So this was a nationwide study. The whole point was to get all MDR strains from the whole country over many years and genome all of them, genome sequence all of them, and essentially test the hypothesis: do these compensatory mutations play a role in the transmission of MDR or not? And very long story, years of work summarized here, essentially 6 years worth of data, 1,600 MDR genomes from patients. First thing we see, 70% of MDR strains carry a compensatory mutation. So clearly, these compensatory mutations are there. They're doing something, presumably. It's not just a lab artifact. So that was one of the take-home messages. And in fact, they're actually exactly doing what we hypothesized. So we actually did a multivariable analysis, which is what you need to do if you have also many epidemiological confounders, such as HIV, previous treatment, age, sex, all these additional factors that will also influence the transmission of TB. We had to include here in this analysis, and which is what we did. And essentially, we do find that MDR patients infected with MDR patients carrying compensatory mutations are more likely to lead to a higher number of secondary cases compared to patients infected with MDR strains without compensatory mutations. And this was independent of all these factors I was referring to, particularly also independent of the lineage. So lineage also played a role. And then we had kind of an internal control, which we hadn't really thought of before, but came quite handy as a positive control, which is incarceration. As you know, prisons are very conducive to TB transmission. And so here we had incarceration as an additional factor popping up in terms of increasing the transmission of MDR-TB, which just showed that essentially our analysis is valuable because we managed to rediscover known risk factors. And so that's the end of the second example. I'm going to show you here this triangle that we have been working with. This is our epistasis triangle, where we say we have an interaction between resistance mutations, compensatory mutations, and the strain background. There's many more papers that have shown this in the meantime, so you could look at those. Everything is published. But clearly, these epistatic interactions here plays a role in terms of the transmission of MDR-TB. We also have some data to show that compensatory mutations also involved in leading to higher bacterial loads within patients. So that would suggest within host increased fitness as well. We know compensated strains are more likely to acquire additional resistances. All of this is published in these papers. But so let me now move to the third example, which is unpublished. And that's a different type of epistasis that here a PhD student, Selim, was interested in. So, starting with one mutation, which is the classical RPOB mutation on the one hand, and then now in terms of mutation 2, it's not a compensatory mutation we're interested in, but it's another resistance mutation. The idea is, okay, if you have a strain that have both a resistance to fluoroquinolone and to rifampicin, are they going to interact epistatically? And in which direction? So that was the starting question. And the first thing that Selim did, he looked at all available whole genome sequences that carried at least one RPOB mutation and one GRA mutation known to be associated with high-level resistance to these respective drugs based on the WHO catalog. And so there were 8,000 of those, a bit more than 8,000. And then he looked at all possible combinations of RPOB and GRA mutations. And there were almost 300. There was 997 different RPOB and GRA combinations, so many different combinations. However, what was extremely striking is that 97% of these 297 combinations occurred extremely rarely, so less than 1%. So this indicates that these particular combinations are bad, if you see what I mean, in terms of success of the strains carrying this combination. And this is in sharp contrast to two particular combinations, which I'm highlighting here. So here's just a bit of a menu of different combinations. These two particular combinations accounted for more than 50% of all of these 8,000 genomes. So out of 297 possible combinations that exist in this data set, only two account for more than 50%, which is in sharp contrast, for instance, to these combinations here that are extremely rare. So there's clearly something going on in terms of having these two combinations of mutations. And one hypothesis is perhaps there's so-called positive epistasis happening, suggesting that having these two mutations is actually particularly beneficial for the bacteria. And essentially that's what Selim wanted to test. And so he went to the lab and came up with a so-called matrix of different single mutants and double mutants. So he started off with 9 different clinical strains that were fully susceptible, 3 lineage 1, 3 lineage 2, 3 lineage 4, each belonging to a different sublineage. And then he selected for spontaneous mutants to either 1 drug or 2 drugs, rifampicin and fluoroquinolone, and essentially came up with this this matrix. We couldn't look at all possible combinations, obviously, so we selected 2 RPOB mutations and 3 GRA mutations. And so everything you see here with black dots are the mutants that he obtained just by spontaneous selecting for 1 or 2 drugs. And the gray stars indicate instances where he was unable to generate the respective mutant. And that already indicates that there's possibly negative interactions between some of these mutations, which makes carrying both mutations extremely difficult or perhaps even impossible from the bacterial point of view. And that's particularly true if you look at the last row. You see the H445R, G88C, these are known to be rare mutations generally. And if you have both combined, essentially it's almost impossible to get the mutant. There's only 1 instance that he managed to get it. So that suggests that this particular combination is actually very, very, very bad. And in fact, you actually never see it in the clinic at all. So that indicates we can look at this in vitro. But the real thing he then really wanted to see, he wanted to test for epistasis. And the way you do this, you first measure the growth rate of all the mutants, single and double, always compared to the wild type. And that's what's shown here. I won't go into the details, it just shows you there's a lot of heterogeneity, right? Independent of whether it's 1 mutation, 2 mutation, the strain background, the lineage, the sublineage, everything seems to play a role. So it's extremely heterogeneous. But then what you can do is to formally test for for epistasis. What you do is you essentially plot what would be the expected relative fitness, which is here is just the growth rate of your mutant, of your double mutant, compared to the wild type, based on what you see in terms of the growth rate of the single mutants. That would be the expected fitness, and then you compare that to what you actually measured. So in other words, again, so the expected fitness of the double mutant based on the fitness of the single mutants, and then you compare that to what you actually measure. And so if there's no epistasis, everything will be on the diagonal, which is true for all the points that have a gray statistical support cross, if you will. But interestingly, so there's 8 instances where we have so-called negative epistasis. So these are black crosses. And that suggests that these double mutants are doing significantly worse than what you would expect based on the growth of the individual single mutants. And on the other side, we have 3 instances where we have positive epistasis, where you actually have double mutants doing significantly better than the individual single mutants. And what was particularly interesting that in in 2 of these 3 instances of positive epistasis, we appear to have something which is known as positive sign epistasis. So let me quickly explain here. So here we have 2 strain backgrounds, lineage 2A and lineage 4C. The first column is RPOB, single mutant. Second column is GYRA, single mutant. And the third column in each group is the double mutant. And what we see here is that in both of these cases, in both of these backgrounds, the double mutant was doing significantly better than at least one of the 2 single mutants. And that's what's referred to as positive sign epistasis. And what was particularly striking, if you look at the combination of mutations, if you remember what I showed you earlier in the genomes, these are the exact combinations that do particularly well in the clinic. So what this suggests here, and of course we need to repeat, so the reviewers asked us to repeat this experiment, is that for some reason, these 2 drug-resistant mutations somehow are reinforcing each other when it comes to the fitness of the strains that carry both of these mutations. So this is actually the worst case scenario, because that suggests that if you're resistant to 2 drugs, you could be more fit than if you're resistant to only one of the 2 drugs. The star here, that's to make the story a bit more complicated, the star indicates that this particular strain also carries a compensatory mutation, which was co-selected in the process of generating these mutants. That, of course, that complicates the interpretation, but it just reiterates the importance of the compensatory mutation I was referring to before, that they also contribute towards the development of highly drug-resistant strains. So with this, I'm coming to the conclusion, back to our epistasis triangle, adding more complexity in the sense that the resistant mutations themselves also can interact together with compensatory mutations, as I just mentioned, and the strain background, because we only found this effect now in 2 strain background. So now we're talking about so-called multidimensional epistasis, which together, and this is a hypothesis, might lead to what we have been referring to lately as so-called dominant multi-drug-resistant clades, which are particular MTB genotypes that are resistant to many drugs, but remain highly transmissible. And we think these are particularly key in the local epidemics of MDR-TB around the world, and something that we propose in this review if you're interested. So with this, I'm ending, thanking the funders, collaborators, other members of the group, and thank you very much for your attention. Oh, now I'm not hearing. Did you hear me? Because I'm not hearing you.
I'm sorry,
I
I'm
lost.
muted. I was muted. Sorry. Thank you
Okay,
so
okay,
much.
good.
Thanks for the wonderful talk. And I must share with all the audience here that Dr. Sebastien has been a pioneer, and his first papers on epistasis appeared in early 2000s, if I'm correct. I remember having read this rifampicin quinolone epistatic mutation in the 2006 paper, Sonia Borrell and Dr. Sebastian's paper. Yeah, and with his vast experience and the additional scientific evidence he continues to generate, he is giving us so many insights into how the TB bacterium survives and how it survives stronger and continues to generate mutations to further complicate life for us who have to deal with treating the TB. So I think, Dr. Sebastien, what you alluded to was beautiful, that there is a epistatic mutation between rifampicin and quinolone, the GYRA and the S450L mutation in the RPOB. You have worked in the lineage 1, 2, and 4. You probably did not work on the lineage 3. But in India, we have more MDRs due to lineage 2 and lineage 3. Lineage 1 continues to be the least resistant lineage in India, in the south of India predominantly. And So I was only wondering if this was true, and S450L being the most frequent RPOB mutation, we would have more FQ resistance in the MDR population, which we do not really see so often. So could it have to do with the lineage differences and the sublineage differences, of course? And like I said, it's a triangle. It's probably multifactorial epistatic interaction.
Yes, so this whole question about the 450 being the most frequent, I think that's partially also a bit an artifact of the sequencing efforts. And I think that's particularly true for lineage 1. I mean, we have one small, relatively small study that we did in the Philippines to look at this. And maybe you know, I mean, you'd be in an excellent position to look at this. It appears that 450, maybe that's what you just said, right? The 450 is much less frequent in lineage 1. But the same is actually true to some extent in lineage 4. It's still the most dominant. I mean, it's the most frequent, but it's not as extreme, for instance, as lineage 2. But it's difficult really to get the clear picture because of some of the biases in terms of how strains are selected for sequencing, right? So, but I guess with more and more sequences coming in and being sequencing a bit more agnostically without any particular pre-selection or any other considerations, it's just kind of random sequencing as people, you know, come in. This should gradually clarify this. But my guess is, yes, is essentially what you just said, it's going to be highly multidimensional epistasis going on in all kinds of different directions between resistance mutations, but also between the strain background.
Thank you so much for that. And there's a question on the chat, if I may bring to your attention. This is, can RR strain under any regimen without having rifampicin, the subsequent MTB population give rise to lack of RPOB mutation? It goes on to say withdrawal of antibiotic can give rise to strains without mutation of that particular drug. Would you like to address this?
Yeah, I see what, yeah, I understand it. So this idea, that was actually some of the original ideas of how you could actually exploit this fitness cost of resistance mutation by withdrawing the drug. So I say you have resistance to rifampicin, you say because there's a fitness cost carrying resistance without the drug, you just stop using the drug for a while. And in principle, what you would expect is that susceptible strains would outcompete the resistant strains. And what has been shown in other bacteria, not in TB, because nobody has done this experiment, right? It's difficult to say, if you already have so few drugs in TB, let's just stop using rifampicin, right? Nobody would actually agree to that until you come up with something new. As far as I know, this has never been attempted in TB, but it has in some other bacteria. And as always in biology, it's never black and white. And I think there is one instance, maybe with penicillin or something, I don't remember exactly which bacteria, it seems to have worked. That and maybe actually chloroquine, now we're going to malaria, falciparum malaria in Africa, chloroquine has been stopped using. So in some instances, malaria parasites become susceptible again to chloroquine, suggesting that there's a very strong fitness cost. But in other places, it has not worked. And the reason for this, and we think that if you take the case of rifampicin, my prediction, it would not work. Why? Because you have this phenomenon of the compensation. Once you have a compensated strain, it's too late to withdraw the drug, because if the fitness is equally good as a susceptible strain, there's no reason to believe that the susceptible strains would outcompete the resistant strain that carry compensatory mutation. And in fact, it's even more complicated because this has been shown experimentally, originally in E. coli, very recently also in TB. Jeremy Rock published a paper in Nature. He was looking at other cases of compensation. Turns out, if you have a strain which carries rifampicin resistance and the compensatory mutation, and then you remove the rifampicin resistant mutation, but the compensatory mutation is still there. You have a loss in fitness. So imagine what that means is that if you lose resistance, you become less fit because of the presence of the compensatory mutation. That indicates that the compensatory mutation on its own, alone, is actually deleterious. So together, again, epistatic interactions. If you have a compensatory mutation, there's no way the strain would lose the resistance because this fitness will be reduced. So in other words, the compensation not only increases the fitness of the strain, but it also stabilizes the resistance, because losing the resistance would lead to a decrease in fitness in the presence of the compensatory mutation.
Absolutely. In fact, I wanted to share that we have seen that the DR, the MDR, and the XDR strains tend to grow quicker than the they're in a heteroresistant population. So what you said is absolutely, it explains it all. So a big thank you to you, Dr. Sebastien, for sparing your time early in the morning for the sake of all of us here and the participants who've joined online. We are live on Zoom as well as on YouTube. And I do not think there are any more questions for you, but a big thank you from all of us to you. And look forward to listening to you again. This was a wonderfully stimulating, discussion, and I'm sure the young researchers have a lot to learn from you. Thank you.
Thank you very much, and happy TB Day.
Yeah, happy working.
Yeah, happy working day, yes.
Yeah. Thank you. Bye-bye.
Thank you.
So moving on to the next session, I request Dr. Tamanna to kindly introduce our next speaker.
Thank you, sir, for that enlightening session. Continuing with our program, I would like to invite our next speaker, Dr. Nimalan Arinaminpati. He is a team lead, TB monitoring in WHO Geneva. He is a professor of mathematical epidemiology, Imperial College London. He has authored more than 100 publications and has an extensive academic career at the Imperial College London. He has contributed to global TB strategy, surveillance, and evidence-based policymaking. He also leads the WHO efforts on global TB burden estimation, as well as capacity building in epidemiological and statistical analysis at global, regional, and country levels. Today, he'll be speaking on the way forward, modeling strategies, priorities for ending TB.
Great. Thank you very much. I'll just share my screen. Can I confirm that you can see my screen and my slides, okay?
Yes, Dr. Dim, we can see your slides, and thank you for joining us.
Great. Wonderful, and thank you very much to Dr. Urvashi and the organizers of today. It's a wonderful opportunity to join you all, especially in such esteemed company. And I was enjoying hearing the last couple of talks on the molecular basis of resistance, as well as some of the really interesting narrative around epistatic interactions. But for this talk, I wanted to take a step back a bit and look at epidemiology and basically some epidemiological considerations around what it is we need in order to reach the NTB goals. But if we can't reach the NTB goals, then what are the considerations for intervention priorities to be able to NTB, at least in our generation? So just to begin with, I thought it might be useful to have a look at some of the background history in terms of TB burden and how it has been evolving over time. As many of you are aware, TB incidence has been declining at a global level at a steady but slow rate over the years. And of course, in 2020, we saw these disruptions to programmatic activities during the COVID-19 pandemic, where, as many of you would have direct experience of, TB services got disrupted dramatically. And this was partly because healthcare services got diverted towards the COVID-19 response, but also because of lockdowns and other restrictions that severely restricted patients' access to health services. And so what this meant was that TB notifications decreased by almost 20% in 2020. And our best estimates of TB burden since then suggest that TB incidence likewise has been increasing as a result because of increasing opportunities for transmission. And a similar picture also for mortality. So obviously major shock to global TB programs during COVID-19. But of course, recently there has been another series of shocks as well to do with ongoing funding disruptions, particularly with the withdrawal, for example, of USAID and now the restructuring of funding from the US, but also additional funding disruptions from other countries that were heavily involved in international financing for TB, including, for example, the UK and other countries in Western Europe, as they've been shifting their priorities away from international aid. So I'm just showing you here some studies that came out early on that highlighted the potential impact of these adverse effects in funding on TB epidemiology globally. At the same time, for those of you who are interested, we also, in WHO, we were having a close look at what this meant in terms of case finding in various countries. This is some findings that we published in the Global TB Report last year. And I won't go through this in too much detail, but the main thing to say was, if we expected that notifications were going to be disrupted during that period of funding disruption, that isn't something that we're necessarily seeing yet. So the immediate drop that we saw during COVID-19 isn't necessarily a pattern that we're seeing yet in the context of the recent funding disruptions. But that's not to say that this is, that these notification reductions won't happen. It may well be a delayed effect. And in fact, when we actually ask TB programs, what are the major stresses that they are experiencing, they do actually report that, for example, in TB community engagement, TB screening, diagnosis, sample transportation, all of these potential programmatic areas, that they're reporting seeing a moderate or severe effects as a result of the funding disruptions. So the picture that we're seeing largely is that national TB programs seem to be doing a reasonably good job at the moment of mobilizing resources so that they can mitigate the effects of these funding disruptions. But of course, it's unclear for how long these mitigations can last into future. So it's something that we're keeping a close eye on. So this is just to paint a picture of some of the stresses that are being faced by national TB programs worldwide. And I should say, these stresses are not being felt uniformly. So India, for example, has become almost fully self-reliant in terms of at least the provision of routine TB services, and is one of the countries, for example, that is much less exposed than many others to these disruptions. But in this context, we can look ahead and think, what are the strategic priorities now, right? We've been hit twice, once by COVID-19 and the next by these funding disruptions. But looking ahead, what are some priorities now for the global TB response? And I should mention, there are two parts of this discussion. One is in terms of new financing strategies, but the other is in terms of what we should actually do. In terms of intervention priorities. And I want to focus a little bit more on this second part. There's a lot of really great discussion also happening in terms of this increasingly pressing question of financing strategies. So just to mention, I'll show you a little bit of modeling later on, but I want to say that, you don't have to believe the modeling, right? I just want to show you the data first. And this is what some of the data suggests. So this is from one of the most recent TB prevalence surveys that was conducted. And for those of you who are not familiar, prevalence surveys are these where we proactively go out into the community to test for TB. But unlike active case finding, here we are deliberately choosing communities that are nationally representative of a TB burden at the country level. And so here I'm showing results from Cambodia. This was their third national prevalence survey that was conducted in 2023. If you look at the whole set of TB that they found, and this was basically all sputum bacteriologically positive TB, as well as those who are on TB treatment at the time of the survey, we can then subdivide these according to patterns of care seeking, as well as whether people reported symptoms or not. And this is the subdivision that you see. And so there they found that almost a quarter of people with TB were on treatment at the time of the survey. And but interestingly, over a half of these people prevalent TB were found to be asymptomatic, meaning that if you ask them the classic set of TB symptoms, they reported that they did not have any of these symptoms. Now remember, these are sputum bacteriologically positive patients, so they're presumably infectious. And the remainder was asymptomatic, but I think it's also interesting to note that they were people who were suffering TB symptoms. They did report these symptoms, but they reported that they had not yet sought care. Right, and so these are people, a decent fraction of these individuals who were outside the healthcare system. And of course, there are people who had sought care but remained untreated. And these are people who could be benefited by improved diagnostics and improved TB services in routine care, TB care. And I'm going to go through this very quickly, but for each of these different compartments, for example, there are different interventions. And as I've mentioned very briefly, for this green, these are patients that have presented, and in a sense, the healthcare system, hasn't lived up to the diagnosis that's expected from them. And there are things that can be done, for example, optimizing diagnostic services, improving sputum transportation systems, also public-private mix as well. But I want to emphasize that all of these interventions that are through the healthcare system are really only going to benefit those individuals that have sought care. And remember, there's this huge other proportion of people who remain outside the healthcare system. And so if we look at those, for example, for those who have been symptomatic but not sought care, of course, approaches such as screening and active case finding will be quite important. But I think it's also important to recognize that there's a reason that these patients have not yet sought care. And this is something that we do also need to understand better. Are there barriers in access to care, for example, that can be addressed? That will mean that these individuals are more ready to come forward for their symptoms. And then there's this whopping great proportion of people who didn't report symptoms. And again, obviously, really the main way that in which we can reach these individuals in a timely way is screening, is really going into the community to find individuals who may not even have symptoms, but have an infectious TB. And I wanted to mention here that doing so just with a focus on TB is going to be very difficult in terms of implementation. Multi-disease approaches will be critical. And for example, approaches where we are concerned about lung health in general, as opposed to specifically about TB. And then TB diagnostics could be one part of that general health screening at the community level. So here I'm talking about really finding and treating TB. Okay, this is finding people who already have the disease. But of course, overarching all of this is the critical need for prevention. And we say that TB is a preventable disease. It is, and that's partly because we have existing regimens that can be used to treat TB infection, to protect people from developing the active form of the disease. There is a lot of discussion also about the potential, impact of a future post-exposure TB vaccine. but also, and I'll come to this in a bit more detail later, addressing some of the social determinants of TB, because it is also a social disease. For many people who develop with TB infection who go on to develop the disease, there are socioeconomic drivers for that, and in potentially intervenable socioeconomic drivers as well. So just to mention, we should not neglect the overall prevention side of things as well. So I just want to put all of this together. I just described interventions, but I just want to put all of this together to try and understand what this would mean in terms of the future TB epidemic. Okay, and so and this is where some modeling comes in. But for those of you, I'm sure everybody would be familiar with the End TB goals, which were posed in 2015, and they called for certain reductions in TB burden, TB incidence and mortality by 2030 and 2035 relative to that starting point of 2015. And for example, the NTB goals for 2030 call for an 80% reduction in TB incidence by 2030 compared to 2015, and obviously we're not going to reach that. We're far far away from track to reach this goal. But for the moment, I suggest let's not think about 2030, right? Let's just concentrate on the 80% reduction, and we can ask, well, based on where we are today, how long would it take to reach that? Perhaps it'll be 2040, perhaps it'll be 2050. But what could that date be, depending on our different interventions? So as I mentioned, I'll show you some results from mathematical modeling, and I think it's always important to be modest about what modeling can actually do. I like to make this distinction between projections and predictions. We're not predicting. Okay, what we are doing is projecting what may be possible in future, depending on different scenarios, but also based on our best possible understanding of the available evidence. In this exercise, what I've done is modeled each of the WHO regions separately, and I'm going to show you aggregate global projections for the future TB epidemic. And here I'm specifically focusing on countries that have an incidence of over 50 per 100,000. And I just want to walk you through some very, some broad intervention packages, right? So the first one is what we might call fixing the foundations. And this is basic TB services, doing the basics well, okay? And this means the uptake of modernized diagnostics, molecular diagnostic tools in routine programmatic settings, our best possible support for TB patients to make sure that they can complete TB treatment, and full implementation of current WHO guidelines for TB preventive therapy. The second one is accelerated case finding. So remember, I mentioned those individuals who are symptomatic, have not sought care. There are also individuals who don't even have symptoms. And so it's proactive efforts to reach these people with TB. And as I mentioned, prevention is really important. And so, I'll show you an example of prevention with a future TB vaccine. But this may only be available from 2030 onwards if the current vaccine trials go successfully. And we need a strategy for wide-scale prevention even before then, right? And when I say wide-scale, what I mean is broader than current TPT regimens. And so I want to show a hypothetical scenario of addressing determinants as well. So these are some of the assumptions that we might have, right? So as I mentioned, fixing the foundations all from today. This is something we know how to do, right? And so we could, I mean, these are the assumptions that have gone into the modeling. But broadly speaking, as I mentioned, this is about better diagnostics, better treatment in routine programmatic activities, and TPT. We can also then consider accelerated case finding, and here I'm assuming that this is going to be enough to find and treat a quarter of undetected TB per year, regardless of symptoms. And then wide-scale prevention addressing determinants. Okay, and I want to take a moment just to reflect a little bit on this. So here I'm considering what we might call TB-sensitive social protection and addressing social determinants. And by that, what I mean is there's a lot of social protection that focuses on people who have had TB and helping them to improve their welfare and improve their outcomes during TB treatment. Now, TB-sensitive social protection is really focused on before people even get TB disease in the first place, right? And this is addressing all the upstream determinants, like, for example, poverty, undernutrition, smoking, diabetes, and so on, that may predispose people towards developing TB in the first place. So I know, for example, Dr. Pranay will be speaking in an hour or two on undernutrition, and I'm sure he'll provide a wealth of information on the potential impact of addressing undernutrition as well. But that I want us to see that as one of potentially several different examples. So here, for example, this is the famous study, the rations trial. Which was conducted in India very recently, which showed a really striking preventive effect of nutritional support amongst household contacts of TB patients. Around a 40% reduction in household contacts over a 2-year follow-up. And there's this other very nice study. This is from Brazil. This is basically poverty alleviation. Okay, so here, this study suggested around a 40% incidence reduction amongst recipients over this 11-year study period. So it's quite interesting to see these, these preventive effects coming through in the literature, and we really do need more longitudinal studies. Just to take a moment to mention, here we're looking at undernutrition and poverty. There are other determinants as well that have potential importance and that are intervenable, and that could also be relevant. And so we know that there are other conditions, including diabetes, alcohol use disorders, and smoking, for example, that have pretty strong population attributable fractions associated with TB. Which require further work, right? But if we put all of this together, it's a reasonable assumption to assume that these kinds of mechanisms could reduce the population risk of developing TB by 30% amongst those with TB infection. And then finally, we have the assumed arrival of a new vaccine arriving from around 2030 onwards. So I just want to put all of this together and ask, when will we achieve this 80% reduction when we combine all of these interventions? Okay, so this is global incidence today being projected forward in future. If all we did was just current status quo, we would expect to meet the NTB goals in another 165 years, which is obviously too long, right? Fixing the foundations, doing the basic TB services is going to reduce this somewhat, but then including accelerated case finding brings this time forward to 85 years. But again, sadly, not within our generation. Now, on top of this, we could then include this TB-sensitive social protection that I mentioned. And you can see here now addressing determinant social protection more broadly is a dramatic decrease to just the next 9 or 10 years, right? And the reason for this is that by the time we have done all of this, we've done the best that we possibly can in finding and treating TB, there's still going to be a long tail, if you like, of people with TB infection who are continuing to develop TB disease over the next few years. And unless and until we do something to address that source of incidence, it's going to take a long, long time for NTB as a public health problem. And then a vaccine, when it eventually becomes available, will then have an important impact in bringing this forward even further. So I just wanted to show you this by way of saying, also I should emphasize, by the way, these are all acting one on top of the other. Okay, so they're not individually, but at the end of the day, we do need measures at every stage of the cascade. We do need to get the basics right, but we also need to get prevention right in the long term as well. Okay, so we can show similar picture for mortality as well. And also, we can have similar estimates for how long it will take to reach these targets. But just to start wrapping up, as I've mentioned, the funding disruptions that have happened since 2015, these have been, incredibly damaging in terms of programmatic efforts. Many of you will remember back in 2015, the publishing of the NTB strategy. What was hoped by that time is that by 2025, we'd have a new vaccine, we'd have new drugs and treatment regimens and so on, right? But, excuse me, but if we take ourselves back to that time, I think the really interesting thing is we had no idea what a new vaccine would look like, right? And drug development was also happening pretty slowly. And of course, now, these critical new tools are taking a bit longer than might have been desired, but still, we have a whole host of tools now in the pipeline, and we do have a much stronger sense of what a future TB vaccine might look like, for example. Dr. Urvashi, I think, has also spoken about about existing vaccine formulations, for example, BCG revaccination and India's experience of that too. But these prospects are becoming more real now, and I think this progress is something to be recognized and acknowledged, as well as increasing recognition, as I mentioned, of the intervenable factors that can contribute to a wide-scale TB prevention. And also just to mention, as while we're talking about reasons for optimism and hope, these are some images from wide-scale screening activities that have been happening in India. And thank you to Central TB Division and Dr. Rishi in particular for some of these images. But these are really, in a country as huge as India, these are really impressive, extensive efforts to find and treat TB, even amongst people who have not come forward for care, which as I say, I think is going to be one of the critical ingredients. And also similarly in Nigeria, for example, where again they've been having really wide-scale efforts to find people with TB. Here, for instance, you can see some really geographically difficult parts of the country to reach, but the field teams are undaunted. I mean, they're transporting this screening and testing equipment to even these most remote communities. And so these ongoing and increasing programmatic ambition is, to me, something incredibly exciting in terms of future prospects. So just to conclude, there have been disruptions and there have been millions of lives being put at risk as a result of these. But as I say, these innovations and growing ambition do offer the opportunity to get back on track. But we do need measures to bend the TB curve that will ultimately address all of these issues, doing the basics right, accelerating diagnosis to TB, but also critically having approaches for implementing wide-scale prevention. And as I mentioned, you should be hearing more about later about at least the undernutrition part of the story. Now, at the moment, WHO, we've started now this cycle of reviewing and updating the NTP strategy. And at the moment, this is in its very early stages where it's in conceptual development. But in the coming year, we'll be consulting with a wider audience on the proposed options for what the new NTP strategy should look like. But my expectation is that we will be addressing each of the points that I mentioned just now. So please see this as, if you like, a preview of some of the upcoming thinking for the renewed strategy of post 2030. And finally, thank you, and I'd like to welcome any questions you might have. Thank you very much.
I'm sorry, I was muted. So thank you so much, Dr. Nim, for the wonderful talk and for actually extending your modeling knowledge to bring to us so much about, how Cambodia, how Nigeria, and how the other countries are actually dealing with TB, and your efforts to actually estimate the TB incidence. Of course, we are aware of how much you're contributing and your leadership in designing the NTP strategy going forth. So let me share with you how India has performed in the last year. We've reported 32.65 lakh cases, while the estimates were 27.2 lakh. Of these, close to 11 lakh were asymptomatic. So what you just alluded to, the ACF does work. It is how much effort can be put into, case finding. That is what will show the results. So thank you for, beautifully summarizing what needs to be done and what, how will we achieve what we have set out to achieve. There are, I think, 2 questions in the chat. If I could bring them up for your. So the first question is, would you like to address them? Yeah. So the first question is, keeping in mind the volume of poor quality of sputum samples, how can it be possible to conduct upfront NAT in all presumptive TB cases in resource-restricted nation? Would you like to take that, or would you like me to take that?
Would you have a first go, Dr. Rishi, and then I can add as needed?
So I think this is from Dr. Indranath Roy. So Dr. Roy, I would beg to differ in 2 or 3 parts of the question. The first, you say poor quality of sputum samples, and I'm not sure if you've been with us since morning. You heard at least 3 experts talk about diagnostics, and the world is now moving away from sputum to tongue swab, and the detection is improving. In fact, the detection methods are also moving from cartridge-based or closed systems to open RT-PCRs, and we're getting good sensitivities, good specificity, primarily to the progress in newer methods of dealing with inhibitors in sputum and so on. So I am of the belief that what we call early on as poor samples, now we're moving to even testing induced sputum in asymptomatic TB patients. So what the program has rolled out, last year, what we did was that we started screening the asymptomatic vulnerable population to diagnose or detect disease early, so that we do not let the patient progress to a severe form of TB, which may become difficult to deal with, especially in view of his comorbid conditions. Such patients were offered a screening by X-rays, and like I've shared in the morning, the capability of we have procured close to 2,000 new systems, and as of today, as we speak, the capability within the country of handled X-rays has gone up substantially, and these handled X-rays are being taken in mobile medical units, in camps in the villages. What I'm trying to allude to is that once X-rayed, every abnormal shadow, every patient with an abnormal shadow is encouraged to get a universal DST by offering them a NAT. Often these patients are unable to produce sputum, so we suggest induced sputum or early morning steam inhalation followed by sputum production. And soon, like you must have heard Dr. Nivedita and Dr. Kiran and Dr. Nishant share in the morning, we would be moving on to tongue swabs. Possibly, the earlier concept of lower sensitivity of NAT test for screening may also change with time. What I'm now trying to actually conclude the first question by saying, we need to move on. And the other point I want to address is, when you call a resource-restricted nation, I'll briefly address this. Now, I would beg to differ here because there have been a lot of investment into the whole of health ministry in all areas of health, but especially in TB, we did not, at least I never experienced that I was ever refused a new thing I wanted to bring in. We were able to enhance the NPY to double it. We were able to take the Nikshay Mitra basket to the whole family. We were able to scale up NAT. You know, I've shared in the morning, like I'm repeatedly saying, probably you may have missed it. We currently have more than 10,000 NAT systems across the country. And the consumables for these systems are being supplied by the government. We are one country which is dealing with a huge problem of TB, which everybody keeps on saying the highest burden of TB, but it's all being supported by the National TB Elimination Program under the able leadership of our current Health Minister and our Honorable Prime Minister, who has TB as one of his prime concerns. So if that satisfies your question, like I said, I would beg to differ if you call our country as a resource restricted or resource limited nation. The domestic support deals with the whole of the program. And if at all there is any international support that's coming in, that's primarily for research that is being done under the program as well. Moving on to the next question. Oh, Dr. Nim, you wanted to address this question too, please. Go ahead.
Yeah, thanks so much, Dr. Rishi. And yeah, some really important programmatic insights in those questions. For the point about the incipient TB, it is an important area for development, and there has been some in the last few years some really interesting scientific advances. For example, RNA signatures in peripheral blood samples. It's not yet ready for prime time, but it's something that I hope will continue to see progress, because if we know, for example, who would benefit most from preventive therapy, that would be a game changer. And at the moment, the best we can do is to recommend household contacts and people living with HIV. But as a low-cost, scalable test that shows who would benefit most from it would be incredibly helpful, and could be another strategy for this wide-scale prevention that I was mentioning. That I was suggesting would be the role of social protection. The more such strategies we have for that, the better. And incipient TB guided preventive therapy would be one important such strategy like that. Thank you.
There's one more question they bring up. Can TB LAMP be another cost-effective screening tool for presumptive TB cases? Would you like to take that?
Potentially, yes. It is obviously the current WHO recommendations are for the use of molecular tests, and this is partly because of the ability to, a rapid turnaround for one, but also partly the ability to have drug sensitivity results at the same time as diagnosing TB. And so, yeah, and so those recommendations continue. Yeah, but I also see the question on the pooled NAP testing of sputum specimens as well at the end. And maybe I can just briefly mention about that too. Pooling samples can provide, can be really helpful for reducing costs. There's a potential for some reduction in sensitivity, but where I see the usefulness of pooling is particularly in the screening that I mentioned earlier. And we know, for example, that the cost of bacteriological confirmation can be a real cost driver for screening. And so pooling of samples can be especially useful in cost control for those kinds of interventions. Even if there's a reduction in sensitivity, if there's sufficiently frequent screening in a community, then we could mitigate losses in sensitivity as well. In that kind of intervention context.
Yeah, and like I said earlier, possibly with the newer tests and newer samples, and better systems to deal with inhibitors in different samples, we may be able to actually improve the sensitivity for screening as well. So I think with that we'll conclude this talk. And Dr. Nim, Thanks for the wonderful talk and for addressing so many aspects of what all needs to be done and what all could make a difference to the TB burden. Thank you again.
My pleasure. Thank you.
Bye-bye. I request Dr. Nitya to introduce our next speaker.
It is a privilege to introduce our next speaker.
Please go ahead, Dr. Amita.
Okay, thank you so much, Dr. Singh, and to the AIMS team for setting up this wonderful marathon of TB science and program sort of implementation findings, which is it's just been wonderful to hear some of the lectures. So I also appreciate you having me speak a little bit earlier. So I will go ahead and share my screen, and I've been tasked to talk a little bit about preventive therapy. And so until we have the wonderful vaccine that we all await for, further prevention, and you heard really elegantly from Nimpathy about, the different strategies we can take. I'm here to remind everyone that we still do have a lot of existing tools to continue to roll out and expand, and in particular, TB preventive therapy can be a really important strategy that we should emphasize. So I don't need to tell the audience about the fact that we're sort of understanding a much broader spectrum of infection, particularly the sort of condition of subclinical or now known as asymptomatic TB. But we are still sort of using the language of latent infection to the extent that our tests that are currently available, the TB skin test, the interferon gamma release assay, and I'll also say a little bit about the TB antigen skin tests that exist to sort of be able to detect individuals who have exposure, and some immune reaction to prior TB, and but remain culture negative, sputum smear negative, and are not infectious and have no symptoms. I think the biggest challenge, as we just heard, is that we don't have a gold standard for latent infection, and more importantly, for really being able to know who will go on to develop TB so that we can do more stratified TB preventive therapy. So for the time being, we are still using the current tools we have. And this is, I'm not going to go into the model because this is an older model that now has been updated, and I just updated with Nimpathy's new model, which really shows the importance of combination approaches. And I would beg to say that while we wait for this wonderful new vaccine that we hope will come in 6 years, that we would be using TB preventive therapy in lieu of the vaccine for the time being. And of course, the challenge we have is that, who all should we be providing this to in terms of beyond people living with HIV and household contacts. And that's the challenge we have for mass prophylaxis, is that we currently don't have that test of infection and progression the way that we need to have. But nevertheless, I think that while we fix the foundations, accelerate case finding, address determinants, we should be continuing to optimize TPT, and here's why. This again also is from work from our prior speaker, Dr. Nimpathy, who did modeling to look specifically at the impact of TB preventive therapy to reduce TB in South Asia, and sort of looking at what impact that would have, beyond doing, in addition to improving the TB cascade. And you can see for India that the number to be treated to avoid a case is around the sort of 80 80 mark. So you have to provide TPT to about 80 individuals to prevent one additional case. And that for many interventions, if we can do that cheaply, that's pretty good. We obviously would like to get the number needed to treat to be a smaller number, but that's within reason if it's inexpensive in terms of both the screening and the TB preventive therapy costs. What I also wanted to share was that these are data from the World Health Organization sort of globally. And as we started the NTP strategy as we know it in 2015, you can see we've had a steady increase in really scaling up TB preventive therapy in people living with HIV. However, I think one of the sort of sobering notes is that the numbers have somewhat declined, particularly during the COVID pandemic. And so we'd like to see this yellow bar increase because it is a recommendation to have every person living with HIV be offered TB preventive therapy after they've been ruled out for having active disease. But you can also see with the expansion of the provision of TPT for household contacts, both children, which are in the light green, and in the darker green, the household contacts who are older than 5 years of age, having greatly expanded, particularly with changes in policies. And still, again, there's room for further improvement. And so while this is increasing, we're still not at our intended targets for preventing TB preventive therapy. And importantly, when we start thinking about TB preventive therapy, there are ways for our implementation science and programmatic improvements for us to increase the numbers. So if you can see from here, these are from the latest WHO report from 2025, where there's an estimated 10 million plus household contacts, of which about almost 9 million get reported as being recently exposed. Then we get down to about under 8 million getting screened for tuberculosis, and then a big drop in terms of proportion who get started on TB preventive therapy, and then another drop, they're not as big for those who actually complete TPT. So this cascade of care for TB preventive therapy, particularly identifying the contacts, but importantly, after screening for TB disease, we could do better with increasing the starting and initiation of TPT. These are data, again, from the WHO showing where we are in terms of TPT coverage for household contacts by region. So we're at about the 25% mark of household contacts who potentially should be offered TPT getting it, and doing a bit better job with people living with HIV, where it's estimated 58% of people living with HIV are getting offered TPT. And as I mentioned, there has been some dip in the numbers. India is included in the sort of Southeast Asia region, and you can see some of the trends. And of course, Dr. Avershi Singh will say more specifics about how we're doing in India. So I didn't want to delve into that when we have the world's experts amongst our crowd, and you can ask her how we're doing currently with the latest data from India. We've already heard from many of the prior speakers about a lot of the new tools, particularly in diagnosis and portable chest X-ray. And I direct you to this lovely article that was written by Avershi Singh and CTD colleagues and WHO colleagues, and those from the University College of London, basically sort of really thinking about what lessons and updates from the NTP, what ways we can think about fast tracking progress towards ending TB, and so really employing the tools that we have in a much more broader way. And that's something that India's really undertaken already in a big way. And so it's very exciting to see what impact these tools will have. And we can sort of see if Dr. Nim put these models indeed reveal the projections or actual data that back that up from the work that's happening now in the country. I won't talk too much about these because you've already had several lectures. I'll just point you to a nice editorial that just came out in IJMR today sort of showing that, we're, and there's also Dr. Sebastien then had an op-ed piece in the Times of India, but specifically these new diagnostics hold a lot of promise. And so, using things like the swab, whether it's doing it on the sputa or the tongue swab, and these portable machines that can be decentralized and put into primary health centers with fast turnaround time. And importantly, these are made in the global south, including India and China. And the other sort of approaches where places where we already have the TrueNat or the expert machines sort of really scaling up the ability to take a tongue swab to rapidly diagnose TB as a first screening opportunity is very exciting. And so we really need more implementation studies to sort of look at how well these perform in real life and in different populations and in different settings. But they certainly hold an exciting promise to sort of be much closer to point of care than we've ever been. And you've already heard a lot of about AI-enabled portable chest X-rays. I think that this is very exciting. We're using this now in much of our research settings, but in the programs you heard about these being in mobile vans, in camps that are being done throughout the country and in much of the world. They're truly remarkable, where you can instantaneously take an individual's X-ray and rapidly have a prediction of whether they have findings of TB or not, or whether it's safe to provide TPT. And that's really what you want to be able to do, is to sort of have a negative predictive value, high negative predictive value, using a tongue swab and a chest X-ray to rapidly screen out tuberculosis and then initiate TB preventive therapy. I won't say too much about this because all of you know much about the different skin tests and the TB blood tests that we have currently, which are essentially measuring host immune reactions. One's a in vivo assay, and the other two are in vitro assays. These both, the IGRA, T-spot, and the quantiferon, require more infrastructure and are more expensive. And but importantly, don't cross-react with BCG. And so there's a lot of data on the use of these tests, and could they continue to be used? But we do have some new tools, and the newest one is the TB antigen skin test, for which the CyTB has been approved in India to be used both in adults and now in children. And you can see that these skin tests that are based on ESAT6 and CFP10, but administered as a skin test, have decent sensitivity and high specificity. And in particular, this is important because they have higher specificity in those that have previously been BCG vaccinated. And so now these are going to be, there's some cost effectiveness data for India, and there's now a rollout that's been started to use this test more readily in the country. So I'll now turn my attention to regimens, which is sort of the sort of focus of the remainder of the talk, because I think there's just been so much that's been done in the clinical trial realm of developing shorter, safer TB preventive therapy regimens. It was not that long ago where we basically had 6 months or longer of isoniazid, and that was really all we had. And then subsequently, we've gotten shorter and shorter, down to the point that we now have 1 month of daily isoniazid and rifapentine. And then there's a lot more exciting work happening with actually one shot of long-acting bedaquiline, which I'll say a little bit more about, which could be effectively a vaccine, if you will, until we have an efficacious vaccine. But basically, the idea of you looking at long-acting formulations of therapies that could sort of provide a pan TB preventive therapy. So irrespective of drug susceptibility pattern or exposure, you could think about an approach such as that. And so, so we have regimens for drug-susceptible TB that are now down to 1 month. We have new data on those who've been recently exposed to MDR-TB. For the longest time, we had sort of either multiple drugs using ethanolamide, high dose, INH, and fluoroquinolone, but 2 recent trials have shown the efficacy of 6 months of daily levofloxacin. And then there's an ongoing trial, which I'm co-leading, which is looking at delaminid once daily for 6 months for those who've been recently exposed to multi-drug resistant TB. And as I mentioned, now there's a lot of interest in looking at even shorter regimens that are pan-TB appropriate. So we'll say a little bit more about that. So let's go into some of the data that we've generated. So it's been a while since we have had a shorter regimen, and which was the 3HP regimen. So back in 2011, this clinical trial here showed that a once-a-week dosing of rifapentine plus isoniazid had the same efficacy as 9 months of INH given daily. And you can see here that and in fact, it almost looked superior compared to the 9 months of INH, with the 0.19% incidence compared to 0.43% incidence, and importantly, had lower rates of hepatotoxicity. So for this has been known now for some time, and we've scaled up the use of 3HP for both adults, and have now some new data for both pregnant women and children to expand the use of 3HP, and I'll say a little bit more about that. We then more recently had a trial to kind of take a look at the efficacy of 4 months of rifampin. And there, this trial showed that this regimen of 4 months of rifampin is preferred to the 9 months of isoniazid. It was an open trial. And again, you can see that the rate difference between the two was essentially 0 practically, and that the treatment completion was better with these shorter regimens than these longer regimens. So 15% better treatment completion with the 4 months of rifampin, and that this was also associated with less hepatotoxicity. And so again, coming down from 9 or 6 months down to 4 months or 3 months have been sort of more ways for us to do a better job of getting TB preventive therapy out. And then more recently, a clinical trial, which I had the privilege of being a part of, was ultra short, really short course TB preventive therapy, now getting down to 1 month of INH and rifapentine. And this was done in 3,000 people living with HIV. And you can see this was a comparison of 9 months versus the 1 month regimen. And this was done both in high incidence settings and lower incidence settings. And of the 3,000 people living with HIV, 21% of them had a positive IGRA or TB skin test. So not everyone was at the highest risk of progressing, but you can look at the difference between the groups is essentially minus 0.02. And so meeting the non-inferiority margin very nicely. And that the serious adverse events between the two groups was also similar. So importantly, this regimen allowed for higher completion rate, 97% compared to 90%. And so this has really been a game changer in terms of really reducing the time where people have to be on TPT. And so this regimen now, thanks to, I think, the leadership of the CTD, has been put into policy in India and in several other countries. And so we're going to be really seeing real life evidence of how well is it working in different settings, well beyond the clinical trial findings. And so some examples of this, there was just a paper published in PLOS Medicine, which looked at the safety and acceptability of the 1 month versus 3 months of rifapentine and isoniazid to prevent people exposed in the household or the workplace in Brazil. It's known as the Ultra Corto trial, and it was just published this past month. in PLOS Medicine. This was a phase 4 trial where they enrolled 500 contacts and found that the 1 HP regimen had higher completion rates compared to the 3 HP regimen. But there were some more adverse events with the 1 HP regimen compared to the 3 HP regimen. But the majority of these adverse events were mild. So showing again that with these shorter regimens, and this time comparing two of the most common ones that are being used, that there was overall high completion rates and relatively manageable adverse events. And so this is very reassuring for programmatic rollouts for these regimens. And then importantly, we are generating some data from Pune, specifically looking at both of these regimens, and should be having data from over 500 individuals who've been also compared between the 1 HP versus 3 HP regimen, looking both at people living with HIV as well as household contacts. And that study is now completed, and we'll have data along with other studies that are being done in the country to look at these two regimens for TPT. All right, so I want to just say a few words about TPT in special populations, and what do I mean by that? So in particular, I've spent a lot of my interest. In fact, I got the opportunity to, as an infectious disease fellow, work in Pune, India, and got very interested in TPT in pregnancy. And that was in part because we were working on a HIV prevention, mother-to-child prevention trial, and noted that, during pregnancy and the early postpartum, we were having a lot of observed incident TB events. And so at the time, there was sort of not clear guidance on what to do with TPT in pregnancy. So I had the opportunity to lead this TB preventive therapy trial called the TB Apprise study, and we enrolled 956 women, including women in India and Sub-Saharan Africa and South America and Central America. And the whole goal was to just show the safety and efficacy of TPT in pregnancy. And what we did was, it was a double-blind placebo-controlled trial where we compared women starting TPT during pregnancy or deferring it to 3 months postpartum. And this is in part because at the time there was some guidance about delaying the start of TB preventive therapy until after delivery. And we showed that there was similar proportions of hepatotoxicity between starting during pregnancy and starting postpartum. But to our surprise, we had an observed finding of increased adverse events associated with the 6 months INH regimen if women started in pregnancy compared to when they started postpartum. So the blue bars represent the TPT with INH for 6 months during pregnancy, and the red-orange bars represent starting the TPT in the postpartum phase. And most of these adverse events were driven by spontaneous or stillbirth occurring generally second trimester. We did not offer this in the first trimester of pregnancy, as well as low birth weight. And so these were the two types of events that seem to be most common during pregnancy and were driving this composite adverse events, whereas preterm delivery and congenital anomalies were not found to be statistically different. We then gone on to do studies to look at the newer regimens of 1 HP and 3 HP in pregnancy, and these were just presented recently at the union meeting last fall, as well as CROI this past earlier this month. And we found that these two newer regimens, the main issue here is making sure we dose in pregnant women living with HIV. The PK data suggests that you cannot dose once daily 1 HP with dolutegravir. Dolutegravir given once daily. It has to be given twice daily. But with 3 HP, you can actually safely give it as once daily dolutegravir, as opposed to having to double dose the dolutegravir. So one of the key things with rifamycins are the drug-drug interactions, and in particular with antiretroviral therapy. And so these are data now showing that we can safely give 3 HP with once daily dolutegravir, but with 1 HP, we have to give twice daily dolutegravir. And so we're excited to have some PK data to support the rollout. And then we've also looked at once daily dolutegravir for children who are receiving the 3 HP regimen. Again, you know, these are relatively small numbers, but there's the Dolphin Kids trial that was presented, and they basically all showed that we could do once daily dolutegravir with the 3 HP regimen in children. So this, again, this is specific to children living with HIV. When you're thinking about using the rifamycin-based regimens, we need to know whether we can safely provide the once daily dolutegravir. And so this is indeed the case. Whereas with 1 HP, it's likely that it'll have to be dosed twice daily. Okay, so just moving on to some of the TB preventive therapy for those exposed to multi-drug resistant TB. Wanted to just draw your attention to 2 recent trials that have been completed, one in Vietnam and one in South Africa. The Vietnam trial largely focused on adults and adolescents, while the South Africa trial looked at children under the age of 5. And so this is known as the VQuIN and the TB CHAMP trials. And basically, the goal was to really look at whether levofloxacin, given once daily for 6 months, could be efficacious in preventing both drug-resistant TB development and TB overall. And what was found, and this was an analysis that combined the results of TB CHAMP and VQuIN and was a pre-planned combined analysis, was that there was about a 60% reduction in the risk of developing TB after MDR-TB exposure by administering the once daily 6 months regimen of levofloxacin. And so this is the first time that we have empiric evidence of the efficacy of giving a fluoroquinolone for 6 months to someone who's been MDR exposed. Now, of course, we worry about side effects and potential changes to the microbiome and, you know, obviously evolution of resistance. And so the studies have also started to look at all of those issues. But importantly, what was interesting was that that while there was more adverse events in the VQuIN, and remember, this was in adults, children actually very tolerated the levofloxacin much better than the adults. And so that was an important finding, because one of the key things that we worry about is, you know, exposing children to fluoroquinolones for that duration, is that potentially that there would be more side effects in children. But interestingly, there were more side effects in the adults. And overall, most of the side effects were actually not major side effects, so grade 2 or lower. But nonetheless, this was an interesting observation. And so if you look here, this is actually showing the age-specific effect of the levofloxacin adverse events. So as you go up in age, you have a higher risk of developing an adverse effect, whereas children really tolerated this much better. So those are sort of 2 trials that have informed policy, both WHO and elsewhere. And so I think what's now the sort of proof in the pudding is, you know, really how well will these get rolled out? And that's where implementation science and review of data that are happening now. And I'd love to hear from Dr. Vershi and colleagues about what currently is happening with MDR-TB, TPT. And just in summary, I wanted to say a little bit more that there's, you know, this continues to be a very vibrant field. There's a lot of work happening in TB preventive therapy, while we also continue in parallel work on vaccines. So for example, the Phoenix trial, which I mentioned, is looking at delaminid given once daily for 6 months versus isoniazid given once daily for 6 months. This trial is now fully accrued and will have results next year. There's looking at children who are less than 2 years of age at the 1 HP safety and PK to inform extension of this ultra short regimen for very young children. There's the Asteroid trial, which is ongoing right now, looking at 6 weeks of rifapentine, sort of as without the isoniazid, so an INH sparing regimen. And this trial, Breach, has just opened up. This is a 1 month, once a day bedaquiline that's been started as a TB preventive therapy. And the idea here is to look at it both for drug susceptible and drug resistant TB exposure, so a pan TB TPT regimen. And then the long acting, which is sort of the latest therapeutic that's been developed, a long acting injectable bedaquiline. A phase 1 trial has essentially been largely completed, and now the phase 3 trial is in the planning stage and is being advanced by the AIDS Clinical Trials Group to look at a 1 shot of bedaquiline as a way to do TB preventive therapy. And so long-acting formulations are really of great interest now, and there's several other compounds which are being developed to sort of take a look at this as a 1 shot and done approach in lieu of a vaccine, or in potentially if, as we think about vaccines and whether they're durable, we still will likely need TB preventive therapy as well. And then I'll end on a program that we have initiated in India. And I want to thank Dr. Singh and the CTD leadership for this is an HMSC approved study, which we are now doing in schools as a way to look at TB preventive therapy, active TB screening in schools. Obviously, there's an education component. There's a screening component for TB disease using PSI-TB and the portable chest X-ray. And then the idea is to initiate TPT in those who are eligible. And data from the Dharamshala study that my colleague Kunjak Dorji, who used to be the TB control officer at the Dilek Hospital in Dharamshala and now is at Hopkins, he sort of performed this study and showed an 87% reduced incidence by doing annual TB screening in these boarding schools and day schools in Dharamshala. And so we now want to see, with some of the newer tools of PSI-TB and the portable chest X-ray, whether this is replicable in other parts of India. So in Maharashtra and Tamil Nadu and in UP, where we've initiated the TB Free Schools initiative. So we hope to have some information to see if this strategy has impact. So I'd like to just thank the organizers and open up to questions, and really excited to be part of this wonderful panel of people who've spoken before me and after me. Thank you.
Thank you, Dr. Amita. Do we have any questions from the audience? We don't have any questions, Dr. Amita. Thank you so much for such an extensive talk on the tuberculosis preventive therapies and on the MDR-TBT. This is the most important right now. It is coming up issue and the ongoing trials you have discussed. Thank you so much for a wonderful talk. Thank you.
Thank you. Thank you.
We welcome the next speaker, Dr. Anuj Bhatnagar. Dr. Amita will introduce him.
Now I introduce our next speaker, Dr. Anuj Bhatnagar, Head of Department of Chest and TB, Consultant Chest Specialist at RBI PMT. His areas of interest spans over MDR and XDR tuberculosis. He is a leading expert.
Yes, good evening. Am I audible, ma'am?
Yes, sir, you are audible. You can
Fine.
start.
So I'll just carry you in brief from where was left. I basically carry you through a journey on how the regimen, what are the need for starting a shorter MDR regimen and how we evolved into what it is currently. It has been basically the lessons were from the Mitchell's model of the different populations of bacilli in the body where different medicines acted in different compartments. The lessons were learned from the standard short course chemotherapy for drug-sensitive TB, where an initial bactericidal drug combination was required against rapid multipliers to reduce the infectiousness of the patient, to prevent the spread of the disease in the community, and finally to achieve cure by giving the sterilizing agents that are active against slow and sporadic multipliers. This basically, finally, it was decided that these are the bare minimum requirements for a TB treatment regimen, which whether it is a susceptible TB treatment or a DR-TB regimen. You have to have at least 4 drugs with probable efficacy with parazenamide additionally for MDR-TB. 2 of the drugs must be core drugs, at least one with good bactericidal activity and one with good sterilizing activity, which should go all along the treatment. The other 2 drugs should be companion drugs to protect the action of the core drugs, which may or may not be necessary after the culture conversion. And there has to be, the treatment has to be given for enough time to avoid relapses and ensure cure. So a drug with better sterilizing activity can reduce the time of treatment. What are the drugs we have? You have to have, basically, this is how the treatment evolved after 2016-17. This was the first meta-analysis and IPD, which basically analyzed the data of 50 datasets from 25 countries of approximately 12,000 MDR-TB patients, which was an attempt to study which particular medicines were the best and were responsible for high cure rates. The odds of success were maximized when at least 5 drugs were used in intensive phase, at least 4 in continuation phase, when the duration of intensive phase was 6 to 8 months, total duration of treatment was 19 to 22 months, the intensive phase was continued for 5 to 7 months, and the treatment continued for 15 to 6 to 18 months after culture conversion. But this was for longer MDR-TB. Could these lessons be learned for shorter? Could these lessons be used for shorter? These were some of the lessons that we learned, that the best drugs, and this is how that led to the various groupings of drugs. I'll just summarize it in the next table, that these are the broad actions of drugs which are currently used in the treatment of drug-resistant. Please note that bedaquiline, the quinolone, linezolid, and delamanid, and pretomanid, they have both a high bactericidal action and sterilizing action. So these were the drugs which finally became our backbone for the shorter MDR. Why? You basically have a challenge in designing the regimen. Basically, you have to find the right balance of the minimum number of the drugs and the duration of treatment for a relapse-free treatment success. Remember, the shorter you make your treatment, the more the chances of relapses. You have to achieve that balance, that the patient gets cured in the minimum number of days or the months, and also remains relapse-free. That is your challenge. This is how the story started. This was the earliest definition of shorter MDR regimen, which refers to a course of MDR-TB treatment that lasts for 9 to 12 months, which is mostly a standardized treatment, and composition closely follows one in which there is a documented evidence from different settings. There were a number of issues for a longer 24 months regimen, which had number of defaults, ADRs, high chances of death, approximately 20%. That is a challenge even now in the program, but that has significantly reduced. I will show in the last slide that significantly reduced with the introduction of the shorter regimen. The culture conversions were poor, the chances of missing dose were frequent, and the cost to the program, the logistics were huge. This was the first evidence in 2016 where the evidence was analyzed for different types of shorter regimens that are, the trials of which were carried out in African and Asian sites, which showed that yes, the treatment could be shortened to less than 1 year, which led to the first randomized controlled trial proposal for shorter MDR regimen, which was basically STREAM. What was STREAM? This was the first non-inferiority trial, which had a trial design of, which basically had 4 arms. The STREAM one had 4 arms. The first arm had 24-month WHO regimen, and there are 3 shorter MDR regimens. Please remember, this was the first trial which had a 6-month regimen for MDR-TB. At the end, this was the regimen, which basically was 28 weeks. this was the regimen that performed the best in the field. In this particular trial, it was also proven superior to it. But just because of the fact that the campaign was against use of injectables to the patient because of ADRs and other logistical problems, this regimen was dropped. These were the different regimens. The first phase, stream 1, proved that yes, the regimen B, which was the injectable shorter regimen, could be used in place of a fully oral, the longer MDR regimen for 24 months. The stream regimen, the injectable shorter regimen was from 9 to 11 months. In stream 2, two additional regimens were compared. One was where which replaced the injection kanamycin with bedaquiline for the entire duration of treatment of 40 weeks. And a fourth regimen, which I was talking about, of 28 weeks, which had an initial injectable period of just 8 weeks. We were fortunate enough to participate in this particular trial. One fourth of patients were from India. This, in fact, the CDSCO of India was adamant that we will not drop the 6-month arm because we want this particular regimen to be tested and we want to see the results. The favorable outcome of stream 1 was marginally higher in the control arm, but it was proven, the shorter regimen was proven to be non-inferior, and hence WHO recommended it for adoption in the national programs. That was the first adoption of a 9-month shorter injectable regimen for MDR-TB patients. The stream 2, which actually compared the injectable shorter regimen with the oral shorter regimen, which in fact added bedaquiline for the entire duration of treatment, whether it was intensive phase or coordination phase. And it also did not extent of TB disease on the X-ray as an exposure. The mutation pattern of INH resistance, irrespective of whether it was INH-A or CAT-G or both, was never actually an exposure criteria. And there was the previous history of DR-TB was also not an exposure criteria. With these in mind, you please see the results. The oral regimen had a better outcome than the control regimen, but the best outcome was for the regimen that was of 28 weeks, which had an initial injectable phase along with bedaquiline for 8 weeks. This also showed both the interventions were significantly better than the control. This also showed that BDQ was absolutely safe. There were no safety signals observed due to bedaquiline, and there was no amplification of resistance to bedaquiline. In fact, we studied the patients for 132 weeks, for approximately 1.5 months, 1.5 years after the completion of treatment. There were no significant relapses. So this was the first trial which studied the follow-up of patients for more than 1.5 years after the completion of treatment. In fact, this gave us an idea that any shorter treatment regimen for MDR, it must not only be tested for safety and efficacy, but the drug composition and possibility of resistance amplification, especially to bedaquiline and linezolid. And finally, the conclusion was that 6-month regimen, that is a 28-week bedaquiline-containing regimen, provides a good option without preterminate and linezolid for rapid reduction in the bacillary load on an initial 8-week IP with a second-line injectable and high-dose INH, thereby reducing the chances of resistance amplification. This was one of the biggest learning points of the trial. But by this time, there were other shorter MDR fully oral trials of 6 months or less going on. One of these first was Beat TB India. You might have read about Beat TB South Africa. This was Beat India, which actually was for pre-XPR and XPR TB patients with 4 drugs, bedaquiline, delamanid, linezolid, and clofazimine for 24 to 36 weeks. We were once again fortunate to be a part of this trial. 96% of these patients were pre-XPR, and some of them were MDR with who were non-responders. There was at week 24, quite a number of patients, in fact, more than 90% of patients were culture negative. All the drugs were continued throughout the treatment. There was an inbuilt provision for reduction in the dose of linezolid or temporary interruption. Majority of the patients had extensive disease, bilateral. Majority of the patients had a high bacillary load. The BMI for more than 1/3 of patients was less than 18.5. Interestingly, the lung involvement for these patients, in fact, was extensive. Extrapulmonary TB patients were not included. And obviously, for any shorter MDR patient, pregnancy and lactating patients were also not included. This was a favorable outcome. We had 91% success in these cohort of patients. There was 75% culture conversion by 8th week. Only the side effects that were observed were lingular related, which were myelosuppression in the initial phase and neuropathy later on, and pigmentation due to clofazimine. We also did intense PK and sparse PK for all the drugs, for which separate papers have been published. Once again, adverse events they were not significant at all. Most of them were grade 1 and grade 2. And one of the learning points of this particular trial was that around 80% of patients had a reversal in the hyperpigmentation in approximately 2 years. So, 94% actually had sustained treatment success post-treatment at 48 weeks follow-up. So, please remember one thing. In this particular trial, the confounding factor was that since linezolid was being used for quite a long time now, by the time this study was initiated, there was a possibility of high linezolid resistance. So we, since were not looking for linezolid resistance at that time in regular IRLs, so one of the recommendations was that there might be a chance that linezolid resistance or clofazimine resistance may have been there. One of the options was, recommendation was probably a Beta-LC regimen may be an option rather than BPAL-M with a fluoroquine resistance. And another limitation was the lack of comparator group was one of the limiting factors. Now, this was something which was coming at that time. We all know about this entity which has now taken the treatment of TB to a new height. This, we all know what exactly it is. The best part is it acts both on actively replicating bacteria under aerobic conditions and non-replicating bacteria under hypoxic conditions. This is something which is one of the prerequisites for a drug to take care of persisters which are not dividing, the dormant bacilli. First trial, by this time, when we are already doing DEEP, this was a trial that was already going on in South Africa with 3 drugs mixed phase 3 containing predominant bedaquiline and linezolid, with the caveat that linezolid here was 1200. And because of the linezolid, this gave a wonderful success rate of 6 months of more than 90% of patients. But the biggest problem was linezolid. The tolerance of linezolid. Quite a number of patients had to discontinue linezolid. Approximately 17.9% patients had to discontinue linezolid permanently. If you ask me, only 1/3 of the patients of that entire cohort completed the complete 1200 milligram of dosage of linezolid without interruption for the entire duration of treatment. And yet, this led to a more than 90% success rate, relapse-free success rate 6 months after the end of treatment. And it was exceeding the expectations. The rapid culture conversion to less than 6 weeks, this also gave a wonderful hope that finally we have a drug, finally we have a regimen that can actually cure the patient in six months. So this was the first learning lesson. But once again, the caveat was the dose of linezolid. This was the next phase of the trial, where different doses, and the attempt was made to either reduce the duration of the linezolid of 1200 milligram to initially 2 months, or reduce the dose of linezolid to 600 milligram for the entire duration of treatment, or limit the dose of 600 also to first 2 months. It was found that the best results were given when linezolid of 600 milligram for the entire duration of treatment was continued. Comparable success rates with marked reduction in the side effects. You see the number of side effects, see the number of grade 3 or more adverse events. Treatment emergent adverse events much reduced. This led to the recommendation that yes, linezolid can be used at 600 milligram in this particular regime. Then came practical. Tactical was a trial that ultimately has led to the regimen that we all are using now, the WHO recommended regimen, using the VPAL regimen. This was a trial which compared 4 arms, the WHO standard of care, the VPAL, the VPAL-C, and the VPAL-M. The patients were 15 years of old, microbiologically confirmed. The study was adequately powered. At the end of the stage 1 analysis, 2 arms were carried for further analysis. All 3 regimens actually had, all 3 arms had approximately 1/4 patients who were quinolone resistant. Despite the fact that they were quinolone resistant, use of moxifloxacin resulted in a 77.1% culture conversion in 8 weeks in the VPAL arm, despite the fact that they were moxifloxacin quinolone resistant. This was because of the additional or synergistic effect of moxifloxacin along with beta-glucan and bitomen. Only 2 arms were carried forward that carried the VPAL-M and the WHO standard of care, and this led to the outcome that VPAL-M was much superior to the standard of care, not only non-inferior, but it was superior. All these events, every sort of outcome was superior to the. There were less side effects. There were more culture conversions, the more sustained treatment success. This led to the recommendation that yes, this particular regimen can be adopted in and recommended for the national programs. In fact, a long-term follow-up of the 108-week post-treatment follow-up has revealed that there were 4% relapses in the VPAL-C arm and the 4% in VPAL arm, and there were no relapses in the arm that used VPAL-M. And for these relapses, there was an amplification of resistance to beta-glucan in more than 50% relapses, especially in the VPAL arm. So this was another argument that we used when the Indian National Program justified its use of VPAL-M rather than VPAL even in fluoroquinolone resistance. Then we were still not satisfied. We are Indians. We are still not satisfied. We want more evidence. ICMR designed this trial, which is called as a modified VPAL trial. Now, for us, for our population, linezolid had been used from 2016, and invariably, in more than 2/3 of the patients, we have had the experience of the patient coming and having side effects, because of which the dose of linezolid either had to be interrupted or it had to be reduced. Then a 3-arm trial was designed whether the linezolid dose could be further reduced, whether it could be given, had to be given for 600 milligrams throughout the treatment, or it could be reduced at 9 weeks, or say it could be reduced at 12 weeks to 300. 3-arm trial was designed in which we were once again fortunate to be a part of it. All the patients were MDR or PXVR TB. These were the 3 arms in which a 26-week 600 milligram throughout along with beta-glucan and bitomen was compared with say a 9-week linezolid 600 milligram and linezolid 300 milligram for 17 weeks. And the 3rd arm was for if the linezolid was continued for 600 milligram for 13 weeks and then further reduced to 300 milligram for the remaining duration of time. We found that the 3 arms had similar cure rate, but there was significant reduction in the adverse events in the 2 arms where linezolid reduction was mandated. This was another evidence which we generated that yes, at 9, the minimum duration for which linezolid has to be given at 600 milligram was 9 weeks. After that, it can be further reduced. This is the guideline. I'll also come to the final 3 or 4 shorter regimens which were recommended in the WHO 2025 guidelines. There were 3, based on the NTB study, there were 3 different 9-month regimens which were recommended. These were without bitomen. So they could be given in pregnancy, they could be given in children. The 3 arms were beta-glucan, the BLNZ, the BCLLZ, and the BDLLZ. And the 3rd arm, another arm was based on wheat fiber of South Africa, which was a 6-month regimen of bedaquiline, delaminate, linzo, levo, and clofazimine with the provision of dropping either clofa or levofloxacin based on quinolone resistance report. Now, this is something based on the first 9-month regimen was based on the NTB trial, which was a multicentric randomized control trial with 5 experimental regimens. The population was as per the population that we see in our country, 15 to 70 years age group. Baseline resistance to bedaquiline, linzolid, levo, moxi, clofa, and delaminate was excluded. The linzolid dose was reduced to half at 16 weeks in these regimens. 49 to 60% also had pyrizinamide use, despite the fact that pyrizinamide was used in all the regimens. No pregnancy patient was taken. And per protocol analysis, the 4-drug arm DLMZ was superior. They were all non-inferior, in fact, but the best was DLMC. So these were the drugs. This is the combination of drugs. These were the 3 arms that are recommended: the BLMZ, BCLLZ, and BDLLZ. The time to unfavorable outcome was longer in BCLLZ than controls. Efficacy outcomes were at 73 and 104 week follow-up were similar. Once again, the unfavorable outcomes were least among BCLLZ versus BLMZ, but the problem was that since the number of drugs were less, hence this was the choice of WHO in recommending this regimen as first. But with the advantage that they could be used in nearly all adults, children, and pregnant women with quinolone susceptible MDR or RRT. This is something which our national program did not accept. This was a South Africa study which had a 200 control and 203 study arm study. All the patients were initially started on 5 drugs: bedaquiline, delaminate, linzolid, levo, and clofa. Linzolid or clofa was dropped based on quinolone DST, and this skewed the results. So, initial randomization, 148 patients were started at 5 drugs. The quinolone sensitivity was unknown. In 40 patients, quinolone was sensitive and it was continued on BDLL. And finally, in 4 drugs, BDLC, 14 patients were started was given at the start. But only 40 patients were known having quinolone DST at the start, and this resulted in the entire cohort being given clofazimine for varying duration of time, and hence skewed the final results. We were not able to decide whether the addition of the 5th drug led to a change in the outcomes or not. And more importantly, it was also noticed that there was augmentation of resistance amongst patients with quinolone resistance at the baseline. There were in fact 8 failures, of which 3 were in the study arm, and all 3 developed augmentation of resistance against bedaquiline and clofazimine. In fact, there were 7 relapses, with 6 out of 7 in the study arm, and in 3 of them again, there was augmentation of resistance. These were the 2 factors that actually worked against this particular regimen for our group, and we, once again, the number of pediatric patients was quite less, pregnant patients were very less, and there was no data on the extrapolability. Despite this, WHO recommended this as a regimen of choice for pregnancy and children in less than 14 in those patients in whom ketamine could not be given. But we have not accepted that. Finally, this is the regimen. These are the 3 regimens which are used for MDR-TB. This is as per the choice. The initial choice is VPAL-M. If suppose the patient is not being able to use or being able to be given VPAL-M, then we use the shorter oral bedaquiline containing regimen of 9 to 11 months with the caveat that linzolid is used for 2 months in place of ethionamide. And finally, the grandfather, the granddaddy of all the regimens, if suppose both these could not be given or the patients fail on these regimens, then a properly designed longer oral MDR regimen or HPR regimen can be given for 18 to 20 months. The rollout was under the guidance of Dr. Roshi. The effort that the group under her actually put was tremendous. In fact, I remember that the 1 hour meeting for this used to take 4 hours, and but that resulted in the rapid rollout of VPAL, and the efforts that I'm I can't even begin to imagine the effort that went on her part and her group's part in CDD in getting this drug and finally ensuring all the logistics were in place so that the national rollout could begin on 27th of December in both the Center of Excellences in Delhi, one of which was mine. Currently, it has been scaled across entire country as the first choice MDR even based on the inclusion of public excellence criteria. In my Center of Excellence, more than 1,250 patients have been started on DPAL until date. I'll give you the treatment outcomes of the initial 580 patients. 83.27% are treatment success, either completed or cured. 2.5% required treatment extension, which are also doing well. So if you add these two, it is coming out to be 85.5%, which is not even 5% below the the trial outcome of 90%. 8.9% regimen change. Most of it, majority of it, was because of the detection of dissemination, which my center is doing mandatorily for every patient. We actually actively look for foci at other sites in the body, and if we find dissemination, we actually have to change it to longer MDR regimen. The deaths have come down from 20% to 1.7%. The loss to follow-up is very less. The failures are only 0.5%. And we are actively carrying out the post-treatment follow-up for these patients. This year, 2/3 of the patients of MDR and TB that are coming have been started on this particular regimen. So what is the future? We know that now that the biggest problems are coming with linezolid. This is a new trial that is coming, with Paradigm TB. Once again, Dr. Urvashi had seen this trial. There are 4 new medicines that are coming: Ganfiborol, Robitussin, Delpazolid, and BTZ-043. These may be used in combinations with bedaquiline, delamanid, linezolid, and either the quinolones or the paracetamol for 6 months. This is the first trial that may try for the use of a pan-TB regimen for either 4 months or 6 months. So this will be the first trial that may actually attempt to reduce the dose or the duration of TB treatment to less than 6 months. Who knows? Let us see. Thank you. Thanks a lot. I'm grateful. I'm extremely grateful. Thank you a lot. I finished my screen sharing here.
Yeah, thank you, Dr. Anuj, for such an elaborative talk on the previous studies, ongoing and the coming up ones, and the basics behind the regimen which we are following right now in our country. Thank you so much. Such a wonderful talk. Thank you so much.
Okay, thank you.
We would like to request for our next speaker, Dr. Pranay Sinha. Dr. Tamanna will introduce.
Thank you, sir. And I am pleased to invite our next speaker, Dr. Pranay Sinha. He is working as an assistant professor of medicine in Boston University. His areas of interest include tuberculosis, undernutrition, and climate change. Dr. Sinha's research has shaped our understanding of how undernutrition drives tuberculosis. He has founded and co-chairs the Union TB Undernutrition Working Group. He has published over 90 peer-reviewed articles. Today, he will be talking on leveraging the vaccine we already have, TB and nutrition.
Thank you so much for having me and as part of this very august lineup. And I also recognize it's the end of the day and everybody's heard a lot of talk, so I want to make sure everyone's doing okay. I'd be glad to share my screen and we can get started. Here we go. Let's put this in share mode. All right, so I think we've heard some incredible talks today, sobering ones as well. And there's clearly a sense that we need a vaccine to end this pandemic. I think Nim gave a wonderful talk where, it was very sobering to realize that doing the things that we've been doing will not necessarily get us to our target, at least not in our lifetimes. That 160-year timeline that he provided for TB elimination it doesn't inspire confidence. But I always think back to this chart of the NTP strategy as initially conceived, that by 2025 we'd have a new tool, something that would just bend the curve. And of course, the sobering thing is that our trajectory doesn't look quite blue, it looks more red. Um, and so thinking about the TB vaccine, that even the most optimistic among us only expects in 2030, and that is this candidate, the M72 vaccine, and this is the NEJM study that came out in 2019 showing about a 50% reduction in TB incidence among recipients of the vaccine. The sad part about that is when you look at the results stratified by BMI, you see that the effect of the vaccine is about 80% in people with BMIs above 25, and it's about 40% in people with BMI less than 25. And 25 is not even an extremely low BMI. And when you look at that chart, that map in the top right, which is the WHO Global Health Observatory analysis of prevalence of underweight, which is BMI less than 18.5, you can see in India, for example, about 14% of people, this is 2022, were thought to be underweight based on survey data. And of course, in other high TB endemic regions, that number gets extremely high as well. You can just look at Africa right there. So will the vaccine, even if it arrives in 2030, will it actually work? Will it actually bend the curve? I do not know. And I think we understand that people who are underweight have nutritional deficiencies. In fact, it has been titled and popularized by Dr. Bhargava as NAIDS, Nutrition Acquired Immunodeficiency Syndrome. And we're looking at adaptive immunity, certainly, but also elements of innate immunity that get impacted in people who are underweight, especially people who are severely underweight. So it kind of makes sense that vaccines will not necessarily work perfectly among underweight individuals. I would argue that nutritional support is a vaccine that we have already. And if you think about it in a very simplistic way, what are vaccines supposed to do for us? They're supposed to either prevent the disease or reduce disease severity. And my argument today is that nutritional support can do both. I'll start with reduction of disease severity. And this is incredible work done by my mentees, Megan Carrolley and Shruti George, and they've really done a systematic review of the TB epidemiology literature of numerous high burden countries and shown that there's an alarming rate of undernutrition among people diagnosed with TB. And I show this slide just to say that nutritional support is highly relevant to most of our people with TB. And it's not just that they are underweight, that they have energy deficiency. They also have micronutrient deficiency. So even the people who seem like their BMI is fine, they may have severe vitamin deficiency. This is work done from Report India and led by Dr. Niveda, and she's really shown that there's profound vitamin B complex deficiencies in India, which tracks based on previous analyses of the Indian population. So both macro and micronutrient deficiencies are prevalent. So, if you look at previous literature, the results were mixed. And that's because a lot of the work done was underpowered, heterogeneous. And so we realized there's a real need to do studies. At the same time, there's a tension with nutritional research when it comes to clinical trials, because you can't ethically say, I'm going to randomize this starving person to get food and this starving person to not get food. I don't know what IRB would sort of approve that. And this is also the inherent tension in my work. When I go back and tell my parents what I do, they're like, well, that's kind of obvious, isn't it? That you'd give starving people food. I'm like, yes, you're right. But I come back to the States and I talk to people and they ask me, well, where's the clinical trial showing that nutritional support is effective? And this is an inherent imbalance in who sets TB priorities, right? And I think it is time for the global South, that actually sees these starving individuals with TB to set the priority and say, this is where we want research to happen, right? Or we don't even need further research in some of this stuff to justify interventions. However, I was able to find a really interesting natural experiment in Africa. So these are two countries, Benin and Togo. They're very tiny countries, and they were basically partitioned as a result of recurrent colonization between the Germans and the French and the English. And so basically it's one population divided by a border. And Benin and Togo have very similar treatment protocols. They actually collaborate a lot with each other in terms of developing that. The one difference is Benin provides nutritional support, but Togo does not. So without having to randomize people, I was able to sort of do a quasi-experimental study. And what we found was that people who received food, which was in Benin mostly, they had a 58% increased odds of gaining 5% weight gain. And the reason this is important is that 5% weight gain in the ration study and numerous other trial studies has been associated with reductions in mortality, improvement in treatment success, and reductions in relapse. So it's a very meaningful indicator when you're treating people for TB. Moreover, there was a threefold increase in adherence, basically. And that's important because we talk about screening people and especially asymptomatic TB. How are you exactly going to convince them to take these toxic medications that have adverse effects, right? Why should they do so, right? And so that this to me is the fact that nutritional support is not just a physiological intervention, it's a behavioral intervention as well. Importantly, it signals to people with TB that we understand that this is difficult and we are trying to support them through a very difficult time in their lives. Unfortunately, our study, we were not able to recruit enough people to have the power to demonstrate improvement in cure. However, the directionality was there in the analysis. And crucially, we've probably heard this already today about post-tuberculosis lung disease. You can cure people for TB and yet they can have a dwindling trajectory for the rest of their lives. Dr. Menzies at Harvard has already demonstrated that about half of the disability from tuberculosis worldwide comes from post-tuberculosis sort of issues. And we found that people who received food had were able to walk 69 meters extra in their 6-minute walk tests compared to people who did not. This is a highly meaningful increase because in most studies of CHF, COPD, we see a 35-meter increase to be meaningful, right? And we don't want to just eliminate germs from these people's lungs. We want to get them back to the life they were leading previously, and that includes functional recovery. And so I think what we are seeing here is that nutritional support serves many of the functions that we want it to serve. And of course, again, going back, the Grobler systematic review from Cochrane, that was the most influential review. And when you look at mortality, they only had 4 studies with mortality. So sorry, there was a unmuting over there accidentally. But my point over there is there was a paucity of data. And I remind people, we talk about HIV/AIDS. It took multiple studies, multiple trials before we had an effective antiretroviral therapy. What would have happened if we just stopped at 4 antiretroviral studies and said, oh, we can't treat HIV? And I think the same is true of nutrition. We can't just say absence of evidence is evidence of absence, right? And so when we start adding studies like the Mahapatra study done in India, in Odisha, which again, as well as the Institute study, which is done in West Africa by us, we can start seeing that there's a real impact of nutritional support on mortality. And again, I think we need more studies. And this is where India comes in, because when it comes to statistical power, India is the best. And so thanks to Dr. Urvashi, we did this analysis of the Nikshay Mitra basket. And what we found, and again, we try to be very rigorous about this analysis because one problem with studying public interventions is that if they arrive too late, you have to then survive to get the Nikshay Mitra basket, and the causality can get reversed, right? Especially in a disease like TB, where most of the mortality is stacked up front in the first 4 to 8 weeks of treatment. And so we were very rigorous. We actually analyzed data for people who received Nikshay Mitra basket in the first 4 weeks, and we made sure that we compared people within 2 TB units to each other. Okay, so it wasn't like we were comparing somebody in rural Jharkhand to, the posh parts of Delhi. We were comparing people in the same environment, and we found that there was between a 40 and 60% reduction in mortality. with most of the benefits going to people with very severe undernutrition. And those included those are basically people with BMIs less than 14, which is an alarming sort of state of being. And Hemant Shebade will remind us that those individuals have a mortality rate of about 25% in his T and CET analyses. Importantly, one of the arguments against nutritional support has been forever that it's too expensive, that we can't afford it, right? And this was work done by Julia Galini, who's a PhD student at Boston University. And thanks to Dr. Urvashi, we had data from the National TB program so that we had a credible model. And really, I think the calibration of this model was outstanding. And I will just point out, I'm very proud of this, that this model was actually cited by the WHO in its recent guidance document, all led by a PhD student. And so what we found was that even if you took a very conservative estimate of mortality reduction from a food basket for persons with tuberculosis, you could show that investing, that providing nutritional support would be highly cost effective at a country specific threshold. Okay, so less than $400 per DALY averted, we still have at a pretty wide range. And most estimates of a food basket for a family of 4 is about $20 to $24. But we could go up to $60 and we could still be fine, even at very low estimates. And certainly if you take a 40% estimate, kind of like what we showed just now, you are definitely good up to about $50 per DALY averted. And this is important because if we do this, if we can take Nikshay Mitra and make sure that every person with tuberculosis who needs it gets it, we can save about 100,000 lives every year in India. That's 1 lakh lives every year. That's about a third of the number of TB deaths that we see every year in India. So the scale of this scale of reward here is unbelievable. And this kind of tracks with what Dr. Nimpathy just showed, that investing in social interventions can get us there in 9 years, not 165 years, right? This is a vaccine we have already. And it just takes me back to this landmark Madras trial that we did, right? At the time when we had sanatoria, nutrition was the cornerstone of TB therapy. And then we suddenly got these new drugs and we got distracted. We said, oh, this is all we need. And this was the conclusion, that chemotherapy of patients at home can be successful even if the dietary intake is low throughout the period of treatment. And to me, this is a classic case of throwing out the baby with the bathwater. Right. And I think now we are finally, 60 years out, we are finally taking steps to go back and rethink how nutrition shapes everything from TB progression to TB mortality. And this is the conceptual framework that come up, and it was part of the WHO guidelines recently. And again, it just says that it's not just about giving people food, it's also about thinking about alcoholism, HIV, age, parasite infections. All of these things play in here. So hopefully I've convinced you that we can leverage nutritional support to reduce disease severity through behavioral and physiological mechanisms. Now let's think about prevention of disease. So we all know about the log linear association between BMI and TB incidence. Basically, Peter Cegelski's work and Knut Lundroth in 2010 had really shown that per unit BMI increase, if you go from a BMI of 18 to 19, your risk of TB drops 13.4%. Well, Matt Saunders and Peter Cegelski went back and actually updated that literature, and this is a breathtakingly beautiful systematic review, and they really demonstrated that actually the reduction is like 18% per unit. So if you take somebody who's got a BMI of 16, they're severely malnourished, bring them up to 19, which is still very, very thin, you've now had a 54% reduction in TB incidence. Coincidentally, that is exactly the same reduction that we saw on average in the M72 vaccine study, right? And it makes you wonder if that 80% reduction that you saw in people with BMIs greater than 25, was that because of nutrition and not the vaccine? I don't know. And we see this effect in people with HIV as well, especially at low BMIs, and even among persons with diabetes. Because again, one of the very confusing feedbacks I get on grants is, oh, this is great that you can prevent TB, but what if you cause diabetes instead? And I'm not saying that we should be indifferent to the metabolic consequences, the cardiometabolic consequences of nutritional support for people with TB. In fact, everything, all the data that exists right now supports the fact that people who survive TB end up having huge problems down the road with heart attacks and strokes. And we should shape our nutritional baskets to be nutritionally sensitive, not just maximizing calories, not just giving people 25 kilograms of rice, right? We should have a balanced nutritional intervention, 100%, but also not over worrying about that risk with diabetes and starving people instead, right? Which has been a very confusing feedback I've been getting over the last few years. And interestingly, the WHO is potentially systematically underestimating the impact of nutrition on the global TB pandemic. Already, they admit that underweight people, that undernutrition is the leading contributor to TB worldwide in terms of TB incidence, more than HIV, which is stunning. But some of the work that we've done, Matt and Finn and I, has really shown that actually this comes from a fundamental misunderstanding of the risk associated with underweight, and that when we take more reasonable estimates, which are derived from his systematic review, we can pretty much attribute about 28% of the global TB pandemic to undernutrition. And in India, this is more like 50% in every single state. So what, one of the questions was, would it be cost effective to act on nutrition? And again, I'll be revisiting this from a TB prevention standpoint now. Previously, we were looking at reduction in TB mortality. Now let's look at TB prevention. So if you just look at the rations intervention for household contacts, it has a ICER of $289 per daily averted, and that's per my Markov model. Finn and I sort of also made a transmission model, which was brilliant and showed actually that it would be $169 per daily averted. This is highly cost effective, right? And just compare this to other interventions that we do enthusiastically, which have their ICERs in thousands of dollars. Right. So this is where, that whole argument, we can't afford to do this, right? So we can't afford to give a food basket, but we want to do care for like really fancy MDR-TB care. Like, I feel like we are chasing our tail here. And importantly, there's also that black bar there that's eliminating undernutrition. This is a previous model I'd made, which looked at leveraging PDS to eliminate undernutrition in India. It's a hypothetical sort of idea. But if we can do that, and we leveraged a very expensive diet to do this, but even then we found that it would be highly cost effective to eliminate undernutrition in India, and we would see mortality and incidence reductions on par with rations and on par with historical precedents, which I will share in a second. So this is all an argument to say this is cost effective. Don't let anybody tell you otherwise. And then, of course, people come back to me and say, well, Pranay, you're talking about food baskets. Isn't that very indirect, right? Sure, it'll help people. It'll reduce catastrophic costs, all of that. But we are just here to cure TB, okay? That's our mandate. We're not the World Food Program. We're the TB people. And I get that. But even there, I feel like Dr. Mandal and Dr. Tate's analysis is fascinating. So this is something we did again with Dr. Urvashi, really looking at the comparison between providing TPT and food baskets. And what we found was that, again, food baskets are comparable to TPT. And that's specifically because not only are you seeing reductions in TB incidence, you're also seeing reductions in mortality among persons with TB. And you'd have a very modest assumption about mortality to be similarly cost effective to TPT. So that is crucial over here. And just make a point here that independent of its impact on TB, eradicating undernutrition is a public health best buy. So when we think about nutrition, we always ask the question, well, does it matter for TB? Well, every single organ system in the body is affected by nutritional status. And so it is critical to sort of not be myopic in our lens or have tunnel vision to TB, because that action on nutrition is going to increase the economic productivity, is going to prevent all manners of malignancies potentially by acting on micronutrients. And so let's not be blind to the collateral benefits of nutritional interventions. And this is work done by Matt Saunders and Pete Dodd fundamentally. And what we showed in this paper was the scale of reduction in TB incidence worldwide. And in India, if you just focus on India, we're looking at a 45 to 50% reduction in TB incidence in India. If we are able to eradicate undernutrition. And so this is thinking above our level, so the sort of at least what we can do right now, what we can do today is act on household contacts nutrition. But what we can do as a government is acting on population level on nutrition. In fact, somebody in my master's used to say that the Minister of Finance has more to do with the health of a nation than the Minister of Health. And lest this all seem pie in the sky to you, I will point out that Massachusetts, where I'm sitting right now, they had a higher mortality rate, much higher mortality rate than India from TB back in the 1860s. And most of that mortality rate, there was an 85% reduction in that mortality rate by 1945. Right? This was before we had streptomycin. This was before BCG was widely available. And this was not because we had sanatoria, which are basically hotels for the rich, to get better, right? It's because of socioeconomic progress. And one example is the average US Army recruit had a BMI of 19 at the turn of the century. And by the 60s, their BMI was 23. Right? And I'm joking about Captain America here, but that tells you a little bit more about what is going on in the population. And we don't have to wait 85 years for that in India. I think with sort of directed focus and good policies, we can get there faster. And so I'll conclude with the fact that food may be the vaccine that we have already but are not using, and that the sort of the new tool that we needed is one that we've had in our grains, in our warehouses, in our grocery stores all along. And I'll just remind us all that a vaccine sitting in a warehouse saves no one. Neither does evidence sitting in a journal. The TB vaccine we already have is waiting, not for more data, but for us. So thank you so much for your attention today. I'm happy to take any questions.
Brilliant as always, Dr. Pranay. We're honored to have you and your perspective and practically every bit of evidence put together. Thank you so much. And we'll see if there are any questions. There seem to be no questions for you, Dr. Pranay, but it's an honor to have you with us, to have brought in all the evidence in the field, shared with the participants, and this will stay on the YouTube in the long term. And, what's, the way you put it and the way you summarize the whole message is the most important message. Even for the program, we've been able to do phenomenally well in India, but I guess there is always scope for improvement. And like you said, the burden is close to 50% in India. We need to devise more ways of how to actually support, these low BMI, possibly a population level intervention with nutrition. That should be the final aim. And like you said, it'll be a multi-pronged effect it could have on several infectious diseases and so on and so forth. So thank you.
And I just want to thank you as the DDG. You've done more to advance the cause of nutrition than anyone else. And I really think India right now is at the leading edge. We did a landscape analysis of sort of what is being done nutritionally for people around the world. And we did not find that any country was doing more than India was. And this is a field in which we need to advance both the knowledge, but also not just scientifically, but also in terms of implementation. So I really thank you for all that you've done to advance the data and implementation for that. Thank you.
Thank you again. So we'll move on to our next speaker. We're running a little late. Thank you and bye-bye. Dr. Nitya, please introduce our next speaker.
I extend a hearty welcome to our next speaker, Dr. Rakesh Kumar, Additional Professor of Community Medicine, All India Institute of Medical Sciences, New Delhi. He has extensive experience
Dr. Rakesh,
Yeah, is it audible?
have you? Yeah, we can see your slides. Please, you can start.
Okay. Thank you, ma'am, and thank you for giving me this opportunity. So actually, one of the kind of positive for being slotted between two stalwarts, Dr. Pranay on one side and Dr. Pai on other, is that all that I have to do is to rush through my presentation. And one positive is that Pranay has already kind of covered a kind of big part of what I'm going to present now. So the topic is energy-dense nutrition supplement for management of undernutrition among patients with tuberculosis. So this is going to be my outline, that is undernutrition and treatment outcomes in tuberculosis, evidence on effect of EDNS on nutrition parameters, on treatment outcomes, acceptability and adherence of EDNS among patients with tuberculosis, what are the research gaps in future direction, and the conclusions. So let's start with when I was about to, I was started preparing the presentation for this, and I looked at the theme of this year's World TB Day, and that is, yes, we can end tuberculosis. But when I start looking at the kind of IC material and other paraphernalia, probably nutrition was not given as much importance as it should have been. And then I thought that probably this is one occasion when I can highlight the issues related to nutrition and EDNS in particular, because we have been associated with that. So this part, I think Pranay has covered quite in detail, and he presented about the effect of undernutrition on disease severity and how nutritional supplementation reduces the disease severity. Just to reiterate it again, so what Rationstyle told us that when they beautifully brought in the whole kind of association between the baseline weight and mortality, etc. So what was striking was even 1% gain in weight by 2 months of treatment, that reduced the hazard of death by 13%. 5% gain was by 2 months, and that Pranay alluded to, had reduced the hazard of death by a hopping 61%. So what you can see is that even a modest gain in weight in patients with tuberculosis can reduce the mortality by a big margin. Undernutrition has also been associated with other unsuccessful treatment outcomes, delayed sputum conversion, severity of adverse events increases, and poor adherence as well. One other thing is that the other part of it is catastrophic expenditure. So what we have also seen is that the lot of expenses, out-of-pocket expenditure that a patient with tuberculosis make is on nutritional supplement, and that adds to the kind of catastrophic expenditure in this poor households. So we can see that undernutrition not only is associated with poorer treatment outcomes, including mortality, but also contributes to the catastrophic expenditure in these households. So I will focus mainly on one part of nutritional supplementation, that is energy-dense nutritional supplement. And what is the rationale for using this energy-dense nutritional supplement is, we all know that tuberculosis is a state of catabolism, and energy requirement is much higher. As per NTP, what is suggested is that it should be 40 kilocalorie per kg body weight per day, and protein requirement is also very high. So standard diet alone will not be able to provide the higher calorie and protein requirement. So what EDNS does is it is suitable for delivering high calorie and proteins in anorexic patients. We have to understand that most of the patients of tuberculosis are anorexic. They're not able to eat, at least in the initial few months. So we have to supplement them with a diet which is rich in energy, rich in protein. The other advantage of EDNS over food basket is it is ready to use, self-stable. So almost you get a stability of almost 2 years, and it can deliver precise quantity of macro and micronutrients, especially in the scenario in India where there are a lot of food insecurity is there. It also avoids household sharing and preparation issues of food basket. And we have got a rich experience of using EDNS for severe acute malnutrition children. So all of these kind of makes EDNS a very attractive option for nutritional supplement in undernourished patients with tuberculosis. And what we see is that WHO in recent guidelines for nutritional supplementation, which suggests that nutritional interventions should be offered to individuals with TB who has severe, moderate, or mild undernutrition as part of the comprehensive package for TB care. So the nutritional intervention that they are talking about also includes specially formulated foods like ready-to-use therapeutic food, ready-to-use supplementary food, or fortified blended foods. Now I will just take you through what is the evidence with respect to EDNS on various parameters. As far as weight gain is concerned, there is enough evidence that it leads to robust weight gain. So in the study that we conducted here in Faridabad, what we could find that the odds of 5% weight gain at 2 months was almost twice more than in the non-intervention group, in the control group. And the odds of 10% weight gain at 6 months was almost both 2 times more as compared to the intervention group. And the weight gain was higher throughout the period of intervention through the 6 months. And there has been reports which there have been studies which has reported not only on the weight but also a kind of effect of EDNS on increase in lean mass and grip strength as well. So it has been shown kind of quite promising as far as improvement in the nutritional parameters are concerned. As far as treatment outcomes is concerned, it has also shown to improve treatment success rates and time to sputum conversion. There are studies which have also reported that increase EDNS has kind of led to increase in viability of anti-tuberculosis drugs like rifampicin. Though one kind of handicap is that most of these studies which has looked at the treatment outcomes are not powered enough. They are small studies and heterogeneous in terms of the kind of EDNS used or kind of total calories kind of provided. So that is a bit of kind of evidence gap. But whatever data is there, that is quite promising. Just to say that treatment, there is an improvement in treatment success. Next parameter that we looked at is the acceptability and adherence to peanut-based EDNS, and that was fantastic. Most of the studies that have been done have reported near universal acceptance of peanut-based EDNS among patients. Adherence were quite high, and a lot of people and a large proportion of patients, they never missed a kind of dose of EDNS. So various parameters related to the acceptability, it was quite high. So EDNS has been shown to be acceptable to the patients with very high level of adherence. There was some concern regarding the side effects of EDNS, but most of them are minor. So nausea, vomiting, and abdominal fullness were present in the EDNS groups, but that didn't lead to treatment interruptions, and that didn't affect the adherence. And it has shown to have no effect on lipid profile or blood sugar profile or the liver function, etc. So by and large, this is found to be safe with minor side effects, but that didn't lead to any interruption treatment. So the next question is how much should be given, whom it should be given, and how it should be kind of implemented. So there are different forms of EDNS. It can be as a part of sachet with the peanut paste, or the others have also used kind of biscuits, bar, or wheat flour, I mean the enriched flour, or maybe in the form of laddus, etc. So it has been used in various forms. Each form has its own pros and cons. So what sachets does is that they increase the shelf life, that allows kind of standardization of content, and that can be scaled for a larger distribution, etc. Locally prepared energy dense foods are more acceptable, but to maintain kind of shelf life and for a kind of scalable, it may not be scalable. And most of the trials have assessed the efficacy with the daily provision around 500 to 1000 kilocalories of EDNS. As far as implementation feasibility of EDNS is concerned, as we all know that it has now been introduced into the NTP in India. So it is very much feasible to introduce this in to scale it up in the program, because the product is ready to use, self-stable, and there is no cooking or water is needed. studies have reported, and I just shown that there's a very high level of adherence and acceptability. It can be kind of, there's not any major side effects. Minor GI tolerability are there, but it is manageable. And it can be, and it should be used as a complementary to other schemes like Niksha Poshan Yojana or Niksha Mitra, etc. is there. So based on these parameters, it is it can be scaled up, it is feasible to be done. As far as challenges and the future direction is concerned, there are, as I talked about it earlier, there are some certain evidence gaps, and that I'll talk in the next few minutes. Most of the studies which have looked at the kind of efficacy and other things are not a very large pragmatic trials. They are kind of smaller kind of trials. Equity issues is there, so reach in the rural and tribal populations that we have to ensure the scalability. Though it is eminently scalable, it can be scaled easily. But in a country like India, it will be a kind of, it will have some challenges. And so what are the research gaps? Some of the research gaps that are there is what could be the ideal composition of EDNS. So we know that what could be the calorie content or what could be the protein content, but other micronutrient, what should be the content, what micronutrients to add. Because one thing also we have to understand that adding more micronutrients to the composition increases the cost, and then cost effectiveness issues are there. So what is the ideal composition and duration of nutritional supplementation, whether it should be given for 2 months, given for 6 months, or during the TB treatment and afterwards. So these are the issues that requires more research and more evidence to be generated. Then if you look at it in India and from abroad, there's no study which has compared the effectiveness of various forms of food support, that is either EDNS and food basket. So their head-to-head comparison does not exist. So probably that is one area where research needs to be conducted, like comparison of the effectiveness, feasibility, acceptability, and cost effectiveness of different interventions such as food basket, food vouchers, cash transfers, EDNS, etc., including in the communities. So head-to-head comparison, probably we need to generate that data. The one area where, again, there is not enough evidence is what could be the optimal nutritional management among people with diabetes, because most of these trials that we looked at, including our trials, the patients with diabetes were excluded. So obviously the results cannot be extrapolated to them. And as we know that diabetics have their very specialized nutritional requirements. So what could be the ideal scenario? So these are some of the research gaps which needs to be taken into care going ahead. Most of them can also be done in the programmatic mode because program has already implemented that. So many of these can be done. So just to conclude, and obviously we also looked at the modeling data on cost effectiveness, what Pranay just presented, that adding EDNS makes the whole thing even more cost effective. So just to conclude that EDNS, especially the peanut-based EDNS, are effective for rapid weight gain and nutritional recovery. One thing which is the highlight is that it is very much acceptable among the patients with the tuberculosis, and it is easily, feasibility is very high for a scale up in high burden countries like India, and it is critical to break the TB and nutrition cycle and achieve NTB goals. So just to kind of take it forward from where what Pranay emphasized, that nutritional support is not optional. It is integral to patient-centered TB care if we really want to eliminate tuberculosis in India. Thank you. I'd love to take any question at this one.
Thank you, Dr. Rakesh. That was a wonderful talk. If there are any questions on Zoom or YouTube? So, Dr. Rakesh, I was just wondering if you'd like to draw a simile between the outcomes of the rations trial and the EDNS trial?
Yes, ma'am. So if we just look at the head-to-head comparison, only what we can do in the weight gain. So how EDNS trial and rations trial were different is because in rations trial there was no control group actually, as far as patients with tuberculosis is concerned. And among controls, of course, there was control group, but in patients with tuberculosis, there was no control group. Both the groups got the food support. So the weight gain, what we saw in our intervention group, was almost similar to what we saw in the Rassens TB group. So that was one thing. Another is, and that is almost similar. So 5% weight gain at around 2 months was around 54-55%. Similar in Rassens, same in our study. And that is acceptable because almost the kind of calories that were given in rations in our study is almost similar. So we were giving around 1,000 calories and Rassens were also giving around 1,200 calories. So almost nutritional support in terms of calories were similar and the weight gain is also similar. What was different in our study is there was also a control group. So we know that what is the gain vis-a-vis the control group in our study, and that was highly significant. So the likelihood of 5%, the odds of 5% weight gain was almost twice in the intervention as compared to the control.
So an excellent talk, and the carry-home message is loud and clear. The National TB program was also able to adopt EDNS for patients less than 18.5 BMI in the first 2 months. This was a recommendation given by Director General ICMR to the program, and the program was able to adopt it. The study and as well as the ration study were both supported by ICMR, and the outcome is for the world to see. In fact, rations study was published earlier on, so it's common knowledge. In fact, no nutrition talk goes without referring to the ration study. I am sure the EDNS study will also follow in its footsteps, and like the National TB program could adopt it. We have done all the work behind the adoption. In fact, a lot of support from Dr. Rakesh, Dr. Pranay, in the nutrition guidelines for the National TB program also, and in designing the components of the EDNS, fine-tuning them by acknowledge all the kind of support they've both provided. So thank you, Dr. Rakesh. We are much delayed, and I just hope Dr. Madhukar Pai is still here with us. We'll move on to Dr. Madhu's talk. Thank you, Dr. Rakesh. Bye-bye.
Thank you, ma'am.
Can someone?
Yeah, we're just introducing you, Dr. Madhu. Dr. Nitya.
And then open the video. Yeah.
I'm honored to introduce our esteemed speaker, Dr. Madhukar Pai. He's Professor and Chair, McGill University, Montreal. He has a vast area of interest, including tuberculosis diagnosis, quality of care, public-private partnerships, and implementation sciences. He holds a Tier 1 Canada Research Chair in epidemiology.
Thank you, Dr. Madhu. Look forward.
I hope my slides are visible.
We saw them briefly, but now we can't see them.
It should come on now. All right.
We can see them, yes.
All right. So I know I'm the last speaker, so I'll keep mine very, very short so that we can all finish the day.
You made it an ultimate speaker. My talk is not yet done.
Okay.
Sacrifices.
All the more reason why I should be quicker. So I think I want to basically talk about the chaos and the turmoil in the world of TB right now. In the last year or so, it's been really devastating. But even before that, TB care was seriously disrupted due to COVID-19. We all know that. We lost a lot of ground, several years of progress during the first couple of years of the pandemic. And as we were limping back towards some level of normalcy, we've now been hit by devastating funding cuts. So USAID no longer exists. The US government has withdrawn from the World Health Organization. In addition, multiple G7 countries have cut their international aid, including Canada. UK has cut UK aid, which is like the biggest cuts in the history of that organization. All of this makes for a very, very, sad story in terms of countries that were heavily dependent on aid for the tuberculosis, HIV, and other programs. So here are two modeling studies, one by Sandeep Mandal and colleagues, and another one from the London School Group. Overall, if you count all diseases, the prediction is about 25 million more deaths because of US cutting its global health funding. But for tuberculosis, Sandeep's modeling suggests that across 26 high burden countries, termination of US funding could result in an estimated 10 million additional TB cases and about 2 million additional TB deaths in the next 5-year period. I think regardless of these models, even if they're not as bad as predicted, the fact of the matter is global health and development as we knew it no longer exists. We are seeing a devastating withdrawal from genuine multilateralism and global solidarity, and global north countries are basically going it on their own. They don't feel the need to be connected in any way to the rest of the world, leaving global south countries, especially poorer global south countries, in a really bad place. And I think this article was making the point that global health as a charity model is a failed model. What we really need in the coming years is genuine leadership and self-dependence by global south countries, especially for diseases like tuberculosis. As we wrote in this article, the future of TB should not be decided by Washington or Geneva, but should be decided in New Delhi, Abuja, Pretoria, or Jakarta, where political will, domestic investments, and innovation can make sure things will get done because of their leadership, not because of charity from the global north. I think in this situation, I know for a fact that India is not reliant on aid. And to that extent, this lecture really doesn't matter much for India. But many other countries do rely on aid. And for them, I think 4 approaches are worth considering. And all 4 of them, I think, should be driven by global south high burden countries. The first is greater integration of tuberculosis in universal healthcare and primary healthcare. Much more domestic resource mobilization, not reliant on aid. Social protection, which Pranay and Rakesh and others very nicely covered. And affordable global south innovations and manufacturing of tools and medicines and tests in the global south, so we are not relying on expensive imported products. So the first issue of integration of TB into primary healthcare is something that we've been discussing for a very long time. As more and more funding cuts are happening, these vertical programs are going to disappear slowly. For example, the entire UNAIDS as an organization is scheduled to be sunsetted. I think independent vertical programs will shrink. The Department of TB at WHO is now Department of HIV, TB, and sexually transmitted infections and hepatitis. Just to illustrate that everybody in face of scarcity is forced to consolidate. For us, as much as we would like separate independent vertical TB programs, we have to make sure we are aligned with a country's universal health care plans and embed ourselves within the PHC infrastructure. And to a great extent, India is already doing that. Much of India's TB care happens through the National Health Mission, and the integration is already happening. But the more we integrate TB into primary care, the less and less reliant it will be on vertical programs. Vertical programs can still offer monitoring, evaluation, and set policies and procurement, but the delivery of services should be more horizontal. The second issue is domestic resources. This is a beautiful article by 4 health ministers of Indonesia, Nigeria, and South Africa as well, and Brazil. So basically what they are talking about it are opportunities to increase more money by domestic investments. For example, taxing tobacco or taxing sugar, taxing things that make us sick is one way you can bring more money. Engage with development banks for results-based financing, swap debt for health, tap funds in the climate finance, and leverage private sector resources. So I know India has dramatically increased domestic resources for TB, but other countries need to do that as well so that they're less and less reliant on aid. I think the social protection agenda came through very beautifully in the last couple of presentations, so I won't say much about it. We know it works, food, cash transfers, we know they work. Only question now is how do we make them universal, that every family with tuberculosis patient will and should receive these social benefits. And the last thing I'll say is it really is more than time for affordable global south innovations. I think this trickle-down model of products being developed in California and then taking 20 years for it to reach rural India is simply not a model that we should be considering. For example, if India had not made their own COVID vaccines, India would have been left behind and things would have been much, much worse. So every country and region should have the ability to manufacture their own medicines, tests, and vaccines. And I think this is already happening. Urvashi and Samir and I wrote this piece that as aid cuts threaten progress, global south innovation can close the gap. Look at the number of products on this slide that have all come from the global south, whether it's digital X-ray solutions from India, whether it's IGRAS from China, near point of care tests from India and China. There is so much happening in this space. And I think these affordable products from the global south will be our pathfinder in the future. So if you look at the last month's WHO policy on near point of care testing combined with tongue swabs, we have several products from the global south, the Plus Life product from China, the Uniamp product from Huel, the TrueLice and the TrueNat tongue swab-based products from Malbio are all examples where these, if they become highly affordable and can be scaled up, can become pathfinders for all global south countries at a period where aid is rapidly disappearing. And just to say that, look at the dramatic difference in cost when the products come from the global south. So the Plus Life product is already available at $3.6 per test compared to almost $8 plus for GeneXpert via Global Drug Facility, and is already being rolled out in 13 plus early adopter countries. And those are all pictures of the product being used. So that's basically what I wanted to share with you, that although the situation is quite bleak in terms of funding and aid cuts, there is a lot that we can do with social protection, with global south innovations. And I think India is already showing that all of these are feasible and doable. And I think India is a good pathfinder for other global south countries. Thank you.
Thank you for that enlightening talk. While the other ministers publish, India is actually leading by example. Yeah?
That's correct.
So the domestic support is primarily responsible for the whole program, and in the past 7 years, I would say, it has almost gone up 10 times the kind of budget the India TB program is using. So that's something that is actually allowing us to go on to use newer technology, expanding our handheld X-rays, using AI tools to actually inform the handheld X-ray results, and we'll be able to take these handheld X-rays to periphery, village to village, camp to camp, and that is how the 2025 burden we've jumped from 26 point something lakh to 32.65 lakh cases reported in 2025, out of which 11 lakh were asymptomatic, which further, strengthens what I'm trying to say. We've enhanced ACF with these X-rays. We've increased our proportion of NAT. So earlier we were at 2024, we were at 30% NAT being offered. as a diagnostic modality. And last year we moved to more than 80%, NAT being offered. Smears we are not still throwing out because we'd like to use them for following up the patients, where our DNA NAT would not work till we come up with an mRNA NAT. So yeah, we're getting there. And like you said, leadership by the South possibly will show the way. So thank you, Dr. Madhu, and apologies for keeping you waiting.
No problem. It's a real pleasure. Thank you so much.
Yeah, thank you. And if there are any questions now on the YouTube or Zoom for sir. So like always, your your points of view, your perspective is always very wide and actually enables us to think bigger and incorporate the latest recommendations, etc., to move fast. So thank you again, and hope to have you address us again another time in the near future. Thank you and bye bye.
Thank you. Bye.
So thank you for the participants who have stayed on with us. One of the talks could not be covered because some talks took longer than they were due to take. My talk on innovation to elimination, if you permit me a quick 10 minutes, I'll rush through the talk, not really take the half an hour I had planned to take. I will quickly allude to a different perspective, which, yeah. So in a minute, I'll just open my slides and be with you. Good evening to all. The topic that I chose to deal with is from innovation to elimination. And so I always like to bring I'd like our infectious disease physicians, our fellows, our MD students to actually widen their perspective. Traditionally, what has been taught is the two ends of the spectrum, just the latent TB and active TB. What one must know is, in fact, what the previous, at least the nutrition talks alluded to, was how the immune response and how nutrition could actually help contain the disease and not, let it activate from latent TB to an active disease. So we have ignored the stages of incipient and subclinical TB and designed treatment regimens only for active TB and latent TB. That actually brings out how the intermediary stages of incipient and subclinical TB have been ignored. And what is important is, if you notice that the infection could be eliminated in a child if the immune system is active, or a child could land up with primary TB, or he could so-called get into the latent TB stage, which could go through incipient and subclinical TB stages. Now, these are all hypotheses, and more scientific evidence will help us deal with them. Here, I wanted, just to share with you that subclinical TB we may be able to catch with X-rays, but incipient TB we do not have a diagnostic modality. For LTBI, the tests that are used are suboptimal. So taking you to a different perspective, 3 longitudinal studies of TB acquisition and progression have shown that, Polson et al. Pointed out that the time of exposure to TB to a two-week period before the disease could actually break down. Another paper talked about the incubation period being from 3 to 9 months, and most of the publications refer to the breakdown within the first 2 years. Now, this is what we published, and I allude to this because what has been shown in MDR-TB, polyclonality to be a rule. This was published in 2020. We were able to show that even in drug-sensitive TB, a substantial number of patients will have a mix of genotypes. It is the limit of detection of a detection methods which may miss the different genotypes in a patient. This thereby questioning the very reactivation hypothesis. It is always reinfection is what we suggest. This brings us to the need for diagnosis, where clearly it is known that in the phase 1,
as a public health activity, we want to deal with the community spread of TB. We have to intensify our early diagnosis and offer DST to all our TB cases as the phase 1, beyond which we go on to diagnose at-risk patients and deal with latent TB infection. And something to this effect was published by our group along with Dr. Pranay and my team at the National TB Elimination Program, where we showed in 2 phases we could deal with the burden of TB in the community. Now, coming to what are the tests being suggested for detecting TB infection. This is published by our dear friend Dr. Pai, whom you just heard. And clearly the summary is that the reproducibility of egras is questionable. The sensitivity we know are questionable. This includes not only egras, but also TST and the new SCI-TB. I'll come to that. However, the sensitivities of the 3 tests here have been compared and are at par. So when somebody suggests that the QFT-GIT is way better than TST, you kindly refer to this meta-analysis published as early as 2011. The SCI-TB or the CTB test was again published and showed this was developed. This is an Indian indigenous technology now being sold world over. Again, an international study showed this to be equally good as TST and quantiferon. So what I'm actually trying to come to now, this is SCI-TB was safe. It chooses the ESAT6 and CFP10, just like the IGRA. And this is, this is a mix between a TST and an IGRA. It's an intradermal test. We're using 2 antigens. Now, coming to this slide was also used by Dr. Nivedita. What I want to allude to here is this is a slide that talks about the research on biomarkers that will probably pave the way going forward if we are not able to eliminate TB, though all our efforts are directed towards it. Now, the questions on the left are the questions that really bother me, and I'm sure these bother you in the practice of treating TB patients. How to differentiate acute TB or active TB from latent TB infection, active TB, versus household contacts, latent TB infection versus household, healthy controls or, contacts who may be healthy and not having latent TB infection. What are the markers of drug resistance other than the DST that we talk about and the NAT systems we talk about? And that is where we are focusing all our energies. We do not have these answers. These 17 things that I've listed out keep on bothering me, and we really need to look for answers to them. Markers of response to TPT. We are empirically giving TPT, but what is the benefit of giving TB preventive treatment? Are we actually dealing with the infection that the patient had? Are we able to actually deal with the MDR-TB if a patient may be, housing infection due to MDR-TB? Or we're just subjecting him to 6 months of levoflox and, lose levoflox for this patient in his treatment. Tissue-specific treatment response, can we assess that? Diagnosis of pediatric and extrapulmonary TB remain a challenge even today, despite the wonderful labs and the N number of, molecular methods we boast of. There are studies in children which can differentiate, based on genes between the response in boys and girls. How to differentiate a person who has HIV from a patient who's developed TB on top of HIV. How to diagnose asymptomatic TB? I've been saying since morning, do screen them with an X-ray. Aren't we missing a good substantial number of these? Diagnosis of smear negative cases. How to predict long-term outcome or a relapse. So we're always worried that this patient may have a relapse, especially within the first 6 months, at least within the first 2 years. How to predict post-TB lung disease. What are the markers of immune protection? We're worried about not getting a vaccine, but we must first need to know the markers of immune protection. Markers supporting, drug discovery, a very pertinent point because we go on losing so many new drugs. First, it's difficult to find them, and then we lose them to resistance. So all these questions, I must share with you quickly. The next few slides are hidden in these biomarkers. And so this is just my initial work published in 2013, where we were able to use messenger RNA as a prognostic marker
So the messenger RNA at the baseline and in the follow-up could actually tell us whether the patient is going to be responding to the treatment or he's going to get MDR. These are the genetic biomarkers, and as you can appreciate, studies have been done. Here I was referring to the difference in males and females. This study was done in Africa, where they were able to use these particular genes would actually signify active TB in males, and in females, these particular genes would help them differentiate whether the active TB was there or not. Upregulated GBP6, downregulated CLSR3, and so on and so forth. ADM remains to be a very good marker that has been found, and initial studies have shown ADM and PBMCs based on single cell RNA sequencing, as well as in whole blood, has been clearly correlated with a very high sensitivity and a reasonable specificity, though not yet touching TPP, the WHO's target product profiles. But the combination of ADM, GBP, along with one or two other of these markers have been found to be very useful. You can appreciate the studies that have been mentioned here. Coming on, so this is the summary of the single cell RNA sequencing and how adrenomodulin, I already referred to, is involved in key TB immunomodulation mechanism and is increased in active TB. GBP5 I already talked about, and the combination of GBP5 with BADF2, CD64 in the PBMC are overexpressed in active TB. Plasma cell-free RNA using these 6 genes can be a marker of active TB, while a dip in KLF2 and ZNF296 clearly goes in favor of latent TB infection. In THP cells, MTB infected THP cells, aberrant RAC1, RBX1, MRPL. So all these are, genetic markers. This was a paper, this was 2016, where they showed a 16 gene transcriptomic signature to differentiate the latent TB infection from TB. These are microRNAs, and the effect of microRNAs, you can appreciate the cascade here, and these slides will be available to you. Let me not go into the details, I'll take longer. Let me quickly come to the summary of what I was trying to. So this particular paper brought in a novel molecular macrobiological biomarker of latent TB infection with properties that are distinct from a commercial interferon gamma assay. So the detection of MTB complex DNA in the PBMC. So earlier I talked about cell-free DNA in the blood. Here I'm talking about DNA inside the PBMC. We know DNA can be used for detecting TB in several different ways, and we are using it in day to day. But when looking for it in the PBMCs, it can be very helpful. This is the TAN TB assay, which will again detect LTBI. And coming on to RNA biomarkers, this is a field less touched. The non-coding RNAs, you're all aware, the long non-coding RNAs and the circular RNAs are able to govern pathogen recognition, modulate the immune system and the disease outcome. These are tissue-specific, stable in body fluids, and are infection stage dependent, meaning you can differentiate latent from incipient, from subclinical to clinical. Again, the data is, early data is there, but several studies have shown the relevance of these markers. And the tie-up between the long non-coding RNAs and the miRNAs, the interactions between them expand their value in the immune networks field. They modulate epigenetics. Through epigenetic phenomena, they modulate the immune response. Coming on to the microRNAs, are also markers of disease. MicroRNA 29A especially has been shown also in HIV, HCV to be reduced. But in TB,
it has been shown to be, this is a COVID-19 study, tuberculosis, they are clearly enhanced, they're overexpressed. Several other microRNAs have been associated with active disease. These are also tissue-specific, discriminate active infection and latency from disease, are stable and detectable in the body. Now, this is, just a glimpse of how the genetic markers were put to use. Expert MTB HR cartridge was, HR would stand for host response. This was brought out, several papers came in, and, when we asked for it in India, we are never given this. The sensitivity of this particular cartridge, this would show progression from infection to disease. This is a host response, basically cytokine-based detection. Again, the risk-6 signature assay was developed. There have been, I've talked about the TAM-TB assay earlier. There have been other signatures which have been proven to be useful, but we are still waiting, their test form, whether, we can have them in a form that can be utilized for the sake of patient care. Now, these are few papers of the use of expert MTB HR for PL-HIV, and you can appreciate that the sensitivity and specificity was quite high. But despite that, the HR cartridge is not available to us. This is another study in PL-HIV and non-HIV patients. Now, this is briefly to bring in the protein biomarkers, which are longer way off rather. They also offer high specificity, sensitivity, enabling early screening. Few markers, a triple marker panel was very successful. Then another marker panel, we would appreciate in the table, there are marker panels including 6 protein signature, another 6 marker panel, which have been proven to be useful in different studies, differentiating latent TB infection from healthy controls, pulmonary TB versus healthy controls, and so on and so forth. This was a work in my lab where we found using urine proteomics and 2D Daesh method, we found some signature peptides, but I am still struggling to come up with a point of care detection method. I am working on it, but it is taking longer than usual. Cytokine markers, I talked about our paper, there was a glimpse of that and I've moved on. So several cytokines are clearly known to be highly specific. You can appreciate here CXCL10, overexpression CXCL9 are highly sensitive and specific in differentiating LTBI versus active TB. This can be picked up in PBMC supernatant. And coming on to other markers here, you would appreciate several studies here, and if I go into each of these, I'll take longer. This is our work again, where we showed the role of NKT and T regulatory cells. Metabolite biomarkers is another area which has seen a lot of funds go in, and a lot of wonderful studies have shown. For example, the glutamine, in Polish children, citrulline. Again, several studies have brought out the relevance of metabolite biomarkers. We published from our lab in children the metabolomics, signatures, 7 discriminatory metabolites were found, and the sensory specificity was quite good. But again, till such time this can be made into something usable. Also, exosome biomarkers have been shown to be useful. This is just a summary of whatever I just mentioned. The most significant and successful markers are included in this picture. Let me move on. Now, this is alluding to Dr. Amita's work. They have found that CRP along with IFABP and zonulin as predictors of TB progression from infection to disease. Another work by the report group, they have brought out, the cytokines, a group of which could actually help us. Now, this is the sad part. If we look at pathogen biomarkers, what I was talking during this talk was host biomarkers. This has been the progress in pathogen biomarkers over the past few years. And we look at the host biomarkers, they have not been utilized much. While, as you could appreciate, the understanding, the wonderful understanding that several research groups have brought in this, enabling us to use multiple markers for, the questions that I listed out earlier. And keeping our fingers crossed, we will be able to get there, use host biomarkers to help us answer those questions and many more that bother us while we deal with TB elimination. So thank you for the patient listening again. Any questions for me? I can take them now. That is a question. Oh, that is very wonderful. Programmatically, is it possible to provide nutritional support to all contacts of index TB cases who are getting TPT? Yes. So in fact, the previous two speakers who spoke on nutritional support and the modeling group, Dr. Pranay referred to, Dr. Nim and Dr. Sandeep Mandal, this paper is under communication, that possibly, nutrition could offer better protection than TB preventive treatment, even that study is based on modeling. What you ask is programmatically, is it possible to provide nutritional support to all contacts of index TB patients? Yes. As of 2018, the Nikshay Poshan Yojana benefit was initiated, and with time, the coverage of NPY has improved significantly. We enhanced that NPY to 1,000 rupees per month since November 2024, and again we have made a lot of effort to ensure that all patients get NPY. For the contacts, what we are trying to ensure is the Nikshay Mitra basket is given. So it's an expanded basket with food meant for the family as well, again, since November 2024. And this, again, the push is a very strong push. And thankfully, this is the program led by our Honorable Prime Minister and was launched by our Honorable President. And there has been phenomenal support from, CSR from all over, from industries, from corporates, from individuals, even from children who have adopted patients, and they are ensuring not only food support, but also emotional and other kind of support that a patient may need. So hand-holding. Our My Bharat volunteers who are youth are also coming forth in a big way and trying to support these patients, practically adopt them, in helping them resolve their queries, ensuring that they get due care. Our TB champions, our ASHA workers, our community, our civil society are ensuring this connect so that every patient can get individual attention. So yes, we'll be able to do and expand the food basket to our families of patients. Another question is, by LPA it shows mutation, but phenotypic LC-DSC exhibits susceptible. Can we consider the case as resistant, not phenotypically expressed? I would be of the contrary opinion. Phenotypic is the gold standard and remains the gold standard, while LPA, there can be errors, but phenotypic, if done as per recommendations and in the right manner, the phenotypic remains the gold standard. The LPA has multiple steps, so errors could happen during these multiple steps. So if you ask me, even whether whole genome sequencing would be the gold standard or phenotypic would be the gold standard, I would say phenotypic would be the gold standard because it actually replicates what goes on inside the body. While in the whole genome sequencing, you may pick up mutations which are not actually responsible for resistance. You heard Dr. Sebastien Gagneux, who so beautifully covered how the mutations could have an interplay. The presence of one mutation alone may not have any resistance. It may need a sister mutation or an epistatic mutation at a distant site to actually lead to resistance. So phenotypic remains the gold standard till we can prove otherwise, till our genotypic knowledge is, can deal with all the possible issues, which would take us some time. So thank you so much. Any further questions? So thank you for being a wonderful audience, and I hope the day's proceedings have informed you as to the state of art knowledge as regards
TB and whether it's the pathogenesis, the immune response, the diagnosis, screening, treatment. We have tried to bring it all in together, the role of nutrition and what massive role you actually looked at the scientific evidence, which actually gives us, encouragement that we can go on and possibly till such time that we, fingers crossed, we get the vaccine, we could work towards ensuring nutrition works as the vaccine that is already available with us. So thank you again and have a pleasant evening. Thank you and bye-bye.